dreams are made of this. Who am I to disagree? Travel the world and the seven seas. Everybody's looking for something. Sweet dreams are made of this. Who am I to disagree? Travel the world and the seven seas. Everybody's looking for something.
always reach for more than what's in my hands. 25% more than what I have. And you tell me there's more to the moment than wondering what it could be. But every time I try, it doesn't last. So I fake some love and I smile and believe it for a while. Make the best of whatever time we had. If it is what it is, maybe this is all we got. We forget that a loss is a gift that can lift you up. Sometimes the rain don't stop, but better days ain't that far. If it is what it is, maybe this is all we got. Maybe that's enough. Trying to meet the ends, but they're out of reach. Yeah, but you get me close when you're here for me. And I know that this life is unstable, but you make me wanna be grateful. Hope you know I am if it's hard to see. So I fake some love and I smile and believe it for a while. Make the best of whatever time we had. If it is what it is, maybe this is all we got. We forget that a loss is a gift that can lift you up. Sometimes the rain don't stop, but better days ain't that far. If it is what it is, maybe this is all we got. Maybe that's enough. Maybe that's enough.
Keep me company in the night. That's all I need, all I want is for you to stay a little longer now, with arms around me like a border, like the air I breathe. I'll let you in, keep me warm underneath my skin, 'cause I'm giving in to your touch. I can never get enough, diving deep into your ocean. You can be my safety zone. Somewhere I can go and feel alone. That's all I need, all I want is to stay a little longer now. Arms around me like a border, like an endless stream. You take me in to a place that I've never been.
Ladies and gentlemen, a very warm welcome to this, the second day of the Renal Conference. We trust you all had a lovely rest after last night's party and opening. Today's program consists of two sections before tea time. Firstly, patient safety, and then the second part will be technical innovations in nephrology. However, before we get to the program, we've got a few housekeeping rules which I'd like to bring to your attention. Firstly, please mute your cell phones. Secondly, the Renal Care Society e-poster presentations will take place in Jabula, right here, during the lunch break. The plenary lecture on organ trafficking, which is an ethics lecture by Prof. Thomas Mueller, will be right here in this venue after tea at 10:40. And then there are also two lunch symposia today, which I'd like to bring to your attention. Firstly, the Boehringer Ingelheim Lunch Symposium, From Filtration to Function, The Future of Chronic Kidney Health by Prof. Nicola Wern, and that'll take place in the auditorium. Secondly, the Adcock Ingram Lunch Symposium, The Future of CRRT is here, unveiling an introduction to Prismax, and that will take place in lecture room number 8. And then I'd also like to request, with question and answer time after each presentation, please don't knock on the microphones. And then a kind reminder to all of you that the Renal Care Society AGM will be taking place this evening at 5 o'clock, right here in this venue. And I'd like to encourage all Renal Care Society members to please be present for that. Thank you for that. And then without any further ado, it's my privilege this morning to introduce our first speaker to you. It's Mrs. Isel Loots. Oh, who am I? I'm Sonia. Good morning. Thank you. I'll be introducing Isel Loots to you, and she'll be speaking this morning on the standards and regulations in the healthcare sector, the OHSC. Now, Isel Loots is the Director of Standards Development and Training at the Office of Health Standards Compliance, and she holds a master's degree in health studies, amongst various other qualifications too. Isel is a recipient of many prestigious awards, the most recent being the Top 50 Nurse Heroes in South Africa, which was awarded last year. Congratulations, Isel, and we really look forward to your presentation. Thank you very much for making the time.
Good morning, ladies and gentlemen, and thank you so much for having me on this Saturday morning. Now, who would like to listen to regulations on a Saturday morning at 8 o'clock? Not me. So I'm going to make it as palatable as possible. But I want to bring you greetings from the Office of Health Standards Compliance. And maybe I must just say this before we start. We are not the NHI. We are the health regulator of South Africa. But today I want to also show you how we are linked to the NHI, if you don't mind. And maybe just before I start with the presentation, I just want to say that we have worked with the DOH already 2 years ago to start with the norms and standards for renal care. So we are not currently working on those tools. At this stage, at the office, we have tools for all public sector hospitals, private hospitals. We are finalizing for GP practices, and we are also busy with ambulance services. And soon, we will start with the mental health facilities in South Africa. So it takes about 2 years to develop a standard, and we must prioritize as we move along. And this is where we are. But, oops-a-daisy, we're going to look at the mandate of the OHSC. We're going to look at the functions of the OHSC, the powers and implications, because many of us are sitting in practices and we want to know what will be the implications. If I do not have an inspection tool as yet, what do I do? Now, also the desired regulatory outcomes and the impact that we want to see in the system, in the healthcare system. And then also I want to show you what the OHSC and NHI link is. Now, the mandate of the OHSC, maybe just to start by saying that we were established under the National Health Act. You will see also in the NHI Act we are mentioned because we are the only health regulator in South Africa. There are quality assurance bodies, but it's not the one that is established under the National Health Act. We also work under regulated norms and standards, and this is what we build the inspection tools on, and then also procedural regulations on the functioning of the OHSC. The norms and standards were promulgated in February 2018, and it came into effect in 2019, and it was from there where we started developing these inspection tools. Now, one of the things that I want to tell you, regulations and norms and standards sometimes feel like a prison door. Have you ever experienced that? Yeah, I must do this, and I must do this, and I must do this, and it sometimes suffocates us. But we must think about it like a safety door, because we want standardized practices for our users in our facilities and our healthcare. So it's not a prison door, but a safety door. Now, if you look at the promulgated norms and standards, so often our healthcare providers will ask us, there's no inspection tool for us, so we will be fine until you come in and inspect us. And we say no. The norms and standards are promulgated, and we have to follow that, whether there's an inspection tool or not. Now, if we look at norms and standards, there's a chapter 1 that speaks about definitions, the scope, and the purpose of the regulations. But we are looking at chapters 2 to 6 when we look at developing inspection tools for a facility. There's 5 critical areas, and then also there's general provisions in chapter 7. It doesn't really relate to the clinical environment. But let's focus on the chapter 2 that we spoke about. It's things that you know, colleagues. It's not things that's unfamiliar to you. User information speaks about the services. It speaks about the complaints, process, cost, so that when a user enters your facility, that they know what is the expected cost of the services that's being rendered to them. The user experience, we look at user experience, and we actually ask that it's being displayed in the facility. And then visiting hours. But I made this in blue because if you do not have a hospital, then visiting hours doesn't pertain to you, all right? Access to care, we are speaking about triage of users. It's about our frail users and critically sick users, and also the referrals. And that speaks to our access to care. Health records. What system you use is very important. It can either be electronic or it can be a manual system. But the confidentiality is very important, and also the biographical data that's documented and the documentation. Also is important is consent. Informed consent has been a non-negotiable measure on our inspection tools. Now, a non-negotiable measure means if you do not comply to that measure, you will be marked as non-compliant and you will not get a certificate from the Office of Health Standards. We also look at clinical management system, the clinical policies, clinical risk management systems, and I don't know if you are aware, we are going to review the norms and standards very soon. And one of the things that we want to bring in is clinical outcomes, so quality indicators. It's always linked to clinical pathways, but we don't always only want to look at inputs and processes in the health system. We want to see if a patient is admitted in this hospital, public or private hospital, what is the clinical outcomes of this patient? And we're going to measure that through many, many indicators, length of stay, readmission rates, and so forth. Infection prevention control is also very important. Hand washing, isolation, linen, protective equipment, and prophylactic immunizations. One of the things that we will embark on is antimicrobial stewardship, because it is not, there's something in the tools, but there's not a lot of that in our tools. Waste management and the containers available. And then we also look at medicine supplies, diagnostic services, blood services, and the medical equipment in a facility. Now, let me just continue on the buildings, engineering services, transport, which will not pertain to your practices if you're not in a hospital setting, and then security for safekeeping of your users, visitors, and also the healthcare providers. Then chapter 6, governance and human resources. Even if you are in a practice, this is something that we look at, colleagues. Your human resource management and also your occupational health and safety. And we have to comply to these things. We also have an early warning system, a reporting system with 11 indicators at the office. When one of those indicators are breached, it must be reported to the Office of Health Standards Compliance. And it's so important that we look at what is in the prescribed norms and standards, because if we follow these things, there shouldn't be breaches in your norms and standards. Or if there is, we can also see how you actually identify gaps in your facility and address those through a QIP. Then we spoke about general provisions, and that is the waiting times or adverse events, and we actually put that in every domain. Adverse event is very important, the way that we manage that, report on that, and keep a register of it. If we look at the mandate of the OHSC, it's really to protect our healthcare users through quality and through safety in the healthcare environment. And we also we investigate, you know that the Ombud is also placed within the Office of Health Standards, and we investigate complaints and we dispose of that complaints. So it's not only inspections, but also investigations that we do. Now, the functions of the OHSC, we advise the minister, and maybe you will find this interesting. We are writing a recommendations report at this stage, and we are looking at the inspection annual report of 2022-2023. And what we found was 3 very critical areas where non-compliance has surfaced. And you will find it interesting to know that your HR plan in facilities is a problem. Governance in facilities is a problem. So non-negotiable vitals or non-negotiable measures is a problem. So in our inspection tools, non-negotiable measures will be something like oxygen availability, a generator when there's no electricity, and also emergency trolley. And every aspect on that trolley, whether it is a ET tube, whether there's a missing airway, you will be marked non-compliant as a facility. So those are the things that we advise the minister of. We inspect and certify health establishments, hundreds of them. You know that we have about 4,000 facilities in the public sector, 460 in the private sector. The ambulances is also about 400, and we are looking between 10,000 and 15,000 GPs in this country, and those have to be inspected and certified by the Office of Health Standards Compliance. And then, as I said, when we write that advice to the minister, we make recommendations to them about what should happen. We publish the information. And then, as you know, we recommend as a quality assurer and not as a quality improvement body. I'm very aware of the time ticking here in front, so if you don't mind, I'm just going to skip a few slides because I want to get to the crux of the matter. Let me just say this, that we've spoken about how important it is to get certified by the OHSC, and what the functions are of the OHSC, but the powers of the OHSC is this, that we can certify a health establishment, but we can also revoke certification if there's a breach in norms and standards. So sometimes it happened that we would inspect a facility, we would certify that facility, and the certification, we will explain to you how that linked to the NHI, but we will certify that facility, and then there's a breach in norms and standards. Through our early warning system, we then trigger a risk-based inspection. We go there and we go and see what's the problem. Remember, when we inspect, we look at processes and systems. We don't look at one thing. We triangulate data so that we make sure that we have a clear picture of what is happening in that facility. But sometimes you do get a bit of stage performance. If they know we're coming next week, all of a sudden the evacuation plans appear. Wrong or right? Yes, I'm right. So, but what happens is we sometimes certify. We do have the evidence, but then there's a breach in norms and standards. And the Office of Health Standards can revoke that certificate, and we do that. So we recommend, we enforce, we certify, but in that event, we will then revoke. Okay, so what behavior do we seek? We want to promote and recognize. It must be a user-focused, patient-centered, a proactive problem-solving system where people are held accountable for their actions. We do not regulate professionals. We regulate health establishments where professional works. Okay, so sometimes when we get in and we see that there's practices that doesn't look right, we report it to the HPCSA, or we report it to the South African Nursing Council, or whichever body, SAPRA, and so forth. We discourage ad hoc and actions, activities, and we also discourage abuse of power, negligence, and that it's not my fault. We do not accept those kinds of activities. And the mandate of the OHSC is reduction in avoidable mortality and morbidity rates. And we want to improve the availability and responsiveness and acceptability of the health establishments. We believe that will enhance our services. Now, the link to the of the OHSC to the NHI. We know that the NHI is a fund, and they will pay healthcare providers from the fund, whether you're a private sector facility or a public sector facility. You will be paid from this fund. But to participate in the fund, you must be accredited with the fund. And the only way you can be accredited with the fund is you must apply for accreditation. And the only way you can apply for the accreditation is if you stand with your certification of the OHSC. So whether the NHI is there or not, the OHSC will be here. However, for you to participate as a service provider in public and private, you will need a certificate from the OHSC. I want to encourage you to go to our website, OHSC, and go to publications. You will see that all our tools are loaded there. And all the measures under each of these norms and standards, let's say record keeping, is there, okay? Go and have a look at what are the requirements. So often I get a phone call from a day hospital and say, we want to start preparing ourselves. What do we do? There's no inspection tool. I encourage them to go to the website. And sometimes they phone me and I say, look at this functional area. Functional areas like a ward, the medical ward, or a HR, or maintenance, and I guide them. You're so welcome to reach out to us. It's important that users, healthcare providers can reach the OHSC. It should be a distant organization that you cannot touch. Please reach out to us. We want to help you. It's an open book test. You can take that inspection tool and you can prepare yourself, identify your gaps, draw up a quality improvement plan, and address the gaps in your facility. It's as easy as that. But it has to be a team approach. We all have to work together so that we can get our mortality down, our morbidity down, and that in the end, our patient experience will be addressed, and that the clinical outcomes of our patient is addressed. Remember, colleagues, we do what we do, not for ourselves, but for a patient in a bed, a vulnerable person. And if we improve quality and safety, we address the needs of that very precious life in front of us. So I've explained how we link to NHI, because if we get on a stand, that's the first question that we get. So we said that we are the gateway for the accreditation process, but let us do not focus only on the accreditation and certification and where I am. Let's focus on how can I improve my services. And if I can say this, One inspection tool have about 1,000 measures that you have to comply with, literally, if you're a big academic hospital. But we do not comply if we grab the tool and within a week we fix everything and we identify gaps. You have to go slow to go fast. So I want to encourage you, take the tool and take the first measure and get it in place. And if you want to do it the right way, we always look at non-negotiable measures first. And we say, let's address this because a non-negotiable measure, like oxygen or an emergency trolley, can have a detrimental effect on my patient if that is not in place. And then you take the next measure and you say, how do I apply it if I am a technologist and I have my own practice? What do I do with this measure to be compliant? Excuse me, to be compliant in this specific area. I thank you.
Good morning. Unfortunately, I didn't hear the good morning, so I'm going to repeat it again. Good morning, colleagues and friends. Thank you very much. I'm David Mputi, and I'm going to be introducing our second speaker. Before I do that, I would like to remind members about the discovery to go and check for your health status, as well as the available check-ins for the GFR and your own creatinine. Because some of us might be sitting here talking about renal failure, and yet we have got only one kidney functioning, but I'm not scaring you. Colleagues, the next speaker that is going to be talking here, unfortunately, the surname is too difficult. I'll leave it for the speaker to come and introduce the surname for themselves. He is a chair of the Department of the Medicine of John D. Dingell Veterans Affairs Medical Center and the vice chair of the Department of Medicine at the Wayne State University School of Medicine, Detroit, Michigan, USA. Prof is currently chairing the core programs committee and has previously led the International Nephrology Committee, the education work group, as well as the founder editor of the ISN Academy. He has organized several symposiums and also has had a lot of recognition, of which the latest was the ASN's Nephrologist Transforming Dialysis Safety Initiative as international expert for the standards outcomes research in nephrology. When it comes to the awards, in 2023, he got the Guru Dronacharya Award Foundation. He is well published. Colleagues, please join me in welcoming Prof. Tushar Vaishnarajan. I hope I didn't butcher your...
Thank you. Good morning, everyone. And this is a great honor. Thank you for your very kind words. It's been a pleasure. Thank you to the organization for inviting me here. I missed coming here 2 years ago. Finally, I made it here. So I'm glad I'm here, enjoying this resort. And some of that enjoyment this morning led to my delay in getting my slides up here. I was enjoying the birds out there. But hey, anyway, I'm here. And let's start on this patient safety in dialysis unit. So it's nice to follow up on the OHSC guidelines and the standards. And the way I often look at this is, it's simple, but it's complex to implement. It's a complex process to implement. And oftentimes it gets so dry and so disconnected from what we are supposed to do clinically that I thought I would tone my talk down, and in the next 15, 20 minutes, I will try to bring in some real-life scenarios where we can all relate to what exactly we are supposed to do. I mean, we all want the best for our patients. We all want that our patients should be safe, but at the same time, we also want to be sure that we are doing it the right way. So the learning objectives for today list common errors that occur in the dialysis unit. Yes, when we look at the standards, we look at it from a large facility standpoint, but when we have to narrow it down to what exactly do we need to do in a dialysis unit and how each team member can help in providing the best possible care to our patients, I think that's equally important to understand. So we describe steps to prevent these common errors. So we need to understand what these common errors occur in the dialysis unit, and then discuss elements of a comprehensive approach to safety and its impact on improving patient care. So let's talk about this. I mean, I'm sure everyone has heard this term HRO and high reliability organization and patient safety. I mean, these are buzzwords. I mean, these are thrown all over. And what exactly do we mean by that? And in the late 90s, one of the publications defined it as all workers share a sense of responsibility and accountability for safety and reliability. They anticipate, detect early, and respond to unsafe conditions before the adverse event occurs. So that's exactly what we really mean by an HRO or a safe environment. We want an environment where not only the patients are safe, but also the team members, they feel that there is a just culture, you see something, you say something without worrying about reprisal, without worrying about punishments. And I think that's what HRO means. It's not just for patient safety, but it's also for all the employees and the staff members and the team that take care of the patients. So what errors are we talking about in a dialysis unit? So in a dialysis unit, yes, lots of things happen. It's a complex place where procedure happens. There are patients coming in and out, multiple shifts, multiple things happening. Patients go into hypotension, they cramp, and there's always some activity that's ongoing. And on top of that, there are medications that are administered. Patients are at a risk of fall, so tons of things happening, tons of things can go wrong, and everyone has to be cognizant of these errors. We are all humans, nobody is perfect, so errors are bound to happen. And so this study, even though it's old, it really highlights the common errors, and if you see the first 3 or 4, medication error, that's the commonest. Failure to follow protocols. Again, it's important to have standard protocols to prevent these errors. And then multiple other things, as you can read through the list. One very relevant for a dialysis unit is when we access the fistula or the vascular access. I mean, needle infiltrations, disconnection of the needles. I mean, these are catastrophic events, and that can really cause harm to the patient. So these are very specific to the dialysis unit, so we have to be mindful of these errors that can happen, and how do we prevent these errors, and how do we keep our patients safe so that they feel comfortable coming back to the dialysis unit for their treatment. So let me go over some of the clinical scenarios here, and this will kind of hone in as to what we really mean when it comes to patient safety. This could be in an acute dialysis unit in a hospital setting. This could be in a chronic dialysis unit. I'm not very familiar here, but outpatient satellite units, if you have those units, then again, these events can happen in any of the dialysis units. So here a patient presents to the facility. He's admitted for bowel obstruction. He undergoes a surgery. He has end-stage kidney disease that requires dialysis. Before getting started, the patient was alert, talking, and oriented. And the machine alarms. The staff notices that the dialysate jug is empty, so they change the dialysate. But then 3 minutes later, when the nurse enters back into the room or gets close to evaluate the patient, he's in agonal respiration, he's pale and hypotensive, and the dialysis access line was found to be disconnected. So again, this is clearly a preventable situation. The patient was in a pool of blood and the code had to be called. Patient with chronic hypotension, missing medications, again, because of the dialysis timeline and delays in the dialysis unit, sometimes these things happen. So a patient who's hypotensive chronically requires midodrine for maintaining his blood pressure. On that particular day, the dialysis gets prolonged, and somehow the patient misses the 9 p.m. dose of midodrine. Next day, the patient was to be discharged. Went for a chest X-ray before discharge for some reason, and he became more hypotensive, fell down in radiology, and a code had to be called in. Why did this happen? Because the previous night's dose of midodrine was missed. Again, this can happen. A very common scenario: heparin is used for dialysis. Heparin comes in different concentration bottles, so you've got to be aware of what concentration is available in your unit. Heparin dose, heparin allergy has to be checked before the patient gets on to dialysis. Here in case number 1, patient received heparin despite having allergy documented in the chart. So making sure these things are checked before a patient goes on to dialysis is important, and that's patient safety. Patient is supposed to receive 400 units per hour of heparin. Instead, the patient receives 5,000 units. So now, again, generally nothing may happen, but you never know. Extra heparin can cause bleeding. Patient may have hematomas. Patient can get intracerebral bleed, and you never know what all GI bleed. So again, being mindful of what medication dose is being used is equally important. Another scenario, changing the dialysate jugs. If you don't have a central supply, dialysate jugs come in different concentration. Here the patient was supposed to be receiving a 2K, 2 calcium bath jug. Instead, the patient received 3 potassium, 2.5 calcium jug. So again, somebody who's hyperkalemic, if he's receiving dialysis with a higher calcium dialysate bath, can run into major trouble. How many of you have seen this happen, where a patient comes from radiology after placement of a catheter, and for some reason they forgot to put a cap on the catheter? So again, these are totally preventable situations. Second scenario, when checking the vital signs, patient's needles were hooked up arterial needle was hooked up to the venous tube, venous needle was hooked up to the arterial tube. Has anyone seen this? So this can happen with a graft very commonly, may not happen with a fistula. So if you have grafts in your unit, then reverse connection is possible. And here, what is important is the person who's needling the access, is that person aware of what is the anatomy? How is the flow? Do they know how to assess the direction of the flow? It's a simple physical exam, but unless the person is trained and educated, these mistakes can happen. So where does this lead to? So what this leads to is errors happen, and errors happen because we are human, and errors happen based on what the process is. So if the process is faulty, the outcome can be faulty. And if you want to change the outcome, you really need to change the process. And that's how we try to implement and bring in patient safety rules in any kind of treatment protocols that we create. Safe design principles must be applied not only for clinical work, but it also helps in building teamwork. We already heard about how teamwork is important, and a culture of safety helps improve teamwork, it helps improve communication, it improves the morale of the team. And if the morale is good, if the team works cohesively, they are less likely to move away, they're likely to stay in their job, they enjoy the company of their team members, and so it in turn relates to better care for the patient. Everyone is tuned in to providing better care to the patients. And then the teams make wise decisions when there is diverse and independent input. So different team members may have different opinion, and when those opinions are put together, you may have a solution that can then be implemented that everybody is agreeable to implement. And so when we talk of system level factors, I mean, we heard about system level factors. So system level, what do we exactly mean by system level? And it's system here as an example, we want it to be patient-centered, we want it to be patient and family-centered, but there is an interaction with each member of the team, and that's how the system is created. So now, as an example here, we have the individual staff member who directly deals with the patient. So the technologist who's cannulating the access, that person is directly interacting with the patient, but that technologist is also interacting with the other team members in the dialysis unit. They're interacting with the other nurses, they're interacting with the nurse manager, and so if one of the technologists finds a challenge with access cannulation, what options does that person have? Is there another expert cannulator? Are they comfortable in approaching a cannulator who's more experienced to ask for help and get the access cannulated without trying to attempt multiple times and causing a big hematoma for the patient? At the same time, so that team is now working in an environment where are the resources adequately available? Is the dialysis unit equipped with hand sanitizers at several places, or the technologist has to walk across the hall to get to the sanitizer? I mean, these are simple solutions. You talk about maintaining hand hygiene, but if the sanitizer is not available close enough at each dialysis station, then how do we implement it? And if you notice that should be brought to the attention to the administrators. That's how the administrators come into the picture. And so eventually, that team then depends on regulators, which we have regulator organizations that really bring in all the elements together and put it down as requirement and certification. So again, it starts off at the grassroots level, but it can reach all the way up to the organization. So you really have to build in a team and build in a system. And at each level, whatever is the deficit, whatever is the gap, we need to identify those gaps, work towards improving those gaps. And so, like I said earlier, people are not perfect. We can make mistakes. And medicine, even though it's an art, it should be looked at as more, at least the safety part should be looked at as science, where we need to identify the gaps. We need to collect data on what are those missing elements, and then put that data, analyze the data, and then find out what the potential solutions could be to improve the working conditions in the dialysis unit. And essentially what we are trying to do is improve the system. So as mentioned earlier, the system, if it's defective, will lead to a defective outcome. You want to improve the outcome, you have to work towards improving the system. And if you can see through these picture images there, things that can go wrong in a very simple situation. There is a pool of water, somebody has kept a warning sign, but again, with the shift change, maybe the housekeeping person didn't realize it, picked up the sign, walked away. There's a patient who comes next to that puddle, steps onto that water puddle, slips and falls. So again, the problem here is the cleaning staff well educated enough, trained enough that, yes, they're supposed to pick up the signs, but are they also not supposed to look up whether the water puddle has cleaned up, is the floor dry, before they pick up the signs? So simple things, and this can be easily corrected by giving proper instructions, having protocols. When do you pick up the signs? When do you leave the sign on? So on and so forth. So to have safe design, what we really need to have is standardize, and standardize in the form of checklists. Again, going back to the example of cannulating the dialysis access, we need to have a checklist. When the patient walks in, train the patient to wash their hand before they sit in the chair. Once the patient is in the chair and you're ready to cannulate, clean it with chlorhexidine, alcohol, whatever is your protocol, and whatever other resources available in your dialysis unit. Are the dialysis technicians well trained enough to identify whether the fistula is functioning enough and ready to be cannulated? Or are there signs where something else needs to be done before even you attempt cannulation? So these protocols have to be in place. And then once these protocols are in place, tracking data, how often the fistula gets punctured or infiltrated, how often there is hematoma formation. Is it related to just one particular technologist, or is it fairly common in the unit? So these are data that are tracked. Audits can be done. Again, is the arm cleaned every time the cannulation is attempted? Somebody needs to monitor and make sure, have random audits to see, okay, yes, everybody claims that the arms are cleaned. Is that really happening in the dialysis unit? And once you start auditing, you will see, I mean, simple things, hand hygiene doesn't happen in the ICU. Not every time the person goes in and comes out of the ICU room that every member who walks into that room should be cleaning their hands with alcohol before they enter the room and after they come out of the room. And those hand hygiene monitors, who are the secret monitors in the hospital, they keep track of these things. Similar things should happen in a dialysis unit too. And then once you have the data, once you figure out that, okay, this piece is missing, how can we fix it? What do we need to fix it? And so those are the steps that can be implemented to narrow or fix those gaps and improve the processes. As I already mentioned, audit tools, I'm running short of time, so audit tools definitely help in keeping track of data and doing it in a scientific manner, identifying gaps and trying to fix those gaps. And finally, engaging team members using 4 E's, which is engage, educate, execute, and evaluate. So every team member really needs to be involved in this. Again, since I'm running out of time, let me just skip through this. What we need to build is strong teams. Strong teams build effective group processes, build stronger teams. And communication here is the real big key. At handoff times, communicating well with your team members, making sure that they understand that the right drug has been given, or if the nurses are changing over, they use the generic name. So erythropoietin, darbepoetin, different drugs may be stored, so patient might receive 2 different kinds of drugs for the same reason. And so a good communication and maintaining that good communication is important. So with all of that jargon, if I may call it, let's come down to what really needs to happen in a dialysis unit. Clinical examples again. So a patient care technician removes the gloves because he or she cannot feel the access, but then forgets to use alcohol again. So if there are monitors, if there are auditors, and these things are tracked, certainly we can try to improve and minimize the risk of infection. Routine catheters are used in the dialysis unit because the staff is not comfortable cannulating fistulas. So the problem here is education. We need to educate the staff members. Alcohol-based drugs, we already talked about it. is it easily, freely available in the dialysis unit? Needle infiltration protocol, have a protocol. How do we clean the arm? How do we cannulate? Do we put a tourniquet for all fistulas or not? I mean, that could be an audit tool. How do we fix the needle? Do we use a butterfly tape so that the needle doesn't slip out and you don't run into situations where there is accidental needle withdrawal? So these can be protocols, and then you can have a checklist based on this protocol to ensure that while you're training the person, are these steps followed, and then audit those steps and make sure that these safety protocols are monitored. And ultimately, what you really want is a quality assessment and process improvement meetings. We have monthly meetings within the team where each team member is free to voice their opinion, voice their concerns without any reprisal. And again, informing the senior leaders and involving the senior leaders into these discussions really helps improve and maintain. So this is a process. It's an ongoing process. It cannot happen overnight. So the take-home points here: failures, clinical or operational events do happen, and once they happen, you want to identify them, and you really want to avoid repeating those same mistakes. Tools help teams, so audit tools, training tools, checklists, they help teams to identify and work towards improving these defects. And identifying opportunities to improve teamwork and communication helps with reviewing barriers and overall improving the process. And ultimately, this is an ongoing process, so it's a slow process, and you keep learning and you keep improving. Thank you very much for your attention.
Thank you very much, Prof. Tushar. That was an informative session. I'd now like to introduce our next speaker, Tamara Naidu, who will be speaking on the infection prevention in hemodialysis patients, a comparative analysis of heparin and trisodium citrate, 30%, as catheter locking solutions at Albert Nkosi Hemodialysis Unit. Tamara, are you here? You are. Wonderful. So Tamara is from the Durban University of Technology and Nkosi Albert Luthuli Hospital in Durban, South Africa. Welcome, Tamara, and we look forward to your presentation. Thank you.
So, when you think back to your career as a health professional in the renal field, how many times have you encountered patients with catheter infections? Was it not hurtful to see them suffering through this problem and feeling helpless? Well, a solution to this problem has emerged, all pun intended. Good morning to all. Today, I will be presenting on my research, supervised by Dr. S.C. Benjamin and Reena Naidu, titled Infection Prevention in Hemodialysis Patients, a comparative analysis of heparin and trisodium citrate, 30%, as catheter locking solutions. In hemodialysis, catheters are considered the first choice access. However, research concurs that this access is prone to infections and thrombosis, thereby leading to reduced efficacy of dialysis, especially when incorrectly maintained. So, why is this important? Well, if we take a look at Figure 1, it is evident that the majority of countries around the world use catheters, be it temporary or permanent. Therefore, if these were to be locked in adequately, the effect would be greater than just locally. So the catheter locking solutions that we are speaking about today and that my study has focused on is the heparin 5000 IU as well as TSC 30%. So in terms of our product descriptions, heparin, I'm sure most of us are used to this glass vial, which we have to connect a needle to the syringe, insert it into the vial and pull out as much as we need, and then we need to discard the needle. But when we look at our TSC 30%, they have pre-fill syringes, which come in twos. So this is for each port, and also comes with a removable cap. They are also available in different dosages, also heparin as well. And then the mechanism of action. So heparin works by inactivating factor 10A and then inhibiting the change from prothrombin to thrombin. But with our TSC 30%, this works by chelating ionized calcium within the blood and then blocking the calcium-dependent components in the coagulation system. So additional properties, we have heparin is only an antithrombotic. It only has antithrombotic properties. But with our TSC, you find antithrombotic and added antimicrobial properties. And then looking at cost analysis, which I will explain a bit later, so heparin was 69 Rand 63 cents per unit, and then TSC found to be 31 Rand per unit. So the review of literature. Once dialysis is prescribed, catheters are used while patients await permanent vascular accesses. 44.1% of the dialysis population in South African public healthcare institutions use catheters. 80% of patients awaiting accesses have catheters, and therefore it's important to establish preventative measures for dysfunctions and infections. Heparin had been the preferred choice due to its diluted versions being available and these versions being cheaper, and also having an advantageous side effects profile, until an upsurge in the use of TSC was seen in both developed and developing countries. However, there has been disparity between results. And additionally, in South Africa, no comparative studies or studies focusing on the effects of dialysis adequacy have been pursued. So, by researching within this context, one may be able to implement more effective solutions to curb the spread of catheter-related infections and acquired nosocomial infections, which are, as we all know, immense burdens within South African public healthcare institutions. Financially burdened institutions may also benefit from TSC as it presents as a more cost-effective solution. Supported by the lack of research regarding TSC 30%, both internationally and locally, the aim of the study was to determine the effectiveness of TSC 30% and heparin in hemodialysis catheters in catheter-related infections. So to successfully achieve this aim, we looked at the following objectives: the assessment of age, gender, race, comorbidity, insertion sites, and catheter types of the sample population. We looked at the comparison of prevalence of infection, an evaluation of the dialysis adequacy, and a comparison of the effect on the patency of the catheters. The research design and methodology. A positivist paradigm was used. It was a quantitative, retrospective, and longitudinal study using blood results from 2018 to 2022. Purposive sampling was also used in the sample of 373. The study was carried out at the nephrology unit in Nkosi Albert Luthuli Central Hospital, situated in the eThekwini municipality. Laboratory results were collected on an Excel spreadsheet and analyzed when patients were on heparin, and then this was compared to when they were switched to TSC 30%. An assessment of the age, gender, race, comorbidities, catheter types, and insertion sites of the sample was done. Secondly, using white blood cell count and C-reactive protein, the study compared the prevalence of infection. The comparison between hematocrit levels and platelet count was also investigated to determine any interruption in patency of the catheters. And lastly, using KT/V and urea reduction ratios, the study evaluated the impact on dialysis adequacy. Frequency, mean, and percentage were the descriptive statistics used, and the t-test was the chosen inferential statistics. The target population included those who had pre-existing or new catheters and had been on dialysis for 2 years or more. The patients involved had to be adults older than 18 years. Ethical considerations. Shredding after 5 years of its possession will occur to all raw data collected. Any data available electronically has been allowed limited access to. Anonymity and confidentiality were upheld by ensuring patients' records were given study numbers and limited access to. Ethical approval has been obtained from the stated boards on the slide. The results. In terms of the demographics, the majority was found to be of the African race, males aged 43 years with a subclavian-placed permanent catheter. They mainly presented with multiple comorbidities such as hypertension and diabetes concurrently. So looking at graph 1, we can see that majority of the sample was 62%, which was the African race. When comparing infection rates, white blood cell count was found to be higher in TSC 30% than in heparin, although this difference was statistically insignificant as we found a p-value to be 0.141. When the CRP was analyzed, however, TSC 30% in this case was lower than that of heparin, with a p-value of 0.016, making it statistically significant. When analyzing dialysis adequacy, KT/V was higher in heparin than in TSC 30%, as seen in graph 3. But the p-value was found to be 0.375. The URR, however, was lower in heparin than in TSC 30%, and this p-value was found to be 0.007. Catheter patency. So when comparing the effects on this, it was found that platelet count was higher in the use of TSC 30% as compared to heparin, as seen in graph 4, but the p-value was 0.491. And in terms of the hematocrit, TSC 30% was found to be higher. However, this p-value was 0.306. Discussion. So in terms of the demographics, the reasoning behind this is that the majority of our sample that we found has lack of access to healthcare. They are economically challenged and seemingly also reluctant to seek help. In terms of our results of CRP, this can be explained because it is secreted by the liver, and this is in response to inflammatory cytokines. So the levels of the CRP increase rapidly in response to trauma, inflammation, infection, but also decrease rapidly with the resolution of this condition. There's no relationship that exists between the CRP level and age or gender, thereby increasing its significance as an infection marker. An elevated CRP level was also influenced by poor adequacy in terms of dialysis dosages and lower KT/V values and URR values in the chronic hemodialysis patients. With regards to the URR values, heparin is widely used as an anticoagulant in the blood circuits. However, in this case, the advantage may have existed minimally, when it was used as a lock solution, thereby resulting in compromised flows from the catheter, where a reduced blood pump speed had to be used, compromising the adequacy of the sessions. However, TSC, as I mentioned, works by chelating calcium ions in the blood, thereby could ensure that after each session, when the catheter was locked, they may have a lower risk of clotting until the next session. This ensures the catheter flows remain patent to achieve high blood pump speeds for adequate sessions of hemodialysis. In terms of our platelet and hematocrit results, it may have been influenced by the event of thrombosis occurring more often after subclavian catheters are placed, as this was the majority type shown in our sample. Additionally, a cost analysis was done. So for 1 unit of heparin, this would have cost 69 Rand 63 per vial. So it would therefore cost 25,972 for 373 patients, which was our sample size. And thinking about putting that into context, each patient would have been locked, let's say for an average of, they're coming 3 times a week, so they would have been locked after each session. This would have amounted to about 835 Rand per patient. In terms of TSC 30%, this cost 31 Rand per unit. So if we had to calculate for our sample size, this would have equaled to about 11,565. And if those patients also attended dialysis 3 times a week and they had to be locked after every session, the amount would be 11,565 for those 3 patients. So per patient, it would have amounted to 372 Rand. So consequently, we found that heparin was 2.25 times more costlier than TSC 30%. The cost of treating complications of catheters or even the removal of a catheter amounts to much higher. It totaled an average of 23,000 Rand per catheter complication. And in some cases, catheters needed to be changed more than once a year. So, in conclusion, the TSC 30% solution has been found to be a beneficial alternative to heparin in catheters based on the results from our study. Using these results and that of other studies, policymakers should consider introducing guidelines on a superior solution for hemodialysis catheters, such as TSC 30%. Guidelines would be based on feasibility, availability, and additional properties that prove advantageous to the healthcare facilities, professionals, and most importantly, the patients. In a resource-constrained country such as South Africa, this may be a benefit to our public healthcare facilities. I would like to give acknowledgement to my co-investigator, K. Madhav, my supervisors, Dr. S.C. Benjamin and Reena Naidu, Mr. D. Naidu, Prof. Sunga, Dr. Hari Prasad, and all the staff at the renal unit, as well as my sponsorship from First Medical Company. Thank you so much.
Thank you very much, Ms. Naidu. She was trying to run away from me, and I told her not so fast. I can be faster than her because I'm on my running shoes and she's on her high heels. Therefore, she can't run faster than me. Colleagues, you are reminded to go and check your health status with Discovery. And again, the GFR and the creatinine. We know that the healthcare workers are very scared to know about their conditions, and yet we are the ones that are caring for the patients. Therefore, we're caring for the carers today. The next speaker is PhD candidate, and the study is focusing on patient safety and staff safety. The person has won several awards, and the latest was the one in 2022 from the Renal Care Society of South Africa, and is currently the nephrology lecturer at one of the universities. Ladies and gentlemen, please join me in welcoming Mr. Sianda Alex Ngema.
Good morning, colleagues. How is everyone doing this morning? Thank you very much, Chair. First, I would like to have a raise of hand. Anyone who drives a manual car in the house? A manual transition car? Quite a few. All right. Can anyone of those raise your hand if when you were driving this morning or yesterday, you pulled a handbrake when you were at the stop sign? Only a few, 100%. This is going to take us then to my presentation. You'd realize later why I'm asking this very important question, because I think as human beings, we tend to forget things. I always say if we all had to be taken back to the driving school, we'll probably fail if we had to go through that test. And the probability is most people bribed when they were driving, hey? As having been said, we can see there from the pictures how typically a dialysis ward would look like, a hemodialysis ward in particular. I'm sure this one looks very clean, as you can see from the pictures, but without a proper test, we cannot really say it's clean. When it comes to the word clean, it's very subjective, because if we were to do a test and scrub this whole area and do the test, we will find amazing results. Florence Nightingale once said, "For us who nurse, our nursing is a thing which, unless if we are making progress every year, every month, every week," and I would add there and say every day, and therefore we are probably moving backwards. This does not only apply to people who are in nursing field, profession in particular, it applies to everyone in this house who is a healthcare worker, because if you are a healthcare worker, and therefore you nurse almost in your everyday activities. So are we moving backwards or we are moving forward? That's a question that I would like to leave you with before I continue with this presentation. The WHO has specified over the times that healthcare association infection, sometimes called nosocomial, are most common adverse events that happen in most healthcare settings. Almost every country, every state can say we do have healthcare-acquired infections. And a large percentage of these are preventable through proper strategies which are robust in preventing such infections. And then in the sub-Saharan, it has been found that infections and the surveillance strategies specifically tailored to enhance prevention and infections are very rare, and also there is a need for such interventions because there is a high burden of healthcare-acquired infections or nosocomial, as we said. But then what's the solution? The only solution to such a high burden of infections in the sub-Saharan is that we need to apply infection prevention and control measures, which is a scientific approach with practical solutions and designed to prevent infections that may be caused in the hospital. And also, it is deeply rooted to patients, relatives, healthcare professionals, including ourselves in this beautiful building. However, there are multiple challenges that have been found that makes it hard to implement such interventions in most facilities in such dialysis units, which is there is no priority of infection prevention and control in most facilities in South Africa and other countries. There is also gaps in policies and also actual implementation of such policies. And there is also a lack of reliable data of healthcare-acquired infections for a lot of dialysis facilities in the country. There is also a limited resource, which includes staffing in the dialysis units. There is also inadequate budgets towards IPCs. Those who work in public sector would say that during the time when it's a change of budget, around March to April, there is mostly a scarcity of equipment in the units. And it's a challenge that is keep on occurring almost every year when it's a budget time. But then now, how do you allow people to work in a space where there are no proper resources? It's something that we have to really look into. We need a built infrastructure so that we can make sure that we prevent infections. And lastly, the challenge is when it comes to procurement. You would find that most times in facilities, people would try and procure the proper probably dressing types and all those things, but they don't get them due to the challenges. You find supplies at times, they delay. It's worse when it comes to public hospitals, because this study was focused specifically on 2 public hospitals in the province of Gauteng. You find that in the nursing facility, or in the ward or unit, they would procure a certain kind of material, but due to constraints of budget, it will take long to get them into that. Those who work in public facilities would attest to this. All right, the WHO and also the South African Department of Health has specified that in South Africa, dialysis units are one of the high-risk areas for infection. Do we agree? 100%. And still, you see that quotation there, hospital-acquired infections represent the most frequent adverse events, was one statement which gave me a runaway from the time when I was seeking ethics. Because one person asked, why do you think your study is so relevant? And I said, WHO every year when they release their reports, they keep on specifying that there is no healthcare facility, unless you can bring evidence today that your facility does not have infections occurring every day. I was laughing yesterday when I was just making sure that what I'm presenting here today is evidence-based. WHO has also published a new set of guidelines on the 16th of October 2024. Did you check them? Oh, it's fine, we'll get to that later. This study, why is it so important? What I'm presenting today here is a situational analysis through an audit, which is phase 1 of all these multiple phases there. It's part of my PhD. We did a situation analysis through an audit of 2 facilities, and soon after that, we've already done direct observations of these people who are working in these 2 academic hospitals. And we also done interviews to try and understand why do they not adhere to infection prevention and control guidelines. And from that, we are going to develop ways on how we can improve such and implement these. And again, we need to test and see that what we are developing is really relevant to them. Is it working, so that we can take it to other facilities in the country and say, please try and do this. That's why we're going to then have to do an evidence-based guideline for IPC in the country. Again, we all know that people on hemodialysis are at an increased risk of developing infections. Hence, this situation analysis was supposed to be done in this study. And also, in so doing, we are trying to adhere, like everyone does, in adopting to United Nations Sustainable Development Goals. Number 3 says we need to have or promote good health for our patients and well-being, while we're also making sure that while we're caring for patients, we need to care for the carer, which is nurses and clinical technologists and everyone involved in dialysis facilities. Then we want to promote safe and secure working environment for all workers, Sustainable Development Goal number 8. WHO specifies that each and every facility which is working with patients must have all these requirements, which is programs must be intact. This one, as you are taking pictures, you need to take a picture of it and go assess your facility after you leave this room tomorrow or the day after. There should be education and staff training that takes place. There needs to be surveillance that is taking place. We need proper workloads and staffing and bed occupancy in facilities where dialysis is given, and the built environment. That second slide, which showed a very beautiful outlay of a dialysis unit, we want something like that. But go to public hospitals. We'll come to that one later. The study was approved by the Tshwane University of Technology Ethical Committee and also the National Health Research, which is the Department of Health in Gauteng, to allow us gatekeeping into these facilities. And for confidence, we make sure throughout that we identify such facilities as Facility A and B. You'll see as we move on to here, because they may be vulnerable if we have to give them by names, because we are dealing with very ethical matters when it comes to such compliance here. So we did a document content analysis, which was also accompanied by asking the questions to the people who are working there, who are in management. So each and every item of this audit, we had to go back and ask, is this there? If they say it's there, we needed evidence to show that such things are existing through a checklist. And we did 1 month each hospital, which was between July and August 2024, just a few months ago. So it's still fresh information, hence we have to make sure we keep confidentiality of information. These two facilities, A and B, they both accommodate patients on dialysis for both chronic and acute. Some of them, they come from the wards, they go get themselves dialyzed and go back to their wards. Some of them, they are outpatient dialysis, with the statistics of between 51 to 72 in a combination. However, very important, none of these facilities are involved in any quality improvement project that is robust over the past 5 years. They both are well furnished, and there is also isolation rooms for patients with hepatitis and also patients with CRE. But we were also a bit worried on the implementation of such because of the spacing between these patients in the wards. We found that these facilities do not have a more than 1.5 meter distance between patients, which is putting patients vulnerable to transferring of infections. So if a person is dialyzing patient A, there is a less chance that by the time they move their hands, they will not touch patient number B. And we had to see this as we were working in these two facilities. They kind of have the same demographics. Those who were here in 2022, in Devon in particular, I had done my master's and I had found, I have done 5 facilities at the time. I did 4 private dialysis facilities and then only 1 public. But this time around, so that we can have a good evidence, we said, let's compare apples with apples. That's why we only took 2 academic hospitals within the province. They both, in the hospital, have people who are having advanced diploma in nursing and certified in infection control in both facilities. But the question that came then, when we went down into the facilities themselves, because remember, in the public sector, it's a hospital, which is very big, and then it's a dialysis unit as part of it inside. No one inside the facility, inside the unit, the ward, the dialysis ward, have a certification in infection prevention and control, but they are called champions, who are the champions of the ward, which is worrisome because they need to be certified in IPC, so we can call them champion. That facilities, both A and B, do provide general training of IPC, but the worrying part of it is that infection prevention and control training provided is not specific to dialysis. It's a general IPC, how to don PPE, how to do hand hygiene, but not specific on how do you connect a patient. Some people have been employed for how many years? More than 10. They have not gotten training again to say, this is how you connect a patient due to using evidence-based guidelines. And then this one, very interesting. We looked at the tools that they have in the ward to try and help staff to do the right thing. Like we said, Goal number 8, we need to have environments which are allowing staff to do the right thing. The only tool that we could find in the facilities, both A and B, was the one concerned with hand hygiene. So in these two facilities, there are no audits done on the catheter exit care, how they do it. There is no catheter connections and disconnection procedures. So if we had to assume, we would say everyone do as they please. What they think is right, then they connect. So a person who would be connecting in A might do a different thing from B because there is no guidance on this is how you should be doing the procedure. We then went further. Remember, this is a phase 6 study. In phase 2, I told you we did also observations, which I just had to give you just a bit of highlight of it. If you look at there, this is facility A. Because they do have, in the previous slide, a hand hygiene tool that is available. Then we said, let us take from our observations what we've observed. These perform hand hygiene before preparation is when they prepare to give medication, which both facilities, they give heparin to patients. Do they wash hands before they prepare a simple heparin giving to the patient? And you can see there, 84% non-compliance. The beautiful speaker from the OHSC said, these people, they change behavior when they know that you are coming to do an audit. In our audit and also our observations, we made sure that we do not tell these people what we are observing. They knew we are in the ward, I'm doing an observation, and I was just walking around with my phone. And that tool was inside the phone. When I see you do something, I will just click in the thing, then it submits the system, then it gives this. That's facility A, 84% non-compliance. Facility B, comparing the same thing as well. 47 responses that we were looking at, 70.2% non-compliance. Should be worried. People don't wash hands, but they have equipment. Now, this study is not going alone. These are other studies which we've found. The WHO, the DAOH, the Department of Health in South Africa, has published that there is poor prevention programs in most facilities in South Africa, which scored 1 out of 5. So out of 5 guidelines which are supposed to be implemented, they found that they were only compliant on 1. It was published in 2020 by the Department of Health in South Africa. And also there is a study which has showed that nurses did say they experience challenges when it comes to knowledge towards IPC, inadequate hospital infrastructure, and more. And also, we did find in 2022 that there is lack of training, education, and staff and supplies to support staff and equipment when it comes to infection prevention and dialysis facilities in Gauteng. Now, what should we do moving forward? So this study concludes that there is a lack of participation in quality improvement in these facilities. There is inconsistent training that is offered because the training, we believe, should be specifically focused on dialysis, not just general practitioners. That's why we are called specialists for a word. Limited auditing. There needs to be more audits that are done in these facilities, and there is policy gaps. What should we do moving forward? We need to engage these facilities in more formal quality improvement programs. We need to do a robust interventions related to protecting staff and patients as well, which is what we are going to do in our phase 3. And implement more audits and train staff, and then after training, we can therefore audit again and say, do they improve when we are intervening or they do not? These are my references, as we can see. And this study acknowledges Prof. Ramukumba TS, who's my supervisor, Dr. Bale, and my librarian, Miss Susan, and Miss Ndaba Spesihle. Siyabonga kakhulu.
Thank you, Mr. Ngema, for the presentation. Colleagues, we are going to take 1, 2, 3 real burning questions for the panel, and then we will definitely move to the second session where we have 2 speakers coming to speak. Over to you, You can ask your question, yes.
Is this mic on? Thank you to all the speakers. Very interesting session. Tamara, I'm so proud. And Sienna, to the young people presenting. It's just awesome. And especially papers and studies and analysis and comparisons done in South Africa. That's what we want. So thank you for that. Of course, my question is to Tamara. Thank you for your lovely presentation about the comparison. With the TSC, we was just concerned about the antimicrobial claim being put there. There are no references on the antimicrobial efficacy of TSC actually. Otherwise, we would have used it in our machines as an antimicrobial really. So I just wondered where you got that from. As we know, it's only a chelating agent. And that was my concern on that. So those references I would love to discuss with you later. The big thing is that I want to find out from you any side effects on your TSCs compared to heparin when installed. Thank you.
Thank you, Tamara. I'll give you a chance now. The second question.
Okay. Good morning, and thank you to the panel for the presentations. Prof. Tusha, my name is Cedric. Yeah, I'm a bit disappointed or shocked that the number one incident in the medical errors of patient safety is wrong medicine given to patients. I know that does not happen in Pretoria, but what I wanted to know was, in South Africa, our public health service it's not capacitated to take all dialysis patients. So most of our dialysis, the biggest dialysis providers are the private sector people. But then, as we all know, it will be naive to think people go into private because of altruistic, ambitions. You go there, it has to make money. I wanted to know, because when you tried to find the causes, you did allude to systems, I wanted to find out, is there a chance that also in how we train the staff to be, dialysis therapists or whatever, nurses, clinics, that we skip steps and then focus on producing manpower. And as a result, they skip over crucial steps. I will give an example. When Tamara and I was doing a presentation as well, she first started by showing which areas has got more PEMCATs versus fistula. And it's like, we do not even encourage our patients to do fistulas. It's like, we don't want to bring the pain. So we just say to everyone, do a PEMCAT or something like that. You understand? And then in that period in between, we open ourselves to more incidents of safety or something like that. Okay.
Thank you, sir.
Thank you.
Last question.
Thank you
Prof,
very much.
be ready.
Thank you for the wonderful presentation. My name is Gail. My question is for the Office of Health Standard. As dialysis centers, we use multiple tools to be able to drive standards for ourselves, and we get multiple tools provided to us by different, sometimes funders or auditors. Are you looking into tools that are specific for us? Because sometimes we have different needs from general clinics, we have needs that are very specific to us. Is there something that is being looked into, put in place for us to be able to have clear standards that others would adhere to? I'll give an example, for instance, an emergency trolley. We may not need what an ICU need, but we get audited differently by different auditors that come through our unit. Thank you.
Thank you. I'm going to allow the speakers, each of you, 3 minutes to answer the questions. Let's start with Tamara.
Thank you so much for your question. And I will get back to you about the references as well. So in terms of the side effects, with my study, we didn't look at it, but from my research, from reading all the papers published, in the use of TSC, most of the time patients report feeling like a burning sensation. They get a metallic taste when it's pushed in too fast. So basically what they've done now is they've given instructions on how to use TSC. So they've said you need to use it very slowly. You push it in very slowly so that the patient doesn't feel that symptom. The other thing is obviously like with heparin, it can, if you maybe lock with more than the locking volume required, it can enter the circulation. So on the TSC syringes themselves, they do have the markings where you can choose as much as you want. For example, if the catheter says 2.5, you push out your solution to 2.5, you inject it into the port. Yes.
Thank you. Over to you, Isel.
Thank you so much for the question. It's so important that the inspection tools are contextual. You must understand the environment. Now, at this stage, just when I spoke, I've spoken about the input that we have given to the Department of Health for standards for renal practices. But it will be contextual. You are not at this stage in the line for, as I said, we have to prioritize who's next. It's TB hospitals, mental hospital, ambulances. And then we will determine what is the next. But remember, with NHI, it's going to be very important that everybody gets certified by the OHSC so that they can apply for accreditation. However, and I said it earlier to the chairperson of the society, we do not develop tools without you. Nothing for you without you. So stakeholder engagement is very important so that we understand what's the needs. And just the last something, chairperson, I want to give an example. Emergency trolley in the ICU and in a GP practice. If you can have a look, reach out to me if you want to, so that you can see how we adapted a GP practice, the emergency trolley for a GP practice, so that it is cost-effective but safe. So I hope that answers your question. Thank you so much.
Thank you, Isel. Prof, over to you.
Yes, I think the gentleman brought up a very good point about medication errors and training, but it's multifactorial, I would say. Training and education absolutely is important so that everybody understands, especially when they communicate what drug they're talking about, as same drug may be available in two different trade names, and if one person uses one trade name, the other person, if it's not communicated well, may think that erythropoietin has not been administered and may use the other trade name and then give a double dose. So clearly that's a problem. More importantly, on top of this, if it's a for-profit organization and there is workforce shortage, then things are rushed to maintain the timeliness for each shift, and when people are rushed, you tend to make mistakes. So clearly it is multifactorial, and one has to look into what exactly is leading to these errors in each individual unit and then tackle those units accordingly.
Thank you, Prof. I can see Mr. Ngema is also saying he would like to have a 1 minute contribution. Over to you, Mr. Ngema. 1 minute. I start counting.
Thank you very much. Do I talk too much, Prof? I want to answer also to following up on Mr. Cedric Mabe. With regards to the training and more, I think there is quite a big challenge in dialysis space. It seems we are a team, but we are not a team as well. How one looks at a nurse and a clinical technologist, it's quite different, and doctors as well work in nephrology. We did our study in 2022, and one of the things nurses were saying and clinical techs was, doctors don't wash hands. They come from point A up to point last without washing hands in the dialysis facility, but yet they are part of the team. Do you tell them, no, we are scared of intimidation and all those kind of stuff? So there is that conjuncture that is not solved yet. And also, when we submitted our paper, I remember in 2023 for publication, one of the reviewers said, nurses and clinical technologists do not get the same training of at undergraduate level and postgraduate level. But then I said, infection prevention is standardized for everyone. Why should there be a difference? So I think there needs to be a point of conclusion in that to say everyone must be mandated to have training specific in dialysis, but not only in their specific facets where they are situated. Thank you very much.
Thank you, Mr. Ngema. Ladies and gentlemen, I invite you to engage with the speakers, the panel, even after this session. They are still here. They are not going anywhere. Mr. Ngema, if you can switch off your mic. In terms of the next session, we are going to look at technological innovations in nephrology. Whilst I ask my panel to, as you give them a round of applause. Remember, Renal Care Society members, there's an AGM at 1700 hours, photo competition on Facebook upload as well as Instagram. However, you must be present at the closing ceremony in order to claim your fabulous good prize. We are moving into technological innovations in nephrology. At this point in time, I am going to call upon Boitumelo Mudumela from Wits Business School in Johannesburg. She'll be talking to us about artificial intelligence in nephrology. Is she here? Okay. I know that artificial intelligence is something else, and let's hear what Boitumelo has to say to us about it. Over to you, madam.
Good morning, ladies and gentlemen. My name is Boitumelo Mudumela, and I'm a clinical technologist in private practice. Today, I will be presenting to you my research on artificial intelligence. South Africa's nephrology sector lags in adopting AI innovations, with scant research on AI's application within the local context. This study aims to bridge this gap by exploring the perceptions and readiness of South African nephrology practitioners towards AI. I want you to imagine a world where AI technologies are used in every healthcare practice and that interoperability is a thing of the past. A 45-year-old patient walks into your practice with mild fatigue and swelling. Routine tests are inconclusive. You're using an online platform that is AI-enabled, and you're using it via your either laptop or your handheld device, iPad, tablet, or mobile phone. So this AI tool analyzes the patient's lab results, detecting early signs of CKD, including changes in the renal cortex and small shifts in creatinine levels, which could be missed by human observations. A 60-year-old patient with stage 2 CKD with diabetes and hypertension visits for follow-up. AI evaluates the patient's lab trends, for example, eGFR and proteinuria, and predicts rapid disease progression towards end-stage renal disease within the next 5 years, unless adjustments are made. The nephrology practitioner, informed by AI, modifies the patient's treatment plan, including stricter blood pressure control and medication adjustments, slowing disease progression. Then you have a patient with stage 4 CKD preparing for renal replacement therapy. AI integrates the patient's medical history, genetic markers, as well as lab data to recommend the most effective medication and suggest peritoneal dialysis based on the patient's home environment and health profile. The patient receives a customized treatment plan that optimizes medication and dialysis options, improving outcomes and reducing potential complications. Then you have a 55-year-old patient on hemodialysis 3 times a week. The machine that the patient is using is AI-enabled. The AI continuously monitors the patient's vital signs during treatments. It analyzes the patient's past treatment data and current clinical conditions to optimize each session. AI enhances the patient's sessions by optimizing dialysis settings in real time, improving patient safety, comfort, and overall outcomes while minimizing complications. In a busy nephrology clinic, AI monitors patient lab results in real time and alerts the nephrology practitioners to any significant changes, such as worsening proteinuria or rising creatinine. AI also ensures that each patient's care adheres to the latest clinical guidelines, helping to prioritize follow-up care. Nephrology practitioners can then focus more on patient care, while AI automates administrative tasks and provides decision support, ensuring that no critical patient data is overlooked. A patient with stage 3 CKD with an AI-enabled device that tracks vitals such as blood pressure and heart rate, while also monitoring medication adherence. AI analyzes these data trends and predicts when the patient might experience fluid overload and potentially hypertensive crisis. AI alerts both the patient and the healthcare practitioner to potential risks, enabling early intervention that prevent hospitalization. The research employed a cross-sectional survey designed to gather quantitative and qualitative data from nephrology practitioners. A survey was selected as the most appropriate tool for this study because it allows for efficient data collection from a relatively large sample of practitioners distributed across different geographic regions and practice settings. The survey consisted of 28 questions covering several key areas: demographics, which included age, gender, years of experience, and practice setting. We also looked at familiarity with AI, perceived benefits of AI, challenges to adopt AI, readiness to adopt AI, and current use of AI, including the impact on patient outcomes. The survey link was distributed through social media platforms frequented by nephrology practitioners within South Africa. It was also shared with individual nephrology networks to at least provide a broader cross-section for practitioners, including those working in urban and rural settings. The survey was available for a period of 4 weeks to ensure that there was ample time for respondents. The survey provides valuable insights into perceptions and potential adoption of AI in nephrology within South Africa. However, it is important to acknowledge the sample size of 45 respondents. While informative, may not fully represent the entire nephrology community within the country. The following discussion considers both the findings and the limitations of the survey. Further research with a larger and more diverse sample would be more beneficial to validate these results and provide a more comprehensive understanding of AI adoption in nephrology within South Africa. So with the demographics, the majority of respondents were women at 68.89%, aligning with the general trend of a high proportion of female healthcare practitioners within South Africa. The respondents reported a wide range of experience levels, reflecting a mix of early career practitioners and more experienced professionals. This distribution indicates that a significant portion of the respondents had more than 10 years of experience, which suggests that they are well positioned to assess the potential impact of AI within the field. The survey reached practitioners from a range of geographical locations, although majority of respondents were based in urban areas. This distribution suggests that the sample may be overrepresented by practitioners working in urban areas, where access to healthcare technologies may be more readily available. Further research with more rural representation is recommended to provide a complete picture of AI adoption in nephrology across South Africa. Then the practice settings. Respondents work in a variety of practice settings, offering a broad perspective on AI adoption across different nephrology practices. The majority of respondents were from public hospitals and clinics, followed closely by those working in private healthcare practices. A smaller portion of the respondents came from academic institutions and private practices. While a small percentage of respondents are highly familiar with AI, the majority are only somewhat familiar or not familiar with AI technologies. This finding indicates a potential knowledge gap that could impact the adoption of AI in nephrology practices. The survey reveals a significant gap in awareness and familiarity in AI technologies among nephrology practitioners, with 65% of respondents indicating that they had never heard of AI technologies within nephrology, and only a minority being highly familiar with AI. There is a clear need for increased education and exposure. This lack of familiarity is likely a key factor behind the low current adoption rates and may also contribute to the resistance to change identified as a major barrier. Then respondents identified several potential benefits of AI in nephrology. The most commonly identified benefit was AI's potential to optimize treatment plans, as well as followed by improved diagnostic accuracy and better patient outcomes. Several challenges were identified by respondents as barriers to AI adoption in nephrology. Data privacy concerns were the most significant, identified by respondents, and this reflects a broader concerns in healthcare about the security of patient data in AI systems. A lack of training was also noted as a major barrier to AI adoption. Respondents were asked how likely they were to adopt AI technologies in their practices. A majority of respondents expressed that they were either very likely or likely to adopt AI technologies in the future, suggesting that there is strong interest in AI despite the challenges identified. The survey explored whether respondents were currently using any AI tools in their practices. The majority of respondents are not currently using AI tools, which aligns with the earlier findings on low levels of familiarity and awareness. The biggest respondents identified several key barriers adopting AI technologies in nephrology. Resistance to change was cited as the most significant barrier, followed by a lack of infrastructure and high costs of AI technologies. Respondents were asked to identify factors that could affect, that could help facilitate the adoption of AI. Training programs was overwhelmingly seen as the most important factor in facilitating AI adoption, indicating a strong need for capacity building within the nephrology community. The survey also explored how respondents perceive the current regulatory environment for AI in healthcare. The most respondents perceived current policies and regulations as neutral, suggesting that while these do not actively hinder AI adoption, they are not strongly supportive either. Respondents were optimistic about AI's potential impact on patient outcomes. A vast majority of respondents believe that AI would have a positive impact on patient outcomes, reflecting strong confidence on AI's potential to improve healthcare delivery. The survey also explored how AI might affect interactions between patients and practitioners. Most respondents expected AI to have a positive impact on their interaction with their patients, likely due to the efficacy and personalization that AI technologies can bring to care. In conclusion, the survey provides important insights into the current state of AI in nephrology within South Africa. While there is significant interest in the potential benefits of AI, particularly in improving diagnostic accuracy and patient outcomes, the adoption of these technologies remains limited to several barriers. To overcome these barriers, it is essential to focus on improving AI literacy among healthcare professionals through comprehensive training programs. Additionally, addressing concerns related to data privacy and infrastructure will be crucial in enabling the broader adoption of AI in nephrology. With the right support and resources, AI has the potential to significantly enhance the nephrology practices in South Africa, ultimately leading to better patient outcomes. Based on the findings from the survey and the subsequent discussion, the following recommendations are suggested to facilitate the adoption of AI in nephrology within South Africa. Redistributing the survey across more regions, practice settings, and healthcare environments, along with a larger and more representative sample, will provide more comprehensive and reliable results. These findings can then guide targeted strategies for AI adoption in nephrology within South Africa, enhancing patient care and healthcare delivery. Can I challenge you today? Instead of standing on the sidelines and observing, I want you to participate in this transformation. Start by investigating or exploring how AI technologies can enhance your practice, how it can improve your workflow, or most ultimately, what we want is for it to assist us to give better care for our patient. The power of AI lies in our hands, but the next step is up to us. So let's shape the future of nephrology, because the future, I believe, is here and it is intelligent. Thank you.
Boitumelo, thank you so very much for that most informative presentation. I'd like to introduce our next speaker to you. Anne Rambaran will be speaking on the role of digital transformation in patient-centered care. She is from National Renal Care in Gauteng, and I welcome her to the podium now. Anne?
good morning to you, and thank you for that introduction. It's fantastic to hear how much of value that technology can bring to our organizations. But today, I'm here to remind you that digital transformation is about people and not technology. The success of any technology depends on the patient and healthcare professionals adapting and adopting to using technology. If we don't see the value in new technology, even the most advanced tools will fail to deliver results. So we've seen patient care is being revolutionized by rapid advancements in healthcare. New technology is driving more efficient, accessible, and personalized healthcare. Digital tools are now available to the masses. As of 2023, around 66% of the world's population have access to internet. In developed countries, the internet penetration is at about 90%. In developing countries, the internet penetration is about 60%, and in the least developed countries, the internet penetration is around 40%. Would anybody like to guess what the internet penetration is for South Africa? Anyone? It's 72%. Okay? So based on this information, the objective of my study was to examine the role of digital transformation and the processes on patient-centered care for individuals diagnosed with end-stage renal disease. So the methodology that I used to explore the in-depth and subjective experiences of our patients was a qualitative approach, exploratory and descriptive case study. Semi-structured, in-depth interviews were conducted with patients who were selected using non-purposeful sampling. I used a systematic thematic analysis to identify, analyze, and report themes within the data. So my research was underpinned on the digital transformation conceptual model and Picker's principles of patient-centered care. Digital transformation occurs when technologies are applied to a business model, culture, and customer experience. Digital transformation in healthcare occurs when information and communication technologies are used to manage illness, health risk, and wellness. The World Health Organization highlighted how important technology is in achieving their health goals by including them in the 2030 Sustainable Development Agenda. Technology in healthcare should focus mostly on the needs of the patient and bring new ways to get patients to participate in their care. The patient ultimately is at the center of all that we do. Picker's patient-centered care model ensures that the patient's needs, preferences, and values are at the center of our care, leading to more personalized and effective healthcare experiences. If you look at the pyramid, it should remind the older folk of Maslow's hierarchy of needs. But here we see that patients prioritize their preferences, and these should be respected and responded to. A patient's values should guide clinical decisions. We see greater outcomes, compliance, recovery, and a reduction in readmissions. In terms of coordination and integration of care, an increase in communication with healthcare providers saw a reduction in medical errors, as well as promoting collaboration and continuation of care. Patients should have access to clear and understandable information and education, specifically around their condition, their treatment options, as well as their outcomes. The physical well-being, pain control, and providing a comfortable environment is important. For those of you that are very familiar with the patients, you will understand what the importance of a TV, bed, meals, and waiting time means for them. Being a patient and receiving treatment is extremely stressful. Us as healthcare providers should take the responsibility of relieving these stressors and anxieties and addressing emotional and physical well-being side by side. Involving family and friends is essential for healing. Continuity and transition becomes relevant as our patients move from the hospital to their home or from one provider to another by connecting these patients to the resources they need. Patients should be able to access the care that they need. So 8 themes were identified after interviewing the patients, and these were namely enhanced access. Having access to multiple digital platforms, patients started engaging in self-monitoring and increased adherence to treatment. Patient engagement and empowerment. Patients felt that they lost control of their lives after their ESRD diagnosis. Having access to education and clinical markers, as well as their treatment progress, made them more confident in making decisions about the path that their treatment journey was going to be. Some spoke about transplantation, and others started talking about palliative care and end-of-life plans. Patients made lifestyle changes by tracking these results, and they had improved quality outcomes, and they saw reduction in costs due to experiencing fewer complications. They started monitoring their weight, their fluid, and their dietary intake. And most importantly, they made realistic, incremental lifestyle changes. Personalized care plans. What we saw here was a shift in the power balance of decision-making. One of the patients said to me, "I am unique and so are my symptoms, and my treatment plan should reflect what I want to prioritize in my care." Care coordination and treatment reduce the duplication of tests as well as delays in treatments. Digital health education provides patients accessible to multiple platforms, and what this did was it increased their health literacy, which promoted healthier behavioral and lifestyle choices. Cultural competence and diversity highlighted that care should be sensitive to cultural differences as well as multilingual support. Communication and information sharing showed that real-time reporting was important to patients, as this meant timely interventions for them as well as promoting patient safety. So there's other studies that we can look at that talk about technology and how there's a paradigm shift in healthcare through technology and patient-centeredness. And there's many concepts that emerged from these studies. Concepts like digital health, which includes information and communication about health technologies that enable patient-centered care that is data-driven. E-health, what this includes is internet-related health services, and the concept of global thinking was introduced. Telehealth, this is telecommunications used to deliver healthcare services, but this included clinical as well as non-clinical services. And telemedicine, you will hear one of the speakers talk about this, and this involved clinical services being offered remotely, and it often involves virtual doctor-patient consultations. And finally, mHealth. This is where mobile devices, smartphones, tablets, and wearables are used to deliver care, and we're finding that health apps are being used to do patient monitoring as well as disease management. So in the figure, you will see how technology enhances patient-centered care. We can see that electronic medical records promote coordination and integration of care. Telemedicine promotes effective communication. Remote monitoring promotes access to care for patients. And mobile apps promote patient engagement and empowerment. So the study also highlighted the importance of the socio-technical concept called connected health. Here, technology is used to share information and stay connected while focusing on proactive and integrated care for our patients. Data derived from electronic medical records drive decision making. For the people, which is namely us, who make up the healthcare ecosystem of our patients. The patients will use this information to decide if they want to receive dialysis or treatment, or what type of treatment they want. The family will use information to decide how they can support their patients in making lifestyle changes, or if they want to become an organ donor. Doctors will use this information to decide what's the best prescription for this patient. Healthcare providers will use this information to decide if they have the adequate resources to provide access to care for these patients. Nurses will use this information to provide the best patient experience during their session of dialysis. Funders will use this information to make value-based care decisions. Pharmaceutical companies will use this information to decide how patients can access EPO iron or phosphate binders. Information obtained from digital transform processes support us in achieving the quintuple aim, which includes improved patient experience, better outcomes, lower costs, as well as clinician well-being. And the new concept that was introduced in 2021 was the health equity, and we must note there's a difference between health equality and health equity. According to WHO, health equity focuses on the needs of patients and communities rather than the disease. In health equality, everyone has access to the same resources. In health equity, everyone has access to resources that they need. So there's a difference. So after my interactions with the patients, what they said, in order for them to benefit from digital transformation, the key success factors from a patient perspective were for us to consider their access to resources. Do they have internet? Do they have a mobile device? When there's load shedding, what happens to them? How do they access all these digital technologies that we want them to access? Provide and promote user-friendly digital tools. For example, certain patient applications are very complex, so we need to take into consideration what exposure these patients have had to technology prior to introducing them to technology. Digital training courses such as online tutorials help the patients to learn to manage their conditions. However, we need to be mindful that this takes time, and we need to consider where are they in their treatment journey. Are we overwhelming them with information and technology if they're at the beginning of their treatment, or are they seasoned patients that have end-stage renal disease that have the capacity to absorb all of this information? Digital tools should be tailored to help patients from different cultures, languages, and religions. That should be considered. That was a major issue with our patients. Interactive digital decision aids help patients understand their treatment, providing personalized information, informed decisions with their healthcare providers, and this increased the interaction with their nurses. A lot of the patients were nervous that by introducing technology, there's a distance that's going to be created between themselves and the nurse. The one patient said to me, there's one thing that cannot be digitalized or automated, and that's the therapeutic touch. Robust data security measures are important. By using digital tools, strong security protocols must be in place to protect patient information from breaches and to ensure that privacy and trust must be kept in place. So I have a message for you, like the previous speaker. Digital transformation, again, I'm going to say, is about people and not technology. We need to look at shifting from being patient-centric, from being provider-centric to being patient-centric while leveraging the use of technology. Thank you.
Thank you so much, Anne. Now, we've had some really lovely talks this morning, and the technology and innovations in nephrology are really encouraging to the future of our profession. So thank you very much, both of you, for giving us those future glimpses. It really is encouraging. I'm now going to open the floor for some questions to our speakers before we break for tea. We have one question there, so please identify yourself, and we're ready for your question.
Yeah, I'm Dr. Alistair Williams. I'm a nephrologist. The first speaker, thank you very much. That was fantastic. We actually got a user case in South Africa already using AI at our dialysis unit in Mossel Bay. And I'm talking about that tomorrow at 11:30. But the question is real. The challenges is fantastic. It's very costly. We use Microsoft Azure. And it's very difficult if your data isn't clean, meaning you can pump a lot of data into AI and rubbish in, rubbish out. So my question is the infrastructure that needs to be in place, whether your survey looked at what do you define as infrastructure? Because in our personal experience in our dialysis units, we have found that to clean your data and to be more structured is the most challenging infrastructure that you need to have in place for a patient to have a really well customized care plan. If you don't give the data incorrectly, or not incorrectly, but poorly defined, then what the care plan becomes very generic. You could at least read that in a book. So my question again is, how are we going to structure our data integration correctly so that the care plan is well defined at a patient level?
Thank you, Dr. Boichimile. Your response, please.
Thank you for the question, Doctor. So in my view, there are different aspects to infrastructure, and we need to look at different providers with regards to either IT, developers, healthcare practitioners. So it's multifaceted. So I wouldn't say that it's one thing that we need to look at. Because there is just frameworks that are basically available with regards to adopting AI in healthcare, we still need to investigate further just to try to get more information so that we can tailor everything based on inputs from different individuals so that we can have a system that works, especially looking at the context within South Africa. So there are systems available out there. We can use them, but we can't just take whatever we find from outside and use it directly within South Africa. So we need to look at a very broad or different inputs and then form something that will work for the South African context.
Yep, so I'm happy to share with you our South African user case, because we've now got a real life case, which I'm happy to share with the audience tomorrow to learn from.
Thank you.
Thank you, Doctor. Thank you, Boichimile. And once again, it all comes down to having SOPs in place and following guidelines strictly to ensure that data is actually accurately captured. Thank you. We have another question, sir. Please identify yourself. Thank you.
Yes. Good morning, everyone. Two questions for both speakers. My name is Mo from Life Healthcare. The first question is in regards to AI. So AI is, the word itself is quite general. I mean, ChatGPT is just water, a droplet of water when you sort of speak about AI. So just in regards to maybe your research, is there particular sort of different sets of AI tools that would sort of be more impactful within a nephrology or renal or even a clinical setting? What I mean by that is there's algorithm, there's predictive, there's diagnostic, and so on and so on and so on. So that's maybe my first question. And then maybe to Anne, in regards to connected care, right? Of course, maybe you did a little bit of some research with your patients within an NRC setting. I just wanted to ask, how would connected care essentially work or look like within a South African setting? And is there something sort of similar to that that you've sort of seen as well? Thank you.
Okay, thank you very much.
Sorry, can you just repeat the question? I couldn't hear the last part of it, yeah.
Is there anything similar to sort of what you presented within a South African setting that sort of looks to sort of what you researched? Does that make sense?
At the moment, during my research, I did not come across anything like that. However, there are several companies that are looking to start something like this. They're in the research phase, should I say.
Okay, thank you very much for that response, Anne. Boichimelu, your response, please. Let's keep it short as we are running a bit late. And those are all the questions we're going to have time for this morning. I would encourage anyone with more questions to please engage with the presenters after the session during tea time. Thank you so much for understanding. Boichimelu, your response to the last question, please.
Thank you. Thank you so much for the question. So with this study, we only looked at the perceptions and readiness for AI adoption. So we didn't go out looking for the actual AI technologies that were available for us to use. So I just wanted to understand how practitioners within nephrology are viewing AI. So yeah, I hope that answers your question.
Thank you. So it seems like you have a very pressing question there, which I will allow. But please, let's keep it very short, out of respect for everyone's time. Thank you so much.
Komoto from MediClinic, Sister Anne, I just want to ask one question. So with going digital, I think we will be compromising the patient care, only in one way. Most of our staff members usually, after connecting their patients, either they're on WhatsApp or whatever. So now, how are you going to ensure that they still go to the patient and check up on the patients and everything like that? Thank you.
Thank you, sir. Anne?
So you would have seen part of the recommendations was that we create digital tools that are interactive that will include the patients. So that's one way of solving that issue. Also, educating and empowering your patients to make them aware of what should happen during a dialysis session will assist you in resolving your issue.
Okay, thank you very much for that concise answer. Thank you, everyone. Thank you once again to our speakers, and please enjoy your tea. We'll see you back here at 20 to 11. Enjoy your tea. Thank you.
I just wanna know the feelings in your heart when the beat drops out and the people gone. We still be there for me, child. When the lights go out and the morning comes, we still be there for me, child. When the beat drops out with you, I found a new way to live. I see an alternative. Now we started, we can stop it. I didn't need to fall in love. Last thing I was thinking of was you and me, but we collided. Baseline, I will always make time. I just wanna know that feelings in your heart for me. Baseline, after all the great times, I just wanna know the feelings in your heart when the beat drops out and the people gone. We still be there for me, child. When the lights go out and the morning comes, we still be there for me, child. better body, I want better skin. I wanna be perfect like all your other friends. You look so pretty, pretty like the wind. Every time you touch me, I feel adrenaline. Wanna go hard, wanna have fun. I wanna be happy, could you show me how it's done? You look so pretty, pretty like the sun. I could watch forever while you shine on every. Wanna be happy, could wanna be pretty. Wanna be happy, could wanna be like the sun. Wanna be happy, could wanna be pretty. Wanna be happy, could wanna be like the sun. Wanna be, wanna step into love. 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 Alright, if I come round, is it too late if I come now? Would you stay up to figure this out some way? And if I stay here, would you come back? If I stay cool, would you be mine? Would you want me if I want you that way? Cause all I can think about is coming over, coming over. All I can think about is coming over, coming over. All I can think about is coming over, coming over, coming over. Cause all I can think about is coming over, coming over. All I can think about is coming over, coming over. All I can think about is coming over, coming over, coming over. Is it alright if I come round? Is it too late if I come now? Would you stay up to figure this out some way? And if I stay here, would you come back? If I stay cool, would you be mine? Would you want me if I want you that way? Isn't it strange that every time I look at your name, I'm suddenly high? For you to feel the same, I would do almost anything. I give away this, I give away that. All of my shoes and all of my eyes. All I need is you and a bit of music. Cause all I can think about is coming over, coming over. All I can think about is coming over, coming over. All I can think about is coming over, coming over, coming over. Cause all I can think about is coming over, coming over. All I can think about is coming over, coming over. All I can think about is coming over, coming over, coming over. Is this the way that it goes? Well, we're all lost in the sun, all lost in the rain. Do I just stop and let go? Well, we're all lost in the sun, all lost in the waves of love, love. All lost in the sun, all lost in the waves of love, love. All lost in the sun, all lost in the waves of love. All lost in the sun, all lost in the waves of love. All lost in the sun, 'cause we only got one night. Double your pleasure, double your fun, and dance forever, forever, forever. And dance forever, forever, forever. Forever on the dance floor. Feels like we're on another level. Yeah, feels like our love's intertwined. We can be two rebels, breaking the rules, meeting you and I. All you gotta do is watch me. Look what I can do with my feet, baby. Feel the beat inside. I'm driving, you can take the front seat. I just need you to trust me, trust me. It's like I waited my whole life for this one night. It's gonna be me, you, and the dance floor. 'Cause we only got one night. Double your pleasure, double your fun, and dance forever, forever, forever. And dance forever, forever, forever. Forever on the dance floor. Slow motion. I've never found my love in slow motion. Without a leaving row, and I can't focus to find another sunset, but I love you. We're sharing every hour, our drawings, drawing our future. I can't sleep without you here. I sing along to you, yeah, I'm falling, falling to your love, yeah, I'm falling, pushing through my back, 'cause I'm falling, we're falling, burning in the deep, I'm falling, we're falling in love, yeah, I'm falling, falling to your love, yeah, I'm falling, pushing through my back, 'cause I'm falling, we're falling, burning in the deep, I'm falling, we're falling in love. Directions, we change it our minds in different directions. We play it out of sounds and I can't focus. Didn't feel your heartbeat, but I love you. We're staring at the future, involving our problems. I don't sleep without you here, and I sing along to you, yeah, I'm falling, falling to your love, yeah, I'm falling, pushing through my back, 'cause I'm falling, we're falling, burning in the deep, I'm falling, we're falling in love, yeah, I'm falling, falling to your love, yeah, I'm falling, pushing through my back, 'cause I'm falling, we're falling, burning in the deep, I'm falling, we're falling in love, we're falling in love. I don't remember how we got here in the first place. Can't seem to figure out where we went wrong. But when I look up at the stars, I see our future. So take my hand and we can run away. Take a leap of faith with me. Everything you want, I'm sure it could be. Take a leap of faith with me. takes to reel me in. When I watch you dance, and I hear you talking in your sleep, from the way you laugh to the way you cry, has got me crushed. And love keeps pouring out of me, sweet sugar rush. Yeah, when you're with me, you make the world seem like a work of art. You make it bright even when it looks dark. You make it easy when this life seems hard. I'm a better me with you inside my heart. And that's a few good reasons why I want to give. A few good reasons to stay here with me. Freaking out, weak without, me without you. So alone, even around people I know. I guess that's how it goes. There's no way to control the way this feeling grows. When I watch you dance, and I hear you talking in your sleep, from the way you laugh to the way you cry, it's got me crushed. And love keeps pouring out of me, sweet sugar rush. Yeah, when you're with me, you make the world seem like a work of art. You make it bright even when it looks dark. You make it easy when this life seems hard. I'm a better me with you inside my heart. And that's a few good reasons why I want to give. A few good reasons to stay here with me. A few good reasons why I want to give. A few good reasons to stay here with me. That's how I feel for you. With all the things you do, yeah, you make me feel brand new. Oh, but it's time to get away. That's how I feel for you. With all the things you do, yeah, you make me feel brand new. Oh, but it's time to get away. That's how I feel for you. With all the things you do, yeah, you make me feel brand new. Oh, but it's time to get away. That's how I feel for you. That's how I feel for you. That's how I feel for you. With all the things you do, yeah, you make me feel brand new. Oh, but it's time to get away. You always say you're fine, but you're not smiling sober. Tell me what went wrong. No, it don't make sense. I wish I could see in your head. Oh, we started strong, now it feels so tense. The distance between it, I bet. No, we start so no one else would notice. But then when we're apart, I see the credits rolling. Tell me what went wrong. No, it don't make sense. I wish I could see it.
Good morning, everybody. Whoops, that's a bit loud. Welcome back from tea. I know it's beautiful out there, but lovely to have everybody here. My name is Mignon McCulloch, and I'm here on behalf of the South African Transplantation Society, of which I'm the current chair. I'm delighted to be here with Professor Graham Paget, who I think everybody knows from Johannesburg. And even more delighted to be here with Professor Thomas Müller. So as I asked him, how do you like to be introduced? He said, Thomas. I think that's a good start. He received his medical degree in Marburg, Germany. He's done extensive postgraduate training in Boston, moving over to Alberta, Edmonton, moving to Zurich. And I think he's very well known for his key responsibility in transplant programs and National Kidney Paired Exchange. He's currently the co-chair for the Declaration of Istanbul Custodian Group as the senior kidney advisor for Swiss Transplant, and he's also doing a bit of nephrology practice. So we really welcome him on organ trafficking. I think this is a topic that is always of big interest to us in South Africa, and we're delighted to have Thomas here. Thank you very much, Thomas. And as a pediatrician, also delighted to have Valerie here as well. Thank you very much.
Yeah, thank you very much, Mignon. Thank you very much, Graham. It's really an honor for me to speak here, and really, I hope I can give you some interesting information, and we would like to make it interactive, so we will have a question and answer session afterwards. But first, I go a little bit through my work or our work in the Declaration of Istanbul Custodian Group. My co-chair is Dr. Nakral, and some of the executive and council members are sitting here, so I'm not alone on the stage, and when you have questions, they can join in as well. So organ trafficking, first, I think I have no conflicts of interest, but one disclosure, and being in South Africa, I think I can say that, I'm not the Thomas Müller, so I apologize for that. I know it would be far more popular if the other Thomas Müller would sit here. And I don't show this picture just because of Thomas Müller. Thomas Müller knows basically everybody, but the Declaration of Istanbul, I'm not sure how many people know that. And we have this abbreviation, DICG, and often people say, well, what is that? So I hope I can explain that to you a little bit. What is the Declaration of Istanbul? What is it about? So I will go a little bit into the background, then on the why of organ trafficking, then what can we do, what can I do to prevent it, and then, if we have time, to go a little bit into the elephant in the room to speak and discuss that with you together. So organ trade, that is a provisional picture in 2007. That's basically a picture that has been shown a number of times, and it basically comes from the WHO, who saw with the development of transplant medicine that in 2007, really the numbers of organ trafficking, of transplant tourism, of illegal transplantation were rising. Despite the success of transplantation, that was basically a side product. And what they did see that on websites, and there are examples of websites, openly people were advertising for, I'll get you a kidney, I can organize that for this and this amount of money. And what they else saw that the typical donor came from the global south and the typical recipient came from the global north. And the typical donor was shown there, age 28, 29 years, was a male donor, and his annual income was $480. And when they looked at the typical recipient, you see the age is 48, male again, but the annual income is the big difference. It's about 100-fold higher. It's $53,000. And that shows you the whole problem, basically. And to counteract that, to be aware of that, and estimating, and these are all estimates, and the numbers I give are all estimates because it's a criminal activity, so it's hidden. They don't give any data to any registry. So the estimate is that it's between 5 and 10% of all transplants that happen as illegal, as non-ethical. So due to this, in 2008 in Istanbul, a large group of people, about 158 people, physicians, lawyers, ethicists, came together to say, what can we do? And that was really an amazing meeting, and perhaps you can see some familiar faces. I think Vivek is amongst the group as well. Vivek, I think you were there. And what was astonishing, really, they came up with principles, and these principles really are still today working. 16 years ago, we still have these principles, and they made these principles to find a common ground of ethics as standards of ethics against organ trafficking and transplant tourism. And the Declaration of Istanbul was basically found. It was updated with minor changes in 2018, and you see there these principles, the responsibility of the government, the optimal care of patients, the prohibition of criminalized activities, the financial neutrality, international standards have to be followed. The authorities were made accountable as well, so it was really a very strong message as well to the international community, the allocation, the prevention of trafficking, the strategies to discourage trafficking, and self-sufficiency. And self-sufficiency is a very important point. That means that every country should be self-sufficient in transplantation. It should not be the aim that one country gets all the organs, does all the transplant, and another country just produces organs. So these were basically the principles, and they became then principles worldwide. And the Declaration of Istanbul realized, or at that time, that they need a group to propagate these and to help with the translation of these issues, and that was basically the Declaration of Istanbul Custodian Group. And this is basically the child of two big organizations, and we are very thankful because they fund us, they support us. It's the ISN on the one hand, so the International Society of Nephrology, who gives half of the funds to us and supports us. And the other organization is the TTS, it's the Transplant Society. So these principles and the DICG represent a large amount of healthcare professionals in transplant medicine and especially in renal medicine. And when one would summarize all those principles, I think it's really the support in growth of transplantation. So it's not against transplantation, it's really supporting transplantation, but via self-sufficiency and, most important, protecting the most vulnerable and the poorest. In the process, the donors. So how can that be really implemented? And we realize that it's really an international huge task, and we work together very closely with the large players basically in the field, with the WHO, with United Nations, with the Council of Europe, and then, as I said, with the TTS and the ISN. And it's really a close collaboration which tries to prevent illegal trafficking. And there are some definitions, but I don't want to bore you now with definitions. I just show very few so that you have a little bit a tool set of what we are discussing. The organ trafficking basically relates to removing organs for financial gain or a comparable advantage. It is any transportation involved with transplantation of transplants of donors for transplantation. It includes as well undue advantage to health professionals, which is a part of it, and the soliciting and recruiting of donors and recipients, again, for an advantage, and attempting all of these acts without really a consent and without overseeing. And trafficking in persons is basically based on this organ trafficking. It's the same, basically, just now the person is trafficking. And then we have another term, this travel for transplantation. And it's important to say, of course, travel for transplantation can be totally ethic. When you have your family living outside of the country, you have a donor there, you travel there, you get the transplant being done there. That's travel for transplantation, and there's nothing wrong with that. But it becomes transplant tourism when there is trafficking involved and when there are resources used from the country that undermine the self-sufficiency of the country and weaken the country's program in transplantation, which is very important. So bringing this into an easy frame, it's a lot of terminology, but I think it's clear. Organs from the donor go to the recipient. This is fine, this is transplantation, this is a miracle, and I'm really fully supporting that. But the problem becomes when it's payment and or coercion. And often it's mixed, and you are from the field, you know that coercion can happen even in families. It's not only now across borders. And payment perhaps as well. There were successes. In 2008, really the global community sat together, made these rules, and you can see here for the Philippines as an example, the numbers of living unrelated to transplants in 2007 were quite high, and then they really dropped, and they are now in 2009, 10 and 11 really near zero. So there was some impact of the declaration, and the same in the Middle East, hotspots before where a lot of trafficking was going on, and I think there was success. So there was justification really for these rules. And perhaps the most important one and the most knowledgeable one, I think you came across that often because it's often discussed, was with those death row prisoners who were used for organ donation. That was a practice in China, and I think it's a beautiful example how the academic community can really change things. There was, following the Declaration of Istanbul, together with the other groups, there was a major global campaign and academic boycott against that what happened in China. And understandably, China had its own rules and said, we are not caring about what others tell us. They were kind of stepping back and said, it's our program. We are not listening now to rules that were made in Istanbul. But slowly, with the campaign, and the campaign basically was that the journals said we don't accept abstracts or publications from China when there is not clear that it was ethically done. Transplantation memberships were held, or the people were given no membership as transplant professionals from China if they couldn't show that they do ethical practice. Even pharmaceutical companies stepped in and were not doing studies in China when it was not totally clear that those prisoners were not used for organ donation. And training in other centers was as well stopped when there was knowledge about unethical practices. So altogether, with letters and friends, Delmonico, one has to name or to say his name. He was one of the fathers of the Declaration of Istanbul and very strong in propagating this. He wrote strong letters, even met with the president or prime minister in China. So eventually there was then a press release that we stopped this practice of doing organ donation from prisoners and especially from patients on death row. We all know how difficult it is now to control in detail whether that is really stopped in every small hospital and whether there is illegal transplantation going on. But overall, that was a big success to see that such a large program, such a large country really stopped the unethical transplantation. But the challenge continues, and probably all of you have heard about examples where there were suspicious cases, and I just put something out from the media from the last 2 years. You see the trafficking in Nepal, often going from donor kidneys going to India and being transplanted there. There is even a kidney valley where most of the patients have donated their kidneys. So poverty drives there the illegal market. There is the example of Nigeria and Kenya and other countries, but I don't want to focus on any country or say that country is bad, the other countries are good. We have even examples from Japan or recently from Switzerland and from UK. It happens in every country. I think this is a given. Perhaps the extent is different, but it's not that one country can say we are totally free of it. And one example I want to give you, which had then an impact, was in Kenya, that we realized and we were informed by the NFP, that's the national focal point, the person responsible for transplantation in Israel, that there were a number of donors or a number of recipients coming back from Kenya being transplanted. And you see here from December 22 to August 23, those patients were going to Kenya, received a kidney there, and you see the ages, so it's a special age group that was transplanted. And when we got more information about that, we realized that the donors were not coming from Kenya. The donors were basically flown over from former Soviet Union countries, Tajikistan, Azerbaijan, Kazakhstan. So we had basically 2 countries being involved, and the transplantation was done in a 3rd country, the HLA typing was done in the 4th country, and the surgeon who comes, he came as well from another country. So you see how international, how global this is. And to give you an example of one case that led then to some action, fortunately, but it gives you an example what the background is for these transplant tourism cases. The recipient was a 51-year-old lady from Israel. She had 80 PKD. She was on dialysis for 2.5 years, and she was sensitized with 70% panel-reactive antibody. So not easy for her to get a kidney quite quickly. So she contacted a broker, and we know the broker, but it's very difficult to kind of get them punished. But she paid 200,000 euro by selling her house. She was not that rich, but 200,000 euro is substantial, so she paid this amount for money and was flown to Kenya. At the same time, in Kenya, a donor was flown to Kenya. He was coming from Tajikistan. He was a young donor, 26 years of age, from Central Asia. Obviously, we do not show all the details, but interestingly, you see he's probably or most likely not related. I think that is clear, so that's probably really organ trafficking. And he had as well a donor-specific antigen against the antibodies of the lady. So it was a transplantation across the mismatch. So one wouldn't have done that, but it was done. And then the outcome was, and I can show the hospital where it was done, it was the Mediheal Hospital and Fertility Center. We know the names of the physicians and surgeons involved. And this was the letter then sent back to Israel when the patient was discharged and came back to the Israel physician about a week later. And the diagnosis was kidney transplant recipient, native kidney disease, delayed graft function, recovering, hypertension, and graft lower pole collection. The patient showed in Israel primary non-function. The kidney did not function at all. There was no urine output. The biopsy showed 50% necrosis, severe humoral and cellular rejection, and this collection was a hemorrhage from the rejection, such a full-blown rejection picture, and the graft had to be nephrectomized. So it was a catastrophe, and now you can see the catastrophe which sometimes happens behind these cases. You've lost your house, you lost this 200,000, you are worse off than you were before. And this is just one example which we could use then to contact or to facilitate contacts to the government in Kenya, and the Kenyan physicians, they were extremely supportive because for them, these cases, are they bring such a bad picture to a country, and these Kenyan physicians, they really try so hard. I was at the renal conference, and it was really heartbreaking to see how they were upset about these illegal practices of a very small group, not even from their country, who really puts a negative picture on the whole country. So we hope that this hospital will be shut down. It's shut down at the moment, but we know that the persons did move to another hospital, so we are not sure whether the full program and full unethical transplantation has been shut down. So the why, I think obviously is the big question when you want to approach it. Why is that happening? And I think all of you know basically why. I think the demand is so huge, and it's increasing, the demand for organs, the organ shortage, compared to the supply. We do not have sufficient supplies in no country, I think, and in most countries where they don't have even deceased donor transplantation in sufficient numbers, the supply is even lower than in other countries. But overall, we have this huge gap between demand and supply. And when you speak to, like in Kenya or so, said, yeah, that's true, but the major problem is the poverty. And I think we cannot really solve the problem, I think, by not solving the poverty. That's really the background of it. People who are poor and who are desperate, they are often kind of thinking as the last straw for themselves to get some money to get an organ. And I think we always have to put that into our frame. The poverty is really the major driver. And you all are aware of these global inequities. This shows kidney renal transplant patients, and that is from 2017 or so. Estimates again, we have about 3.9 million kidney patients with renal insufficiency, and transplanted, you see, it's about 100,000. So this shows you the big discrepancy, and probably the kidney renal patients, there is even a higher number, which is not really known. And then when you see a similar gap, but really another gap, is the income. And you see here the income in dollars. The richest 10%, they earn more than with $122,000 than the poorest 50%. So we have these problems that difficult to address, but at least we always have to highlight them and to say this is really the key problem. So what can I do? What can you do? What can we do? One thing is just to inform you about the willingness. And that was for me something really sobering. This was a study done in about 800 Canadian patients on dialysis. And they were asked, are you willing to travel for transplantation? 60% said, yes, we would travel for transplantation if we get quicker an organ. This is okay, but 25%, so every fifth patient said, I would even travel and buy a kidney, even knowing that it's unethical and illegal and not okay. Even when the physician to me tells me, don't do that, I would do it. So we have a significant number who is willing to do unethical buying of organs. It's not that I want to blame now this dialysis community, and I don't think it's a Canadian problem that it's only in Canada. There are other numbers in other countries. It shows really the despair on the recipient side, and I think we can't forget that. I think people are desperate to get an organ, especially when they don't see any chance to get a transplant within a reasonable time. And what was interesting then, when these people were asked, what would prevent you from traveling in general? It was not the financial problem. They would find the money. And as you know, it's not just the patient, it's the family. So they kind of try to get the money. And it was not the ethics. We think, oh, the high ethics. That was, I think you have different ethics perhaps when you are desperate and in a desperate situation. Then it's easy for me to say you shouldn't do that, and it's against the human rights and dignity and so, but when you are in a desperate situation, you have to help your family, your children are starving, perhaps they can't go to school, ethics changes. What, however, had an impact was when they would know that legal actions would follow out of it, then they would hesitate. And when they would know that the medical outcome is poor. These were the two reasons. And I tell you that when you have patients who say, and sometimes they say just emotionally, I will go and buy a kidney, you can inform them about obviously the ethics, but primarily about the medical and legal consequences. And the medical consequences is changing because as we see transplant programs and transplant becomes a routine, so not even in all the countries, I think they have very high standards now of transplantation. So it's not a given that it's a poor outcome, I think. The given is that you have to pay a lot, and the given is that it's illegal. And I don't want to say it only negatively. I think we are living with patients and with people who are amazing, and we all know beautiful stories of patients, and because of that I'm interested in altruism as well. And I just show you, I come later to it. This is basically the frame that we are speaking of. The frame is, we have a gap between demand and supply, we have a gap between rich and poor, and we have the despair of the patients and the despair of the donors. And I think this gives basically the surrounding for it. And when one goes to the different levels, for us, the realities for the DICG are the rich and powerful who are willing to travel, the willingness of all recipients, the family fates that are a problem, the return with a transplant from abroad, the lack of knowledge about transplant-related crimes, the moral distress that we as physicians are under when something happens like this, the low numbers of prosecuted cases, the polarization in the world, the hurdle of data confidentiality, the privatization of healthcare is a major problem. I think we see in those countries where privatization is really taking more and more patients and more resources, their organ trafficking is probably the highest. The lack of international laws and the limited resources versus a multi-billion-dollar industry. One has to realize if it's really 5 to 10%, the recipient gets perhaps $1,000 to $2,000. The donor gets 1,000 to 2,000. The recipient pays about 100 to 200,000. So there is about 98,000 to 198,000 benefit in that. And that's a profit which goes to brokers, to healthcare physicians, to corrupt politicians. So it's a really big industry. So what can we do? I think one really approach, and because of that it's great that we can speak here from the DICG to you. I think in the middle of all of this is the physician and is the healthcare professional. So we are really the ones who know about these suspicious cases. We have to treat them when they come back. We have to do the workup before they go. So we are really in the middle, and that we have to address. So what can we do? I think it's basically 4 steps. We can prevent, we can detect, we can report, and we can help prosecution. And when we go through these, I think with the willingness, I think this is a good example for prevention. I think we can tell the patient about the outcomes. We can ask them and give them information. So I think their prevention probably is possible. And now I come with my altruism. And we have to think of the good in the people. So we have to think of course, altruistic donation. And I always was questioning, really, is there really altruism and how much altruism is there? And we all know how we get cynical a little bit with our daily workload, with the negative experiences, and we don't believe them anymore. And I was really very much touched by this paper. This is a group, Marsh Abigail, who looks on psychology and who analyzes altruism. Altruism, as you know, is an act where you do something for someone else without benefiting for it yourself, perhaps even hurting yourself. So that is basically the span of altruism, not being egoistic, but doing it. And this group did analyze altruists. And you see there are different groups. Liver donors, so to donate a kidney, liver part is quite an altruistic act. Kidney donors, humanitarian aid workers like MSF people, kidney donors, heroic rescuers, people who run to a car when it's burning and in flames and just open the door and don't think about it, or jump into a water to save someone, forgetting that they can't swim themselves. So these are the people who are really altruists, or marrow donors. So when they compared them to the controls, you see that the amount willing to forego, that means the interest or the strong feeling you want to give without a personal advantage is increasing, and totally is higher, significantly higher in these groups to the controls. So they have really this feeling to give. And the interesting thing is, this feeling is even strong when the social distance is very high. That means they don't only give to their mother or to their son or to their partner, they give to very far distant people. And it doesn't drop that much. A liver donor has really this feeling to help, and it doesn't matter whether it's the closest relative or it's an immigrant in a camp. So I thought that was very interesting. And then they did further studies in other groups, and they did see that altruists, they light up their amygdala, lights up when they see a fearful expression in a person. It's exactly the opposite to psychopaths who are very aggressive. There the amygdala goes down, and these people show a high empathy when they see a misery. So they could really measure that very nicely, significantly differently, and they could even see that altruists have bigger amygdalas. I would not like to check your amygdalas, but the point is really there are good people. It's not all bad and trafficking. The next thing what we can do, I think, is we can screen for people who want to travel or who want to be transplanted at your center. And I think South Africa has a very high standard in transplant medicine. It's a leading country in transplant medicine, in heart transplantation, HIV patients being transplanted and used as donors. I think you set really worldwide the rules and the standards. So you have people coming into your country who want to be transplanted because you are so excellent. But please check them. Is that brother travel for transplantation? Is the donor they bring with them really a related donor? So I think this would help prevention and detection. We have a protocol, but I don't go into detail, to check for those who come from the outside who want to be transplanted in our hospital. Another point is where I think we can address both willingness, moral distress, and return with a transplant from abroad is the concept of a national focal point. And I think South Africa has no national focal point so far, but I think that would be perhaps something we have to think about, which would help to prevent trafficking. And it's a model which was developed in Europe and is now done by about 25 countries. They assign one person, and it could be a coordinator or it could be one in the government who is the person. The physicians report to all cases of patients being transplanted outside of the country and coming back, or cases where they feel in the country that it was not quite clean. And this reporting is done to this national focal point. The beauty, I think, of this model is that the physicians are mandated to report, so they don't have to feel moral distress. All patients, independent whether it's ethical or unethical, are reported, so that's your duty. And then the national focal point looks at these cases and sees, is there something suspicious or not from the documents? And if they think this looks like something suspicious, then they can include or can approach the law enforcement who can look into these cases. It's important, I think, we as physicians, we have to take care of the patients. We are not the police. We are not detectives. We just report, and we take the best care of the patient we can, independent whether there is any suspicion or not. That's our duty. But like with child abuse, you report and you take care of everything. But you have this national focal point who takes care of it then. So we want from the DICG really push a little bit this model. We have contacted now with Kenya and the European Communion, so to get this perhaps as a global model. So in summary now would be for me, we have this gap, we have the frame, we have to work on the frame, we have to inform the patients about the medical and legal risks of buying organs, we should perform standardized screening for proper travel, we might install a national focal point to facilitate the reporting and the law enforcement, and with the altruism in the background, there are good people, so not everybody is an organ trafficker, and we don't give up. And yes, we have a little bit of time now. I think we could go to question and answers, and there I'll start with the elephant in the room. So the elephant in the room is something that we quite controversially and hotly and emotionally discussed in the DICG, and I really wonder what your experience is with that and what your thoughts is. And it is incentives to increase donation. So there is a huge movement, especially in the States now, to pay donors to increase the donor numbers. They say we have this gap, we will never get rid of this gap, so why don't we give something to the donors? The donors, they don't have any advantage with the donation. Everybody else benefits from it, the recipient, the society, the taxpayer, the physicians, the hospitals, but the donor gets nothing. So they say we have to change that, and they put in a bill now to say that $50,000 tax reduction should be given to every donor. And this tax deduction should be $10,000 per year. So over 5 years, these donors would get not money, but an incentive like tax reduction. So is this something we should think of? We from the DICG, one of the strongest principles is organ donation should be a financially neutral act. We do not want that donors gain from donation. They should not pay for donation. They should have covered all their expenses, so there should be full reimbursement, but they should not get an incentive so that the poorest really donate just to get the money, especially as we know from all the previous examples, including Iran, that the donors are worse off after the donation than before, despite the fact that they think it's regulated and it's a lot of money that they get at the moment. So we are in this problem. Should we address this question at all, or should we negate it? Should we say, no, we have the strict rules? Should we open this discussion? Here is a discussion of financial neutrality, and I'll go now to my question to you, which would be, should we open this can of worms? And I have 2 further questions, but we can perhaps start with this. And Graham and Mignon allowed me to kind of go to this discussion, so I think we are open to listen to you now.
Thank you very much for a fantastic talk. And yeah, it's been a privilege to work or be involved with your, it's an incredible endeavor. Are there any questions from the floor? Somebody must have an opinion on this. Prof. Naika, do we have a microphone? Oh, do we have a rover?
Thank you, Thomas. That was wonderful. I really enjoyed it. And I think Vivek and others in the room were part of the DICG, and we were all really overwhelmed by the sort of commercialism in transplantation, which went everywhere, even came to South Africa. And even now, even though South Africa has a ministerial advisory committee, which I chaired some years ago, and while the paperwork looked good, sometimes you had a niggling feeling that it isn't above board, but you couldn't do anything because everything seemed kosher, if I could use that word. So I think, as you said, even in families and living donation, there's always some aspect of coercion or commercialism. Now, what I wanted to ask you, and maybe people to address, is the despair of the recipient and the desperate situation of the donor. So is it ethical of us as transplant physicians and surgeons to get on our moral high horse and say that, you know, nobody should be compensated financially? And while you said what you said about the Iranian model, is it really so bad? Should we not look at it and see how we can improve it and make it ethical for recipients and donors? So I'd like some comment on that. Thank you.
Now, very thoughtful question. The Iranian model, as you know, it's a regulated model. That means that the recipient pays a given amount to the donor, and in addition, the state gives some money and the coordination gives some money to the donors. And it's regulated so that it's very transparent and open and organized by the government. So that sounds very good, and they have high living donation rates. When one sees that when one looks then at the numbers or so, it's obviously that the recipient, when he pays something to the donor as an appreciation of it, in addition to that what the donor gets from the state, the recipient can give more or less. And what the system turns out to be, that then the recipient asks for, the donor asks for more money. So they go to that recipient who gives them the most money. So suddenly it becomes a commercialization that those who give the most get the organ. And they ask then for quality of the organ, for the age of the donor. So suddenly it is on the one hand very nice and transparent, but then they ask for more and they bypass the regulated system basically. And when we do not have very good data, they are transparent data, but there was a recent analysis of donors, I think about 60, how they felt afterwards. And more than 70% felt stigmatized by society afterwards because society told them, you donated to make money. So the positive thing of donation was totally away, and the donors feel stigmatized and labeled as being money hungry. Then whether they could cover their problems, most of them, and it was a high number, I think 2/3 of them were in financial distress. They had problems, so they did the donation not because they wanted to be altruistic or so they wanted the money. And looking afterwards, they could not settle their financial problems. So they were often worse off, so they regretted it. So there was a huge number of regret on the donor side to have gone into the system. But what I like, Sarah, and you are always kind of so differentiated, we should look more into it. Perhaps we can learn from it and we can think about models that are possible with perhaps a better organization of the money, a stricter provision of the money. And I think, and it really came out, this discussion, to discuss it when not speaking in Switzerland or in Germany, it came out when I spoke in countries like in the Middle East or so, who say, you have blood on your fingers, on your hands, you cause death on the waiting list by having so strict rules. We have the rule of reciprocity, so we have to give something back. And what is wrong to cover the funeral costs for a deceased donor? What is wrong to help the children's education? So we are really in this, it's not easy, and I don't have an easy answer to it, but my feeling is to open the can of worms, I think, is justified. I think it's already open anyhow. It's practiced in a lot of countries, and we should discuss our ethical standards and see how in different countries they are contextual as well. And I don't think we should ride on this high horse of morality and tell them what to do. And for me, it was interesting as well that in some discussions or so, they say, well, we are sick of all this colonialism. That's just post-colonial. You, with your Western philosophy and ethical rules, you benefit from it, you teach it to us, but first you don't behave yourself according to it, and then you tell us what to do. We are sick of that. So it's really interesting. I learned a lot, and you become, or we learned a lot, become very humble.
Errol?
Hi, thank you very much for your talk. Just a few thoughts. You know, history has always taught us that when you ban something, it doesn't go away. It just goes underground and it continues, often with worse outcomes. The other issue is that in your slide, you presented about 400,000 people on chronic dialysis. Probably that was then. The figure's probably around 2 million at this stage. And calculating the cost per year, that's about 200 billion euros per year. The fact is, how ethical is that to society, to the individual? So there's two ways of looking at it as well. Can we as a society ethically support probably the highest incidence and highest cost disease that we face? I think it's not a thing of should we open this can of worms. We definitely need to open this can of worms. And I think there needs to be various solutions that needs to be created in perhaps different environments. Because ethics is where you live, who you are, what society you're part of. Our ethics can be very different to somebody else's ethics. And I think that to ban something without options is never going to work. And I think the declaration, as honorable, as ethical as it was, is swimming against the tide. And I, as I said, my closing comment is, should we? No, we definitely need to open this can of worms, and urgently.
Thank you, Errol.
Perhaps I don't comment on that. We collect the...
Gordana?
Thank you for this wonderful talk, and I just can't agree with you more. I think the can of worms is open and has been all the time open. And the way I see, unfortunately, I don't see the way when and how it can be closed. I used to practice in former Yugoslavia before and during the war. I am 30 years here, so I've seen countries like Croatia that have one of the best preemptive dialysis program, and I've had the patients from Kosovo during the war where the organs have been harvested from the war prisoners. And that's basically 400, 500 kilometers away. My thoughts are, as we know, in Europe how it works. Brussels has the United Registry of the patients, and if there is a kidney needed in Spain or Holland, it's transported within a couple of hours. Doesn't seem to be feasible here, but what I experienced in my own practice is that there were a couple of patients that had to change their IDs from Botswana to South African ID to be eligible for the transplant program. So that's something that we have to keep in mind. May not be for the whole Africa or for sub-Saharan Africa, but for the countries within the region, Namibia, Botswana, Zambia, Zimbabwe, Mozambique. At least, we none of us have a transplant program, and we are all in the process of doing so. And probably we won't be contributing to the Bank of the Organs anytime soon. But at least if our patients can be registered, and of course we need to work on our own register, if our patients can be registered in the program, and if there is not adequate recipient in South Africa, why don't you call someone from Namibia or from Botswana for the transplant? Thank you.
I think it's Elaine next, and then Schwab.
Declaration meeting, which was wonderful. Don't you think that is the time to have the second meeting now? Because the issue after, over 10 years, to almost 15 years, maybe the time has come to evaluate the Istanbul Declaration, not in piecemeal meeting here and there, as the run tour of Istanbul Declaration, so we can take stock of what's happened, where we are, and where we need to go. Thanks.
Schwab next? Or?
Perhaps I'll just, I think it's very important really to hear, and I hear already the answer to the question is basically from most of you, we should open this can of worms. It's already open, and we have to address it. We have to have this discussion on it. And that is now to your question and to the previous. We kind of have decided to go in this way, that we have at these national meetings like here, these discussions with people, really the people who know most about it, and we'll have this process of collecting opinions. Then we'll have external experts as well involved who kind of know more about politics, economics, psychology, anthropology, culture. And then we plan for the beginning of 2026 for a workshop comparable to that in Istanbul for 3 days, really to have an in-depth discussion. We are aware, and I think you know the complexity of it. It's so complex and so emotionally charged. We don't expect a right yes and no answer, black and white answer. I think it's so contextual as well for each country and region. But we want to engage into this discussion and want to stay involved as ethicists and as Declaration of Istanbul, really to be not sidelined. But I agree fully with you, it's happening already, and it's happening to a degree we don't think sometimes. And I think the more we kind of open ourselves for this discussion, what we want to do, and that should be really an example, and I discussed it with Graham and with others and with Vivek, really to try to get it as a respectful, open discussion, so to allow really everybody, because it's so often that it's getting so emotional, and we have to show, and that I think is the beauty of the Declaration of Istanbul. 16 years ago, physicians and healthcare professionals sat together and established rules which are really seen now as ethical rules for transplant medicine. And they are beautiful. When you read them in depth, they are really beautiful rules, and they show the strength, I think, of humanity and of ethics and of universal ethics. I still believe in universal ethics. I don't think each culture has its own ethics. But there are shadows and there are different gray zones which we have to approach. But we are on this process, and everybody of you who is interested can contact the DICG. We will have several sessions, and that won't be the last today, and we are really aiming for something then in 2026. Should we go to the next question then? Or your question first?
So I think you actually answered my question to some degree. It's no use opening the can of worms without knowing what we're going to do with the worms once we get them. Are we going to go fishing? Are we going to go and eat them? And maybe we find some of them are not worms. There's still some good peaches in there.
Mulberries.
So I mean, I think we're going to have to learn to forgive ourselves, because we're definitely going to make mistakes with a process like this. And you're going to have a framework of ideas, because this is a novel practice. Transplantation didn't exist for thousands of years of human history. It's something which is new, and it's now being integrated within the anthropological history of dozens of different societies. So we're going to definitely make mistakes. And as you say, on that framework, you've got desperate people, and you've got opportunists who are desperate to benefit, and you've got altruists on the other side. So it's going to be, we're definitely going to make mistakes. But there are going to be some things which are obviously wrong, like creating a bidding war in Iran. We've learned that lesson. So there's some clear ideas which need to come out, like having an independent third party which regulates sort of, for example, reimbursement or tax breaks or social benefits, whatever it is. So there are some ideas which I'm sure you guys already have, and you're going to have to put, there's no question about it. I don't know how many other countries you need to go to, but I think there's no question about it that this can of worms needs to be opened and needs to be broken up.
Yeah, thank you.
Thanks very much for quite an informative talk. I just wanted to say no transplant anywhere in the world is financially neutral. And in fact, donors, I think, take the biggest hit financially. I mean, whether it's time off for the surgeries, recovery time, etc. And I think that is one of the biggest problems that we're actually facing, is that it is very negative on the donor side. And by having the statement financially neutral, it absolutely isn't.
Yeah, I think that's for me a very important point, that we all know how the living donation really works in reality, and that there is so much extra costs for the donors. I think that they kind of they don't get the reimbursement. Some of them lose their jobs. And when you think of long-term follow-up of donors, how poor that is. So I think if we would really address all the disincentives, then we would have already achieved a lot. And perhaps this might be one result of our discussion, that we say, no, we don't want to commercialize it, and we don't want to put financial gain into it, but we want to reimburse them for that what they have spent.
Thank you so much, yes, for this amazing talk as usual. What I want to say is that we are all aware that CKD is rising, and we're having a huge problem, and that dialysis, despite all the studies and everything, is not providing actually the best outcome. I mean, a 40-year-old person on dialysis has the same lifespan as a 70-year-old person. So transplantation is theoretically the best option, and still the numbers are too small. So we have this chance of organ donation, but we have to kind of arrange it. As Dr. Saib said, it's a new system. It's how we prepare the patients and how also we implement criminalization. I mean, do we have actual legal actions which are taken against those who are actually the centers, even the patients who received? Do we have a global system who is preventing these illegal actions? I think it's not about opening the can of worms, about organizing it, legalizing it in a very clear way.
Yeah, and I think it's a very important point that we realize more and more that probably those who are most punished or pressurized are, again, the recipients and the donors. And those in between, this black box, who really benefit from it, and who really kind of are the illegal people, they get hardly prosecuted. I think we have good examples. I think India is a very good example where really people are put into jail. And it works, but the amount is still very small. And I think we have to go to the brokers and these organizations. There are organizations who still advertise, and they kind of say it's all altruistic. We have the consent papers. Someone spoke about that the papers are produced by the authorities, and the authorities are perhaps not that critical in looking at them. They look a little bit fishy, and so I think we have to do this work as well.
Do you want to go to the second?
The second question?
Thank you, Prof, for that nice talk. My name is Dr. Mazar. I'm from Tanzania. I think we met at Krakow. I'm a nephrologist there. And maybe just to give you perspective on my side, I've had multiple times in the clinic where I work, healthy individuals coming in, young guys, and telling me, listen, what's the process of selling a kidney? And I mean, I've been flabbergasted multiple times, but obviously I've tried to, tell them that it's completely unethical and we don't do that. So basically my comment or my question to you is, we know that there is a significant lag in the donor pool. And we know that there is paired organ donation, and that there is also the Spain model where you're kind of already counted as an organ donor. Why can we not adopt this in other countries to kind of increase the donor pool? Thank you.
Yeah, no, I think it's a good question. I think we have to look really in these models and see how they are controllable and regulated. I think one basic question for me is whether it's possible to have a regulated market so that it's transparent and not kind of influenced by corruption and by who gives the most, gets the best, and so really to make it transparent and regulated. And if we find some solution to this, then I think we could go in this way. But it's still very, very difficult. I still believe in the financial neutrality, but I really want to open the can of discussion, the can of thoughts and of models that people really think about from their background, like you, from your background, what would ethically work in your community. And one thing that we realize from the beauty, I think, of the Declaration of Istanbul is one thing that has changed. Now we have to involve far more the patients, the community more, and the healthcare workers. So I think this is one thing to relook at the Declaration of Istanbul, to get other groups in, and especially those groups who suffer the most, the recipients and the donors.
Okay, can I? Sorry.
Okay. Final comment, I think, sadly.
Okay, so I just want to comment that, as you said in your talk, that the reason why this happens is because of financial difficulties of the donors, and that's the reason why organ trafficking occurs. Now, there was a study which was done in India maybe about 20, 30 years ago, where they actually interviewed people who actually donated those organs or sold those organs. I'm sure you know about the study. And it was quite remarkable in the sense that, they interviewed those donors, and over 90%, when asked the question whether they would actually donate those organs again, they said no. 90%, over 90% of those donors were still in financial difficulty even after they donated, and they still had the same social standing. So in opening this can of worms, what I'm trying to say is that you're still going to pay someone. The question is whether it's going to make any difference to the donor in the first place. And the second thing is that whether this happens or it's not going to happen, it's still going to, there's still going to be a black market where people are willing to sell their organs. The question is where we as a medical group are the ones who are actually paying the donor, or whether somebody else is paying the donor, knowing what the end product of the donor is going to be.
Very good. I think it's a really excellent last comment, I think, and more in the question. So far, I think, and there we have lots of data and publications, payment did not help donation. And the donors who were paid overall said they wouldn't do it again. And their financial situation was not improved. So this is a big point. And this is one of my major arguments as well for people who say, oh, we just pay and we solved the donor problem. It might well be what you indicated, that by changing the system into a commercial payment system will actually reduce the numbers of donors and of donation. It will have a negative impact rather than a positive impact or a neutral impact. I fully agree with you. That was basically my last questions. What if it would not increase donor numbers? That is a big likelihood that donation being paid would not increase it. And the negative impact right now, when we would say now they start that in the US on the world, when they would start something like this, would be immense, because it would really open the floodgates then. So I think our hope is to have this very open and deep discussion over the next 2 years, and then try to find some consensus and to discuss these points.
So I just want to say thank you very much to Thomas for an excellent presentation that was really very thought-provoking. Thanks to the audience for being awake and so interactive. I chaired a session on Thursday on liver transplant allocation, which is also quite a thorny issue. And I think what's really great is starting to sit together in a room and starting to talk about it. So I think we need to grapple and open the can of worms and do whatever we need to do with the various kinds of worms. But I think the starting point is actually sitting in a room and talking about it. So thank you for helping us start that conversation. Thank you to SANS for letting SATS be part of this, because I think it's really important for SANS and SATS to work together. And we invite you to the IPNA Congress, to the ISPD Congress, and to the SATS Congress next year. Thank you very much.
kuita Diani anenge alipo Soma Diani angakudese madira andokuita Diani anenge alipo Soma Diani Diani angakudese madira andokuita Diani anenge alipo Soma Diani angakudese madira andokuita Diani anenge alipo
Good afternoon, everybody. We're about to start our transplantation session. I think I'm going to. Okay, just before we start, a few housekeeping announcements. Please mute your cell phones. The RCSSA poster presentations will take place in Injabula today during our lunch break. The adult e-poster presentations will take place in Khotla exhibition today during lunch break as well. And then, just a reminder, there will be 2 lunch symposia today. Just a few other things. For all speakers and everyone who asks questions, please do not tap on the mic. I was asked by the AV guys that you guys please don't do that. And a reminder to all our CSSA members that we will have our AGM tonight at 5 in this location. Thank you so much. So it's my pleasure to introduce to you our first speaker today, Daniel Maweli. Daniel works at Groote Schuur Hospital, where he's the Assistant Director of Clinical Technology and Nephrology, with over 14 years of experience in nephrology. He is in possession of a BTech degree in clinical technology from DUT, and also works as an e-tutor for postgraduate diploma in public health, University of Pretoria. And Daniel is currently studying MPH at the University of Cape Town. His research interests include epidemiology and biostatistics, and of course, clinical technology, nephrology. I'm pleased to announce Daniel is one of my former colleague of mine, and I'm very proud of what he has achieved. So Daniel, over to you. Daniel will be speaking about the first immunoabsorption for ABO incompatible kidney transplant in South Africa. What nephrology, clinical technologists, and nurses learned from the immunoabsorption. Thank you, Daniel. Let's welcome him to the stage.
Good afternoon, colleagues. Thank you for the opportunity. Thank you. So, my title, as explained, is going to be focused mainly on the effect of the immunoadsorption in reducing the antibodies in the patient, that is the recipient, so that the patient can be able to get a kidney transplant. We covered some of the practical aspects of this procedure yesterday, but today is going to be more on the theory part and how we assess the outcome. So I would also advise that we check a paper that was published by Dr. Badei. It's APO incompatible kidney transplant using the immunoadsorption columns, telling us about first experiences in South Africa. It was published, I think, if I'm not mistaken, this year. You can just check it there by South African Medical Journal. Let us recap and review about different blood groups. So we've got blood group A, B, AB, and blood group O. So the blood groups are identified because of their antigens in the red blood cells. For example, blood group A has got A antigen, blood group B has got B antigen. Of course, blood group AB has got A and B antigen. And then blood group O does not have any antigens. Right. So knowing that, that in the red blood cell there's antigens, there could also be antibodies in the plasma. So we're going to call that isohemagglutinin. So those are naturally occurring antibodies in the blood. For example, for someone who's got blood group A, has got anti-B antibodies. For someone who's got blood group B, has got anti-A antibodies. And then the one who's got antigens, which is A and B, does not have any antibodies in blood. Unfortunately, for one who normally is a universal donor, which is blood group O, has got both anti-A and anti-B antibodies. So for them, it becomes a bit difficult to get transplant because they've got both anti-A and the anti-B antibodies in the blood, of which now we should be able to reduce them. So yesterday we covered this part about immune adsorption, whereby the blood actually is drawn out from a patient, normally with either a fistula or a catheter, and then it is passed through the circuit. We can use either the plasma separation, which is going to be consisting of the plasma filter, or you can choose to use the centrifuge, either one. The reason, you just want to separate the plasma from the blood, and then once the plasma has been separated from the blood, it is passed through the glycosol APO column. So you should use a specific one. For example, if you want to remove anti-B antibodies, you have to use the B column. Of course, for A, you have to use the anti-A. And then, after the blood has passed through the column, and then the plasma has passed through the column, it goes back to the blood and then to the rest of the blood cells, and then it goes back to the patient in the venous line. So one may ask, why do we prefer to use immune adsorption over therapeutic plasma exchange for APO incompatible kidney transplantations? The first reason would be that there's no replacement fluid required if you are doing the immune adsorption. Unlike when you're doing plasma exchange, you have to use a number of plasma volumes. Say, for instance, if you want to exchange, let's say, 2 plasma volumes, and the patient has got like 4 liters of plasma volume, which means it's going to need to have 8 liters. If like 1 plasma volume is equal to 4 liters for the patient. So if you need to treat 2 plasma volumes, you have to use a lot of plasma in that case. And of course, second one, it is actually more effective in reducing the anti-A or anti-B antibodies compared to plasma exchange. With the plasma exchange, maybe you find that the levels are going to drop only by 1 level down. Unlike when you're using the immune adsorption, you will see in the next bar charts how much you will see the difference compared to just dropping by 1 level. Another reason for using immune adsorption is that the patient only comes on the day that is required to, rather just 1 day before the transplant. So the patient does not need to come like for 5 sessions of plasma exchange before the patient can get transplanted. Of course, there is no loss of platelets with the immune adsorption. Unlike with plasma exchange, there's also a risk of infections, of course, small one, but also the risk of losing platelets because of the removal of the plasma from the patient. And of course, you don't need to use any IVIGs because patient does not lose the immunoglobulins if you are using immunoadsorption compared to using therapeutic plasma exchange. And of course, it is quite cost-saving, provided you don't do a lot of the sessions, probably like you're doing 1 or 2 only, compared to doing like 5 sessions of plasma exchange. So this is how the registrar or specialist nephrologist rather prescribes the immune adsorption. So there are 4 things here. The first one is to give us the target plasma volumes to be treated. So that is based on the patient's levels of the isohemagglutinins. So the more isohemagglutinins we have, the more like the more the number of times the plasma should be treated. So we normally use that formula. There's a number of formulae that are available, but we prefer to use the Kaplan one, whereby we just multiply the patient's weight by 0.065 and then multiply by 1 minus patient's hematocrit. I put an example there for a patient who's 72 kgs, and then with a hematocrit of 35%, it's got a plasma volume of 3 liters. Okay, that's one thing that the doctor prescribes. And then the second thing that the doctor will prescribe is the anticoagulation. In our cases, we actually use the heparin. We never use the centrifuge. Unlike with the centrifuge, whereby we are expected to use the ACDA, which is citrate, and we also need to select secondary plasma exchange or device, SPD. But we opted to use the plasma filter, and you'll see the advantages of that with time. And then the doctor will prescribe the recommended blood flow. And then lastly, the doctor will prescribe the plasma filtration rate. You notice that I did not mention the time because the time is not an ideal, but what is very important is the number of plasma volumes that need to be treated. So you can just continue treatment as long as you can until you have reached those plasma volumes to be treated. Yesterday we covered this quite thoroughly, so I will just quickly go through it. I won't go in detail. So we mentioned how we prime the machines. We set 2 machines in our case, and then we prime the first one with a plasma filter, and then we prime also the second machine using the AP, or rather anti-A column or anti-B column, either one, is labeled there with a light blue arrow. And then we, of course, it takes some time to do the priming. It takes about 30 minutes, but we covered that quite deeply yesterday, so I'll quickly go through over it. And then during treatment, we start the treatment slowly. We first set the blood pump to our target blood flow, of which it is normally at 250 mils per minute. And then we also give heparin boluses. Normally we give something like 4,000 to 5,000 for someone who's about 75 kg. And then also per hour, we give about 1,000 IU, and then we check the ACT as well. So very important there, highlighted in red, is that the maximum flow for the plasma separation, it should not exceed 50 mils per minute. Also, it should not exceed 20% of the blood flow, which means if you cannot reach the blood flow of 250 mils per minute, you cannot run it at an optimal level, which is 50 mils per minute, which is, of course, 20% of the blood flow. And then need to monitor every hour all the vital signs for the patient. Continue with the treatment. When you've treated those amount of plasma volumes to be treated, then you need to take the blood samples to the blood bank, and then they will check if you've reached your target, which is in our case 1 to 2, but sometimes 1 to 4 is still fine, then you can discontinue with the treatment. So also, the levels need to be checked first thing in the morning before the transplant. So we should be on standby. In case a patient needs either a short session in the morning, you should be ready to connect the session, but you should, of course, avoid using the heparin in the morning. So with this diagram, or this bar plot, or bar graph, either one, so it shows the effect of the immunoadsorption in the anti-A or anti-B titer levels. So firstly, I will just explain how the anti-A or anti-B are measured in the lab. So they're using the ratios there on your y-axis, right? So for example, 1 to 2 is a lower level, 1 to 4 is a little bit going up right there to 1 to 1,024. So those ratios mean that, for example, let's look at 1 to 8. It means that it takes 8 parts of saline to dilute 1 part of the plasma, such that there's no more antibodies in the blood. So the more parts of saline you need to dilute with, which means that there's more levels, there's higher levels of the antibodies in the blood. So our goal is to reduce them, like I said earlier, to as low as 1 to 2 or 1 to 4. So what this also figure shows us is that each time you're treating 1 plasma volume, there's going to be 1 level drop in the expected number of the anti-A or anti-B in the blood of the patient. So, for example, if a patient's got 1 to 32, so if we're treating one plasma volume completely, it's going to drop to 1 to 16. You treat another plasma volume, it's going to go further down to 1 to 8, and so forth, right to your target. But I'll actually use other diagram. Maybe it's going to be a little bit simpler to understand. Okay, before I go to that part, if you want to check for the clearance, it may not be beneficial to actually compare the pre and post levels using the equation that you normally use, for example, when you want to check the urea reduction ratio, because these are in the exponent form, so it won't be so much meaningful. For example, if the level has dropped from, let's say the pre was 64 and the post is 16, and then you find that the reduction is 75%, it sounds like it is a very good clearance, but it's not so good, because remember our target, we want to go down to 122 or 124. So as I said earlier, I'm going to use a different chart, or rather different bar chart. It's going to be quite similar to this one, just that I'm going to use different expression of those ratios. So this time we're using the logarithms. So we're using the log base 2. For example, 2 to the power of 1 is still as 2. 2 to the power of 2 is 4, right up there to 2 to the power of 10. So what does that mean? For example, let's say 2 to the power of 3. It means that 1 has got a level of 1 is to 8, right? Of course, 2 to the power of 4 is going to be 1 is to 16. So it's going to be much easier to check for clearance if we are looking at the reduction from the exponents. Let's look at the example. One of our 3 patients that we treated presented with the levels, I'm going to show you just now, of 2 to the power of 6. What is 2 to the power of 6? That's 64, right? So that is, so a patient at levels of 1 is to 64, which means that it took 64 parts of saline to dilute 1 part of serum, so that there's no more antibodies detected in the blood. So normally what happens is this. These blood tests are done by the 2 technologists in the lab, and then they report on the highest one. Say, for instance, if the one is done the test and found 2 to the power of 5, which is 32, and the other one found 2 to the power of 6, which is 64, they will only report the one which is the highest one, which is the 2 to the power of 6 in this case. So after treating the patient, we can see that level went down to 2 to the power of 2. So we can now estimate and tell how many levels it went down by. So that is like moving from 2 to the power of 6 to 2 to the power of 2. So it went down by 4 levels, which is very good. Maybe if we were to do plasma exchange, you would need to do definitely more than 6 sessions of plasma exchange, and I don't think we'd actually reach such a very low levels. So in this case, the patient was able to go for transplant. So these are the results of our first 3 cases. The first patient had levels of 1 to 8, and then it was first time, so we treated more or less 5 plasma volumes, but it was not so accurate because it was first time. And then the levels went down to 1 to 4, and then further went down again in the morning before the transplant. Rather, remained 1 to 4 in the morning before the transplant, and also it went further down after the transplant to 1 to 2. The second case, the levels moved from 1 to 16 to 1 to 2. That was a very good clearance. So in that case, we treated 4 plasma volumes, and then we treated them in about 6.5 hours. And then the levels remain low as 1 to 2 the next morning. Just to emphasize on that point is that the duration of treatment will depend on the patient's total plasma volume. For example, the picture that I showed you earlier, it was based on someone who's got a plasma volume of 3 liters. So if a patient's got like more plasma volumes, which means that it's going to take longer to treat that 1 plasma volume. For example, our third case there, the plasma volumes for the patient, it was 4.5 liters. So normally we are able to treat 1 plasma volume per hour if one has got plasma volumes of 3 liters. But in this case, patient had 4.5 liters. So it took us a little bit longer to treat just 1 plasma volume. So that is why that the level dropped from 1/64 to 1/8 after treating 7.5 plasma volumes of the patient in about 11 hours. Basically, the longer the treatment, the better. It means that the patients will actually have better clearance if we keep them longer in the treatment. So all of these patients, they only needed one session of plasma exchange. No one needed more than one session, even after the transplant. So the benefit of using the plasma filter over the centrifuge is that it is, of course, cheaper to use the plasma membrane compared to the centrifuge. Secondly, it is more flexible using the anticoagulation. If you are to use, for example, the centrifuge machine, you have to use the ACDA. Sometimes it can be a bit concerning if you're going to run for very long sessions because you might end up having hypocalcemia. Sometimes can also have problems with the pH starting to go up a bit, and of course you might have problems with also citrate toxicity going to the patient. And you don't want to cause such problems for a patient that's going to go for the transplant the next morning. So that's why we prefer to use the plasma filter and heparin, because with heparin you can stop it at least 8 hours before the operation. And of course you can run the session a bit longer for up to even 12 hours or more with one set, or even you can change the set if the filter is clotted, compared to the centrifuge whereby you have to change the set after treating, I think, 4 plasma volumes. It doesn't allow you to run with one set over 6 hours. But to its advantage, you can use a centrifuge device because I think it's going to quickly drop the levels of the isohemagglutinins. That is per hour rate, not necessarily that for the entire, like for the entire level that we want to reach for. So it's just going to drop the levels quicker, but not necessarily that's going to drop it to the target that we want in one session. Maybe we need to repeat the session again. And then in conclusion, we can say that the first 3 cases, all of them, it went well. There was no single loss of graft due to APO incompatible mediated rejection or hyperacute rejection. So all the patients survived. Even today, they're all alive, those 3 patients. And we're hoping to maintain the protocol that will always allow for these procedures to take place. So we suggest future studies looking at the improvement of the anticoagulation, especially if you are going to use the centrifuge machine, so that we don't give patients too much of the citrate. Also, you don't also end up having a clotted circuit. So that's it. Thank you so much.
Good day, colleagues. Thank you very much, Daniel, for the presentation. Our next topic is recorded. It is by Dr. Baga. The topic is latest intervention in renal transplantation. Dr. Hussein Baga is a consultant physician and nephrologist working at the MP Shah Hospital. He is the head of the Renal and Transplant Unit and also the head of the Department of Internal Medicine. He did his Master's of Internal Medicine training at Aga Khan University, and his nephrology training, he did it here in South Africa at the University of Witwatersrand. He also completed his MRCP nephrology, and he is a member of the Royal College of Physicians in the UK, member of Royal College of Physicians and Surgeons in Glasgow, fellow of the International Society of Nephrology, fellow of the East, Central and Southern African College, and fellow of Royal College of Physicians in Edin. He has presented at several international forums. His main interest is in kidney transplantation, cardiorenal syndrome, and diabetic kidney disease. Thank you. We will listen to the presentation. Thank you.
Hello everyone, my name is Dr. Hussain Wada. I'm a consultant physician and nephrologist working at the MP Shah Hospital. And it's my pleasure to give this talk with the virtually though, with the South African Renal Society Congress, and I'd like to thank the organizers for having invited me. It's very unfortunate that I could not be here physically due to other engagements that I could not respond. So I was tasked to talk about the current interventions in kidney transplantation. So I'll just start off. So this was the iconic moment in kidney transplantation. I'm sure all of you are familiar with this photo of Professor Richard Murray together with the twins. And this was the first successful kidney transplant among genetically identified individuals, which was a success and basically paved the way for further advancements in kidney transplantation field. Subsequently, after 1954, we saw the field of kidney transplantation expand in leaps and bounds, and we could see newer molecules and newer medications and newer technologies coming in the transplant field. And up to now, there's quite a bit that is happening in the transplant field. Despite all of this, unfortunately, there still remains a huge need or a huge demand for transplants. As you can see that from this global activity in organ transplantation estimates of 2022, we are meeting less than 10% of the global needs for transplantation. From this figure, from this slide, you can see that kidney transplantation, of course, is the most common organ that is transplanted, followed by the liver and the heart. Now, when you look at acute rejections and acute graft survival or 1-year graft survivals, this is an old slide, but it shows that the 1-year graft survival has significantly improved over the years. However, if you look at the picture on the right, you can see that the graft survival, long-term graft survival is still quite dismal. And this is data from New Zealand and Australia. More recent data also shows the same thing, whether it is a living a living donor or a deceased donor, the 1-year graft survival is excellent. However, as the months go by, especially after the 5th year and going to the 10th year, you can see that the graft survival tends to significantly reduce. And at 10 years, you can see that the graft survival is less than 60% for both the living donor and the deceased donor. So the question is, why hasn't improved early graft survival resulted in better late graft survival? So the answer could be the fact that the immunosuppression that we use could be having early benefits, but long-term immunosuppression leads to infections like BK viral nephropathy, cytomegaloviral nephropathy, other late infections. It also predisposes to malignancies and cardiovascular disease. The late graft failure may also occur due to mechanisms unrelated to immune injury, especially CNI nephrotoxicity. So more and more studies are showing that when you have CNI nephrotoxicity, prolonged CNI use, it can lead to worsening of renal graft function. Immunosuppression may also be inadequate later on because of non-adherence and the minimization regimens that we see, and this leads to multiple and or late acute rejection episodes, especially what we are all worried about is antibody-mediated rejection, be it early antibody-mediated rejection or late antibody-mediated rejection. Okay, so I will look at certain aspects and to see what is relatively new, addressing all of these concerns: the global organ shortage, how we can improve our long-term graft survival, and also now looking at the newer modalities of lab parameters that we can use, non-invasive ones, to basically diagnose rejections. So if you look at modalities of reducing or avoiding CNI or CNI-free regimens, the TRANSFORM study comes up immediately. And the TRANSFORM study was a 24-month multi-center open-label study for which randomized kidney transplant recipients either to 2 arms. One was everolimus plus reduced CNI or mycophenolic acid plus standard dose CNI. And the primary objective was to evaluate the effect of everolimus plus reduced CNI versus mycophenolic acid plus standard CNI treatment regimens on the binary composite of treated biopsy-proven acute rejection or an estimated GFR of less than 50 mils per minute. And they basically had more than 1,000 patients in each arm, and the patients were subsequently randomized into two. They also had patients who were on either cyclosporine or tacrolimus, and these were the targeted levels for the reduced CNI as well as for the standard CNI. And the patients were followed up for 24 months. So what they found was that the GFR up to month 24 was very similar in both the arms. Both the arms basically at the end of the study had GFRs of more than 50 mils per minute, which was one of the composite primary endpoints. When we looked at urine protein creatinine ratio by category, because remember there was this fear when we used sirolimus that it basically caused proteinuria. The urine protein creatinine ratio across all these categories was basically similar in both the arms. And even over time, you can see that the urine protein creatinine ratio basically was comparable from month 2 onwards, as you can see in this graph. When they look at the primary efficacy endpoint, they found that everolimus and reduced CNI was non-inferior to mycophenolic acid and standard dose CNI at both month 12 and month 24. Remember that the primary efficacy endpoint was a composite of treated biopsy-proven acute rejection or an estimated GFR of less than 50 mils per minute. What they found, which was very beneficial for the everolimus and reduced CNI arm, was that the risk of infections was much lower, especially viral infections, including Ehrlichia virus and cytomegalovirus, which are quite common post-transplant, was much lower in the everolimus and reduced CNI arm. We also found that the formation of de novo DSAs was also much lower in the everolimus and reduced CNI arm. So this showed that basically if you use everolimus and reduce CNI in patients post-kidney transplant, you basically were achieving similar results to standard dose CNI with mycophenolic acid. However, your infection rates were much lower. The development of de novo DSAs was much lower as well. Then came the belatacept study. The belatacept study was a slightly older study, which was, and the title of the study was the benefit trial and the benefit extended trial. So this was basically an extension of those two trials for long-term follow-up of up to 7 years. And the initial belatacept study was a 3-year randomized trial that was basically looking at kidney transplant recipients who were assigned to 3 arms. There was a more intensive regimen of belatacept, a less intensive regimen of belatacept, or cyclosporine for maintenance immunosuppression. And each patient had basically received basiliximab induction and was a mycophenolate and corticosteroids. The primary outcomes of patient and graft survival, renal function, and incidence of acute rejection evaluated at year 7. And what they found was that the rate of patient and graft loss were higher in the cyclosporine arm compared to both the less and more intensive belatacept treatment groups. The belatacept treatment groups both had an increase in the estimated GFR, while the cyclosporine group had an annual decline of 1.04 mils per minute of the estimated GFR across the years, as was seen in this graph. And the mean GFR of the belatacept group of the lower intensity, the mean GFR was 72. The one for the cyclosporine group was much lower at 44. The biopsy-proven acute rejections were much higher in the belatacept arm as compared to the cyclosporine arm, but after treatment, which was effective, they did not recur. So what this showed was that the belatacept regimens had basically superior graft survival and reduction of death as compared to the cyclosporine arms. The rates of acute rejection were similar and they were easily treated and did not recur. The development of DSA, especially class 2, was significantly lower in the belatacept regimen, and the safety was very similar to that of, it was comparable to cyclosporine. However, one of the main drawbacks of the study was that the comparison of the comparator CNI was basically cyclosporine and not tacrolimus. And of course, we do know that tacrolimus is much more potent when it comes to immunosuppression as compared to cyclosporine. There was a huge retrospective analysis done in the US that was looking at belatacept versus tacrolimus, and they found that there was no benefit of belatacept over tacrolimus, and the patients who are on belatacept had higher rates of acute rejection as compared to tacrolimus. So again, the jury is still out there when it comes to belatacept, and I presume that is the reason why belatacept has not been taken up so well. Now, when it comes to antibody-mediated rejection, remember antibody-mediated rejection is a very complex disease to treat. And several drugs have been tried, and this is one of the latest drugs, felzartamab, which is an anti-CD8 monoclonal antibody. And this was a randomized phase 2 trial of felzartamab in antibody-mediated rejection. So as I said that felzartamab is an anti-CD38 monoclonal antibody, and CD38 is a transmembrane glycoprotein that is expressed by immune and hematopoietic cells, particularly plasma cells and natural killer cells. And blocking the CD38 has emerged as a promising therapeutic target in antibody-mediated rejection, because when you block it, then it leads to depletion of plasma cells, which produce donor-specific antibodies, and natural killer cells, which are important in microvascular inflammation in antibody-mediated rejection. So felzartamab is an investigational fully human IgG1 monoclonal CD8 antibody that depletes target cells. So this was a phase 2 randomized double-blinded placebo-controlled trial, and they included patients with AMR that had occurred at least 6 months after transplantation, and they had 2 arms, the felzartamab versus placebo. The primary outcome was the safety and side effect profile of felzartamab, and the secondary outcomes was renal biopsy results at 20.52 weeks, the DSL levels, peripheral natural killer cell counts, and donor-derived cell-free DNA levels. The 222 patients underwent randomization. The median time from transplantation until trial inclusion was 9 years. They found that mild to moderate infusion reaction occurred in 8 patients in the felzartamab arm. Serious adverse events occurred in 1 patient in the felzartamab arm and 4 patients in the placebo arm. Graft loss occurred in 1 patient in the placebo group. At week 24, resolution of morphological AMR was more frequent in the felzartamab arm of group of 82% compared to the placebo group, only had 20% of resolution of morphologic AMR. Median microvascular inflammation molecular score reflecting the probability of AMR and the level of donor-derived cell-free DNA was much lower in the felzartamab arm as compared to the placebo arm. So they concluded that felzartamab had an acceptable safety and side effect profile in patients with AMR, and treatment with felzartamab did not result in complete ablation of natural killer cells, which is very important as well. And there were no substantial increases in the frequency and severity of infection-related complications. And however, of course, this was a very small study, so bigger studies need to be done to assess the efficacy and safety of felzartamab. This was a very important trial that, although slightly older, looking at eculizumab and splenectomy as salvage therapy for HLA-incompatible kidney transplantation. This was basically done at Johns Hopkins Hospital, and what they included 24 patients who experienced severe AMR from the 267 who had undergone kidney transplantation from 2003 to 2012. This was the definition of antibody-mediated rejection. So in addition to plasmapheresis and intravenous immunoglobulin, which is the standard of care, 14 of these patients received a splenectomy, 5 received eculizumab, and 5 received a combination of both. And eculizumab treatment was continued until DSL levels reduced or AMR resolved on biopsy. 21 of the 24 patients also received rituximab, and all patients continued on the standard of care for immunosuppression. So what they found was that antibody-mediated rejection in these high-risk patients was diagnosed at a median of 6 days post-transplant. Graft survival was, at 1 year, was 100% when you use splenectomy and eculizumab. It was the lowest with eculizumab at 30%, and splenectomy alone achieved graft survival of almost 80%. So all grafts were lost or had transplant glomerulopathy in the eculizumab arm, and overall the combination treatment group showed better outcomes with higher graft survival rates and lower rates of transplant glomerulopathy. So what they concluded was that plasmapheresis, IVIG, and anti-CD20 was ineffective in rescuing the grafts in patients who had got severe antibody-mediated rejection. Immediate splenectomy can rescue most kidneys from undergoing severe early oliguric AMR, right, because splenectomy removes the antibody-producing cells, while eculizumab protects the endothelium from injury. And combination of both results with 100% rescue and 1 year graft survival. There was a lot of hype about the proteasome inhibitors, and that was the reason why the BOCHECK trial was done, which was a randomized trial of bortezomib in late antibody-mediated rejection in kidney transplants. And however, they did not show any benefit of bortezomib in slowing down the progression of graft dysfunction due to late antibody-mediated rejection, and its use was associated with significant toxicity, especially neurotoxicity, and there was no between group differences in regards to measured GFR, urinary protein, DSA, or incidence of rejection in the 24-month mark biopsies. So what they concluded was that bortezomib as a proteasome inhibitor was ineffective in treatment of late ABMR and was associated with significant toxicity. So another way of improving our supply of organs or kidneys is basically to use highly sensitized patients. But the question is, what do we use to desensitize them? So imlifidase, which is an immunoglobulin G degrading endopeptidase of Streptococcus pyogenes, IDES, is a unique molecule that basically breaks down only IgG and into two parts, the FC portion and the FAB portion. So it basically eliminates anti-HLA IgG. It doesn't cleave IgM. It cleaves the IgG type B cell receptor, inactivates therapeutic antibodies, and this provides a window of opportunity for HLA incompatible transplantation. So this was a study that was basically carried out in two centers, one in the US and the other one in Sweden, and they basically used HLA incompatible patients, and IDES was administered 4 to 6 hours prior to transplantation. Patients additionally received horse ATG or alemtuzumab, and the patients in the US also received IVIG and rituximab as per the protocol. And DSA monitoring was continued up to 180 days post-transplantation, and indication biopsies were done as needed, and protocol biopsies were carried out at 6 months. So they enrolled 25 highly sensitized patients with a median PR of 96%. And what they found was that imlifidase resulted in reduction of circulating IgG, and this effect persisted for up to 28 days. All patients experienced complete or near complete reductions of HLA antibodies at 6 hours post-transplant. In the US cohort had less patients with rebound, most likely because of the concurrent use of IVIG and rituximab. So 3 out of 11 patients in the Swedish group experienced AMR at a mean of 2 weeks post-transplantation, with biopsies showing higher CD4 positivity. 2 of 14 patients in the US cohort experienced AMR detected at a mean of 5 months post-transplantation, and renal function was acceptable in both the cohorts. 1 patient in the US group experienced hyperacute rejection, likely due to non-HLA antibodies. So the findings from this study indicate a notable decrease in IgG, HLA-Allo antibody, and DSA levels after treatment with imlifidase, and it can be used to reduce the burden of DSAs, allowing transplantation from an HLA incompatible donor, and then subsequently we can use our immunosuppressive protocols to basically suppress the immune response against the rebound antibodies. Carfilzomib is a second-generation proteasome inhibitor, and this was a trial which was basically looking at carfilzomib-based desensitization. So the bortezomib trial basically was a failure, and because of its neurotoxicity. So carfilzomib, as I mentioned, is a second-generation irreversible proteasome inhibitor that is an ex-oxyketone non-boronated agent. And the irreversible nature of carfilzomib has led to a more profound and long-lasting proteasome inhibition, and the avoidance of boronation has substantially improved the toxicity profile of carfilzomib. So this was a prospective non-randomized iterative adaptive trial of carfilzomib-based desensitization. It included highly sensitized patients with positive cytotoxic cross-match, moderate to strong positive T or B cell flow cross-match with confirmed DSAs and PRAs of more than 30%. They had 2 groups, Group A and Group B, and both groups received carfilzomib. And after the last dose of carfilzomib, patients underwent 3 sessions of flex on days 47, 49, and 51. And serial HLA single antigen B testing was done. In addition, Group B received flex once weekly before carfilzomib. And they had 16 patients enrolled in the study, and 13 patients reached the primary endpoint, 6 in Group A and 7 in Group B. What they found was that the safety profile was similar to bortezomib. Neurotoxicity was not observed with carfilzomib as was seen in the bortezomib. Toxicity resulted in permanent dose reduction in 1 patient, and the toxicity was basically the leukopenia, but did not result in withdrawal or death. HLA antibodies were substantially reduced with carfilzomib, and median maximal immunodominant antibody reduction was more than 70%. And they also found that on bone marrow studies that almost 70% of plasma cells were depleted after carfilzomib therapy. After depletion, there were rebound of the antibody levels, and they returned to baseline between days 81 and 141. So what they concluded was that carfilzomib monotherapy-based desensitization provides an acceptable safety and toxicity profile while leading to significant bone marrow, plasma cell depletion, and anti-HLA antibody reduction. So this was basically looking at the drugs that we have in our armamentarium. Xenotransplantation is another way of basically improving the organ supply. And because of the shortage of organ donors, xenotransplantation has come into the limelight, especially more recently, as a sustainable alternative. However, the risk of rejection is much higher for obvious reasons. Now, pigs are widely considered to be the most suitable for xenotransplantation due to their anatomical and physiological similarities. However, concerns for zoonotic infections cannot be ignored. So we know that interspecies molecular incompatibilities can trigger host immune responses against the xenograft, leading to hyperacute and acute rejections. And there's also the risk of transmission of porcine enteroviruses and retroviruses and other xenogenic infections as well. So there is research into genetic editing technology that has allowed mitigation of all of these responses. We know that hyperacute rejection is mediated by natural antibodies that is possessed by both humans and non-human primates against the xenoantigens. A significant proportion of these circulating immunoglobulins are the anti-alpha-gal natural antibodies, making A-gal the most critical xenoantigen. Interaction with the natural antibodies with the xenoantigens causes complement activation and the MEC formation, which basically leads to graft injury and graft failure. So if you can eliminate the alpha-gal xenoantigen, it prolongs the survival of pig to primate xenografts. Acute humoral xenograft rejection is mediated by the non-alpha-gal natural antibodies, which include your anti-SDA and your anti-U5GC natural antibodies. And these preformed anti-HLA antibodies can also react with the swine leukocyte antigens and can aggravate acute humoral xenograft rejection. And this can be reduced by eliminating the non-alpha-gal natural antibodies. So the major viruses of concern are your porcine cytomegalovirus and porcine endogenous retroviruses. So while the porcine cytomegalovirus can be easily eliminated by early weaning of piglets, the porcine endogenous retrovirus remains unsatisfactory. The treatment of porcine and endogenous retrovirus remains unsatisfactory. And strategies like use of pig breeds with low or no porcine endogenous retrovirus expression, use of ARVs, and development of anti-P porcine endogenous retrovirus vaccines can be adopted. However, it should be noted that in vivo PERV infection of human cells has never been reported in all of those studies that have been done. So the timeline of xenotransplantation has really been going on since 1960s, but it is more recently, in the past 5 years, that it has taken off quite well. And more recently, of course, we all know that in March and April 2024, there was the US FDA approval for compassionate use of xenotransplantation for 2 of the patients that was successful. Unfortunately, both the patients died, and one of them was not related to the transplant or kidney failure. This was a study that showed the results of 2 cases of pig to human kidney xenotransplantation, and these were patients who were brain dead, and luckily the families consented, and the renal xenografts obtained from genetically modified alpha-1 pig galactocell transferase knockout pigs, and they had the porcine thymus implanted under the renal capsule approximately 2 months before the organs were obtained. It basically helped to sustain or reduce the risk of rejection. Okay. So once when the procedures were done, the urine output was measured from the xenograft as well as from the native kidneys, and immunosuppression was achieved only with methylprednisolone and MMF. The kidney function was estimated using the kinetic estimated GFR, and serial biopsy specimens were also analyzed as well. And the 2 transplantations were carried out, the first set in September 2021 and the second in November 2021. And after implantation and reperfusion, both xenografts begin to make urine within minutes. As you can see, the kidney turned pink. And the eGFR increased from 23 to 62 after transplantation for recipient 1 and from 55 to 109 for recipient 2, and they had excellent urine output as well. And the biopsies, serial biopsy did not show any evidence of hyperacute rejection. So what they concluded was that after transplantation of alpha-1,3 galactosyl transferase knockout pig kidneys, it resulted in doubling of the estimated GFR and immediate urine output. Hyperacute rejection did not occur. And this possibly could have been because of the addition of the thymus autograft under the renal capsule. And the risk of your porcine endogenous retroviral infection appear to be quite low even in this study as well. As I mentioned, that this was took the world by storm, and the xenotransplantation was carried out in living recipients, and it actually was a success, but unfortunately we lost both of these patients. So what is next? So if FDA approves the clinical trials, the xenotransplantation will go through several phases. One, to determine the safety and identify the side effects of the procedure, measure effectiveness and further study the procedure's safety, confirm effectiveness, monitor side effects, and compare the standards of treatment. And of course, there's also other aspects to look into it, especially the religious aspects and cultural aspects, which are now being discussed at all the major transplantation meetings, including the one that just recently got concluded in Turkey, in Istanbul. So unfortunately, despite a lot of research being done into this and a lot of medications coming into the market for transplant, a lot of them did not stay for long, mostly because of the risk of more infections, risk of more malignancies. Some are given intravenously, like pelatacept, and they're very expensive, especially the IDES or the Imfides is quite expensive. So the ideal is not, immunosuppression is not yet found. Now, shifting gears and looking at the new biomarkers in kidney transplant, we have the donor-derived cell-free DNA, the gene expression profile, and the urinary RNA profiles for the diagnosis of rejection. When you look at the donor-derived cell-free DNA, we know that allograft cell injury leads to an increase in your donor-derived cell-free DNA in the bloodstream of the recipient, which can be measured, and this can tell us whether this patient is basically having allograft injury or not. In the 3 clinically available assays, so it has potential benefits, but also pitfalls, such as the presence of both the donor and the recipient DNA. So it will be difficult to know whether it's coming from the donor side or whether it's coming from the recipient DNA as well. It is useful for the diagnosis of antibody-mediated rejection, but it can't be used for patients with T-cell mediated rejection. Gene expression profiles have been shown in both urine and blood and can be used to detect kidney transplant rejection. TrueGraph is a blood gene expression classifier in the field of kidney transplantation. It was significantly better detecting cellular rejection as compared to your donor-derived cell-free DNA. So this is a major advantage that the gene expression profiles have over the donor-derived cell-free DNA. Urinary exosome mRNA signatures for rejection is another very exciting field, and this was an excellent study that was done, which basically looked at bulk urinary exosome analysis for patients who already had rejection, and they compared it to the urine of those patients who did not have rejection. And they basically they managed to basically isolate the specific signatures for messenger RNA in those patients who had rejection. And this basically will help to identify these patients earlier without necessarily having to do any invasive procedures. In conclusion, there have been a lot of developments in the domain of kidney transplantation, but it is yet to translate into clinically significant graft outcomes, both short and long term. And with persistent demand for organs and changes in the demographics of the donor population, smarter ways to use the current supply are needed, and prolonging the long-term graft survival is important to reduce the numbers of patients going back on dialysis. Thank you very much for listening. I know it's exceeded my 20 minutes, but I hope this was useful. Thank you very much.
Thank you for listening to the presentation. In this session, we've learned various aspects of transplantation, so it will be very interesting to hear from a patient who was transplanted. Can we welcome Marjorie Jonker? Oh, you stood there. Okay, thank you.
Good day, ladies and gentlemen. I am privileged for the opportunity to speak to you today. When my doctor first informed me that my kidneys were failing and that I was needing a transplant, I was overwhelmed with emotions. How does one respond or react to this type of news? The questions raced through my mind. Am I going to die? Am I dying? Why me? Why did this happen to me? Before I continue, I must mention that I'm a diabetic. On January 6th of this year, I marked the 30th anniversary of being a diabetic. I was told that my kidney failure was a consequence of my diabetes. Despite my diligent efforts of managing my sugar levels and through my health and through proper diet and exercise, this was an incredibly challenging period, filled with uncertainty and fear. Yet, I had the support of family and friends. In October 2018, I learned that I needed the transplant. My cousin is a kidney donor, organ donor. She was tested and found to be a match. My cousin was my donor. Her willingness to donate her kidney was a profound blessing. But the journey was far from straightforward, not knowing what roadblocks were waiting for me. When it came to choosing between hemodialysis and peritoneal dialysis, I opted for the PD option. For its convenience and the comfort of my tongue always starts with that word, of dialysis at home. I was fortunate that my medical aid covered all the necessary expenses without hassle, as these treatments are incredibly expensive without a good medical plan. I had the financial support throughout my whole journey. However, when my transplant date came closer, my work situation added another type of struggle, of difficulty. My employer at the time, a doctor, gave me notice due to my extended absence. Since then, finding suitable employment has been a struggle, despite being well qualified. On January 17th, 2020, I underwent my kidney transplant. The first of the year, and just before the onset of COVID-19. The surgery was successful, and I was eager to return home after 3 weeks in hospital. I got to see the outside world again. Unfortunately, after a few weeks at home, I fell ill and was readmitted to hospital with an infection. Then the COVID-19 pandemic hit, and the world went into lockdown. No visitors were allowed, and while I had support from outside and from the hospital staff, the isolation was hard, lonely, and depressing. My family and friends would leave treats for me at the hospital entrance, which was a small but cherished comfort. I was constantly in and out of hospital with infection. Then, on June 4, 2020, the day before my birthday, I was admitted again, this time with sepsis. I was close to leaving this world. I wanted to give up. I could not handle what was happening to me anymore. All the needles, all the drips, all the tests. I just wanted to go home, but my doctor and my parents urged me to keep fighting. They reminded me of how far I had come. A PET scan revealed an abscess on my spleen, leading to the removal in another surgery. I spent a month in the hospital. Once again, it was a hard, lonely, and depressing time, being trapped in a room without any visitors from the outside. I was admitted to hospital several more times after my spleen was removed. Eventually, with an amazing support network and many prayers, I regained my health. In 2021, inspired by my own experiences, I founded a charity, Ava Second Chance, dedicated to supporting individuals with kidney disease. I named my transplanted kidney Ava, which means life. In honor of my cousin's selfless gift, I was given a second chance on life. Ava Second Chance, in partnership with Q Kidney Care, aims to provide a support network, raising awareness and assist kidney warriors in need. Though still a small charity, our mission is to grow and support as many people as we can. Living with kidney disease involves daily struggles and challenges that few truly understand until they've faced them themselves. In 2020, I endured 9 hospitalizations. In May 2022, I broke my beautiful small foot in 3 places. When my foot healed, I broke my knee. When my knee healed, I broke my tiny ankle. All in all, I had 7 operations on my left leg. I never had an operations before for breaking a bone. This happened because of my bones that got brittle, a side effect of the medication that I am using. Now I'm on osteo medication. I had an X-fix through my leg and ankle for about 9 months. The day the X-fix was removed, while I was lying in theatre on the operation table, my heart briefly stopped 6 times in 40 minutes for 4 seconds each. Despite these hurdles, I refuse to give up. I remain hopeful, resilient, and positive, fueled by faith and hope and endless prayers. We as kidney warriors are being labeled as sick human beings. This has a profound impact on our well-being, but a kidney transplant does not define a person's identity. Being labeled created barriers for me in personal relationships, which was maybe a good thing because I lost friends that I thought were my friends. In social settings and especially in the workplace, it is a real struggle to get proper work that you are more than qualified to perform. Because when it is mentioned that you had a transplant, you are suddenly removed from the shortlist and not suitable for the job anymore. Having experienced this a few times made me doubt myself, my self-worth, am I good enough? Because I have all the qualifications, experience, and capabilities to do great work. It is difficult to get past these struggles and shift your mind to positive thoughts and not to give up. The journey of being a transplant warrior is a continuous challenge. I made the decision and promise to myself when I heard that I have CKD, that I will not sit in a corner to succumb to self-pity. That is not who I am and who I want to be. It has been nearly 5 years since I had my transplant. I am stronger, happier, learned lessons from every challenge I had to face, and I am deeply grateful for the love and support that surrounds me. My name is Marili, and I'm proud to say that I'm a kidney warrior. Thank you for your time.
Wow, Mariori, thank you so much for sharing your journey with us. We often, as practitioners, just get caught up in the treatment, and we don't always hear the patient's perspective. I think it's just an eye-opener for each one of us. Thank you, Mariori. That was very special. Colleagues, we've got some time for questions for either one of the speakers. Please feel free to raise your questions if there are any. Do we have any questions to any of the speakers? Thank you.
Thank you, Chair. I only have, I'm not sure if ever it's one or two questions for my colleague there, Daniel. Daniel, I know that in the previous years we've been using plasma exchange to, for treating antibody-mediated rejection. So for someone who doesn't know, what would you say if ever now you want to convince me to also go into immunoabsorption?
Okay, thank you for the question. It's a very good question. Yeah, regarding the plasma exchange, actually it is still a very good treatment, but it is not an ideal treatment for APO-incompatible kidney transplants. So we use the therapeutic plasma exchange if a patient's got like, the HLA's levels are high, and then now in that case you need to remove them. So normally patients undergo 5 treatments, which means we treat them every day for 5 days in a row, and then they actually exchange about 1 to 1.5 liter, rather 1 or to 1.5 plasma volumes. So it is still valid to do the plasma exchange. However, if we want to consider the APO mismatch blood transplant, definitely you have to do the immunoadsorption because of those few advantages I mentioned earlier. Thank you.
Thank you, Daniel. Are there any other questions? Just a question from my side, Daniel. Or actually 2 questions. How many of these procedures have you done so far? And okay, if you can answer that first.
All right, cool. I think for now we've done, this was based on a last year study that was published by Dr. Pate. For GSH we did 3, and then we read, this year we've done another 1, and then we expect to do another 1 in 2 weeks' time. So for now we've done already 4 of them.
Fantastic. And my next question is, I know it's early days, but what have been your graft survival rates so far?
No, it's excellent. Like, with some, they always say the best transplant is the one that is from the live donor. So we appreciate our transplant coordinators for organizing these transplants compared to cadaver, but also appreciate as well. They're also very helpful. So with them, I would say it is very, it is normal actually. There's no difference compared to other transplants that we had. All the patients actually recovered soon after the transplants. Not even one had complications that needed to have dialysis after transplant, or we never actually even needed to do immune adsorption after transplants. But also just to mention a few things, it will depend. Our patients in the public sector, they are quite young and also don't have many complications, so that's why we get all the best results. I'm sure if maybe someone also on the floor here, maybe Walter, from private might have a different picture, but in our case, because the patients are also quite good in the overall, so we never had any issues there.
Fantastic. I just want to commend you and the team at GSH for spearheading this procedure in the country, and keep it up. And I hope the results in the future will make the rest of us also adopt the same. So thank you so much. Thank you, Daniel. Thank you to Mariori. We've reached the end of our session. Enjoy your lunch. Remember, we've got 2 lunchtime symposia happening, one in the auditorium and one in room 8. So please enjoy your lunch, and then we'll see you back after lunch. Thank you very much, everybody. 1, 2. All right, so to all our e-poster submissions, we're going to commence. Please feel free to join us in front. We only have 3 e-posters. The one person didn't submit in time. So our first presenter will be Tebogo Malele. Just a reminder that we have a 6-minute presentation plus some time for Q&A if there are any questions. So please, can Tebogo please come to the stage? Following Tebogo, it will be Daniel, and then it will be Dr. Jardine. Thank you, Tebogo. Effective use. You are being assessed.
Yes, okay.
You are being assessed. So all we want, just some guidelines. All we want is just for you to take us through your slides. Tell us what it's about briefly, within 5 or 6 minutes maximum. The talks are being assessed as well, because there are prizes at the end of the Congress. That's correct.
Thank you. Good afternoon, ladies and gentlemen. My name is Tebogo Malele, as introduced. My poster presentation is on effective use of alternative funding models to increase access to South Africa. My supervisor was Professor Elmi Muller, and my co-supervisor was Prof. Razine Davis. The aim of my research was to explore financial barriers, public and private healthcare capacities, and existing policies affecting access to dialysis. If you can see on the diagram that's on the board now, I just basically indicated, trying to put everything in perspective, to just show you that South Africa's population is 59.62 million. And out of that 59.62 million, 15% are self or medical aid funded, while 85% of the patients are dependent on the public sector. And if we have to put in terms of the renal registry, in terms of treatment centers, 34 treatment centers exist in the public sector, while 262 facilities exist in the private sector. So if you look at the discrepancies, 85% of the population is dependent on 34 units, 34 centers in the public sector, while 15% of the population is dependent on 262 centers. I know the statistics, if you have to look at the latest ones, they've definitely changed. And if you had to look at the stats that are coming from the medical aids, they are also different. And another thing to consider is 50% of patients in need of dialysis are unable to access dialysis in the public sector. So the problem statement is to investigate effective alternative funding models and interventions that can optimize renal replacement therapy access for patients, specifically patients reliant on the public healthcare system in South Africa. So the objective was to identify how alternative funding models enhance access to renal replacement for patients in South Africa's public sector. Also to examine and compare various interventions, analyzing financial aspects and their impact on treatment, availability, and patients' outcome. Recommend to optimize these models for improved access to dialysis services for those with end-stage renal disease. The methodology that was used was qualitative research methodologies, which provided in-depth understanding of alternative funding models, experiences, flexibility, and motivations of funding and treatment institutions. And it was also investigating centers that are treating or funding patients with end-stage chronic kidney disease, basically patients that are on dialysis. The population was either a funding or a treatment institution which treated such patients which are in stage 5. The sample then became a focus group of 12 to 15 treatment center funding institutions that treat or fund renal replacement therapy for stage 5 CKD patients. The sampling method was non-probability sampling method, which selects the sample population in a non-systematic process. And the data collection method was secondary qualitative data comprising of focus groups, in-depth and interviews using unstructured questions. The results, so we ended up just interviewing 7 participants because we reached saturation. And out of the 7 participants, 6 were treatment centers, while 1 was a funding organization. Out of the 6 treatment centers, 3 were from the private sector, while 3 were also from the public sector. And if you have to look there on your left-hand side, I'm not sure if I'll be able to point. No. On the left-hand side, okay. It's not? Okay. If you look on the left-hand side, it just basically shows you the type of funding method, the source of fund, and the length of the funding that was available. And if you look at a lot of them, even the funding institution, you will see that everybody is limited mostly to 12 months. 12 months being the period that most medical aids then are willing to fund a chronic patient or pay for the chronic patient. And also with the funding institution, what was also what was the limit for them was that annually they could only take 16 patients, and out of those 16 patients, the patients needed to be sure that they'll be able to maintain the renal, they'll be able to maintain the the medical aid payments going forward. So the fundings were that the public sector's alternative funding requires self-funding in the long term and significant financial burden on patients, and there was also a significant financial burden on patients and their families. Private grants were often competitive and challenged to obtain and access, and self-funding was short-term, and as I explained about the 16 patients annually. So there's also this concluded that there's a strong link between alternative funding models and access to renal replacement therapy in South Africa. If you look on the bottom right there, you'll see that the private grants and self-funding, the patient's criteria differed, but at the end of the day, affordability for the patient was the big determiner on whether the patient is put on any of the alternative funding of the funding models. So a recommendation that came out of this study was that creation of collaborative platforms between the South African government and the private sector to improve the efficiency and effectiveness of the current healthcare is needed, and that the formulation of transparent and sustainable alternative funding models is needed, and also improved procurement processes, because a lot, especially the public sector, have complained a lot about procurement processes that barred them from increasing their numbers that they could fund or they could assist in their units. Increased investment in disease prevention, which is something, even from the environmental guys yesterday when they give their presentation, also affects the environment. So it's good that we are recommending that we need to, we are recommending that we need to increase our preventative with the aim to address ethical concerns and ultimately improve access to life-saving kidney treatments. In conclusion, there's definitely a need for more sustainable, coordinated, and integrated approaches towards a comprehensive funding model for renal replacement therapy, because currently, as I've indicated previously, over half of the patients that need dialysis are not able to access it. So there's an emphasis on an urgent need for sustainable, coordinated funding models. Thank you very much.
Thank you, Tebogo, for that. Just a comment. that in our unit where we work, Dr. Jadine as well, we've got a collaboration between our hospital and the private sector. And it's working quite well, but it took a while to get there. It takes lots of effort convincing the hospital and then, of course, the government as a whole to actually fund these patients. But once it gets going, I think it's very effective, and it does relieve a lot of the burden of the public hospital as well. So it's definitely something that has to be considered, I think, more broadly, but it definitely does work. Thank you so much. Our next speaker is Daniel Maweli. Welcome, Daniel, my ex-colleague from Tygerberg, at the moment, currently from GSH. So Daniel, thanks. Just take us through your slide.
Good afternoon. Thank you once again for this opportunity. So this is going to be a very brief presentation that shows the relationship between the bioimpedance spectroscopy device given weight, often call it BCM weight, and the blood pressure of the patient. I don't know, just double check with the guys on that side. I think I've got a presentation with 6 slides, just to verify that. Thank you. So we're first going to look into the relationship between the post-dialysis weight of the patients and the normal hydration weight. So the normal hydration weight, we obtain it from using the BCM machine. So that machine, what it does, it actually checks for the hydration status of the patient. So this is the correlation graph. As you can see, by the shaded area there, it marks the 95% confidence interval. And then that straight line, diagonal line, it is actually the correlation line. So what you can see there is that the weight at which the patient comes off after dialysis is quite similar to the weight that is actually given by the BCM. So in other words, even for any unit, if you want to do the auditing to check how well the patients are getting dialyzed, I would suggest that you need to check for correlation between their dry weights or their normal hydration weights, as well as the post-HD weights. Now I want to see the impact of patients reaching the dry weight. Does it make any difference in their blood pressures? So as you can see there, I put dotted lines, horizontal lines. The one on top there is a target systolic blood pressure. The one at the bottom, it is the diastolic blood pressure. And then I also used different genders, with females having a light red color and males having a green color. And then I'm also showing on the x-axis there, the post-dialysis weight. So I'm looking at 2 things here, the post-dialysis weights as well as the blood pressure after dialysis. If we just visualize this diagram, we can tell that, oh, by the way, the patients were selected on the fact that they arrived on dialysis day with high blood pressure, either systolic or diastolic blood pressure. So by seeing this diagram, or this plot, you can clearly see that even after dialysis, the patients had very high blood pressures. There's very high systolic, extremely going up to 200, diastolic also above 80. So in other words, that one, the blood pressure is not so well controlled by just only reaching the dry weight. We have to consider some medications for the patient. So normal patients don't take medication before dialysis, so expect that blood pressure to be a bit high. But then for those that got very, very high blood pressure, we recommend that they should actually take their medications even on the day for dialysis. So we also looked at the other impact of the BCM on the patient's clearance, KT over V. So in this case, we use the 2x2 table. As you can see there, we use the exposure as being female. So we recorded those that are having poor adequacy of dialysis using single pool method versus those that are having good dialysis, single pool KT over V. So we use the 2x2 tables, and we find that the odds are like this. The females was 82% less likely to have poor dialysis or poor adequacy of dialysis compared to males. So in other words, females, they tend to have a good clearance or better clearance compared to females. So also what we noticed is that the females actually reached the target dry weight after dialysis compared to males. Males were actually at least 1 kilogram on average above that dry weight even after dialysis. So, and also males had higher weight than the females in overall. But there is another poster that we'll see probably at some point that's got more details in terms of the methods and findings. But just in a nutshell, we can see that BCM helps us to see if patients can achieve their dry weights, and it is good to compare their dry weights with the weight that they achieve after dialysis and see if there's correlation. And also it is good to check the adequacy of dialysis and see if the BCM guided dry weight helps us to achieve a good clearance. Thank you. Okay, lastly, just on that diagram, you can just visualize like the same thing that I already explained. Thank you.
Good afternoon, and thank you very much for the presentation. And without any more waste of time, our next speaker will be talking about evaluating the impact of an educational I've lost the presentation. Oh, it will be the impact of an educational video on the knowledge of South African patients undergoing dialysis for the treatment of kidney failure regarding the use of their health data. The presentation will be done by Dr. Jardine. Dr. Jardine, yeah.
Good afternoon, everyone. Thank you for the opportunity. We know that the South African Renal Registry is important. It really gives us a snapshot into the state of kidney replacement therapy in our country. All countries should have a renal registry where possible. And it tells us also about access to kidney replacement therapy, as Prof. Davids spoke about earlier. But at the same time, we acknowledge that there's a growing acknowledgement that patients need to be aware about how we use their data. We need to be transparent and open about how we use their information. And so for this study, we really wanted to evaluate educational videos as a tool for improving patient literacy about their health issues and the use of their health data. And we decided to use their knowledge about the renal registry for this particular study. So really, it was divided in two parts. The first part of the study was designing the video. And if my memory serves me correct, this actually took longer than the actual interview component of the study. So through an iterative process, we designed an educational video and redesigned it based on known, sort of well-established data about adult learning. And then the second part of the study was then to go interview patients before and after showing them this video and to see whether their knowledge about how we use their data improves. So I won't give you too much jargon and information about the methodology, but just to know that it had a quantitative part, so a numbers part, and it had a qualitative part. And we used a pre and post test design. As I said, we interviewed before and after the video, and the patients included those undergoing chronic hemodialysis at a public facility, Tygerberg Hospital, as well as patients at NRC Goodwood. And we showed them the interview, or rather we interviewed them at different time points before being shown the video, 1 hour after, 1 week after, and then 1 month after, to see whether there was any gain of knowledge and how long it lasted. And as far as the statistical analysis, I won't go into that. We used repeated measures ANOVA and post-hoc pairwise t-tests for multiple comparisons, describing mean differences and 95% confidence intervals at each point in time. So I'm just going to go straight into the most important data. If you look at the table on the top left, you can see these are the patient's interview scores before the video, at 1 hour after, 1 week and 1 month post-video. And as you can see quite clearly, there is an improvement in the average sort of interview score from 57 or 58% rather to about 73% at 1 hour. And importantly, whether you look at the table or the figure at the bottom, this gain of knowledge was actually maintained over the subsequent week and month. In terms of the qualitative data, these are some quotes from the patients. One said, "It gave me a clear idea about what is done with my health data. They thought it was easy to follow and understand. Health data is kept safe and private." And they recognized the societal benefits of the renal registry and the way that we use their health data as healthcare workers, that there's obviously significant benefit to not only themselves but society at large. So to conclude, it seems like a good idea to use educational videos to support patient literacy about how we as healthcare workers use their data. Thank you for listening.
Well, thank you so much, Dr. Jardine, for that. I think in the past we used to use brochures and papers, and people don't read. I mean, if you look at ourselves, I don't like to read papers, but on a video, I'll watch a video. So it's definitely, I can imagine why it's so effective for our patients. It's definitely something we can implement. So I'm not sure whether there are any questions to any of our speakers. We have an opportunity just for 1 or 2 minutes, 1 or 2 questions. Please feel free to ask, or any comments on any of the talks. Yes, Doctor. Just hold on, Daniel.
Okay, thank you. So our inclusion were all patients that had high blood pressure on the day for dialysis. So if got like high blood pressure, let's say systolic of more than 120, diastolic of more than 80, you were included, regardless of how much you've gained. Cool.
Okay. So it wasn't everybody that was included in your
No, only
study.
those with high blood pressures, because wanted to see the effect of the PCM in controlling blood pressure, and then among the same cohort as well, see if there's any improvement in their clearance, KT over Vs.
Okay. Are the BCM something that you do routinely, or?
Yeah, definitely, we do it every 3 months, and then what we did on the same, like we do it like a week. After a week, then we take the blood samples, the 3 monthly blood samples. Then on the day of dialysis, also check blood pressures before and after and in between. So I took those details quite close to each other to maintain accuracy.
Sure. Okay, thank you, Daniel. If there are no other questions, I'm not sure, David, anything from your side? Okay, thank you so much, guys, for your submissions, and we appreciate your time.
Thank you.
There's still some time for lunch, so please enjoy. Thank you so much. Of who?
It's fine.
Not-
I'll
not
take
me.
with Jonathan.
Not me.
I'm going to take with Jonathan.
Thank you.
Dr. Mputi, are you not
Tata,
coming?
come on,
Are you not coming, Tata? How can you are going to retire and then we wanted a picture of you?
Yes.
trip around the sun, round the sun, round the sun, round the sun. Faster it goes. Let's get it now while we are young, while we're young, while we're young. Red River stole my heart again. Red River, you stole my soul again. It's headed in the soil, it's basking in the moon. Your waters flow down the Gulf of Mexico, the Appalachian, through the whole damn southern nation. You take it slow, just enough to let the snow melt below the mountain. Not a shiver, you warm the cliffs and stone. You deliver life to these dried up bones. Islands in the fog, they're basking in the moon. Your waters flow down the Gulf of Mexico, the Appalachian, through the whole damn southern nation. You take it slow, just enough to let the snow melt below the mountain. I'm trying to put you in the West mood. People cleaner than the churches. Really point to just to hurt you. All bad just to tease you. None of these toys on the list too. Made you, yeah, in a week too. Made bitch out of your league too, yeah. Side bitch out of your league too. So what do you need to send a piece? 20 racks a table cut from ebony. Cut that off and read skinny pieces. Since you clean up with a face, man, I love my babe, my babe. Talking about you need to hear me. You talk about me, I don't see the shade. Switch up my style, I think anything. Switch up my cup, I kill any pain. Somebody brag big, legend of the fall, took the year like a bandit. My mama a crib and a brand new wagon. Now she hit the grocery shop looking lavish. Star Trek roof and the Wraith of Khan. Girls get loose when they hear the song. 100 on the dash, got me close to God. We don't pray for love, we just pray for cause. So what do you need to send a piece? 20 racks a table cut from ebony. Cut that off and read skinny pieces. Since you clean up with a face, man, I love my babe, my babe. Talking about you need to hear me. You talk about me, I don't see the shade. Switch up my style, I think anything. Switch up my cup, I kill any pain. never gonna be. You get what you pay for, that's how it's always been. The world is a minefield, better watch out where you go. But if you wait, the sun will shine. The morning might be late, but that's alright. If you wait, the sun will shine. The morning might be late, but that's alright. Live in the moment and be all you can be. Just like the ocean, you're more than what they see. If you keep on going, life will give you what you need. You can't change the weather, so take it how it comes. A brand new horizon is there for everyone. Just do what you do, what you do will soon pay off. But if you wait, the sun will shine. The morning might be late.
No, Shamin, just. Thank you. Good afternoon, everyone. Please make the following. We just need to give you some house rules. Please mute all your cell phones. Please scan your CPD QR codes once a day. Your QR codes are available at the registration desk and at the exhibition hall. Discovery are accepting walk-ins for the wellness checks in the exhibition foyer. You do not need to be a Discovery member. It's open to everyone. You can have your creatine check done opposite the Discovery station in the exhibition foyer with the scientific group and the NHLS. Delegates who are booked for airport transfers for tomorrow, you can leave your luggage at the main hotel reception, and the transfer pickup point will be at reception. Our CSSA members are invited to join us at the AGM this evening at the same venue at 17:15. So our next session is on nutrition and treatment management, and our first speaker is Mareka Pinar. She's a registered dietitian from Johannesburg, and her topic is fiber usage and protein wastage in dialysis patients.
Good afternoon, everyone. Oh, sorry, okay. So just from my point of view as a dietitian for the renal process, we are going to pack in a lot of information in a short period of time, especially with fiber, smaller things that can be quite impactful to your patients in the unit. So of course, our primary focus as a dietitian or anyone that needs to look after our patients dietary-wise in the units is that we need to make sure that our patients at the end of the day has good quality life, and this is all about compliance. We all know this, but unfortunately our roles in the dietary units have exceeded or started making more of a broad spectrum, and this will include that we need to start focusing on things like your albumin, urea, your protein, energy, malnutrition, hypertension, edema, anything that we can focus on. Now today I'm specifically only focusing on the fiber aspect and new aspects that came in with the hyperkalemia. Sorry. All right, so if you look at the basic, it's what we've got with our food groups. Your first thing that we're focusing on these days, and this is for the fiber can have quite a big impact within our patients, especially with our protein energy wasting, and then, of course, chronic inflammation, metabolic bone disease. I'm not discussing today for the phosphate. I had to squeeze in quite a lot of information. At the end of the day, all that we need to try and do is to slow the progression of our patients and still provide them with a good quality life. Traditional renal diet principles that we've always implemented, of course, we've always split our meats 50-50, more high biological value. We are going to limit our milk products, and we're going to focus more on our egg. We were concentrated more on your refined carbohydrates. We would limit all of our fruits and veggies. We would try and add energy. And of course, eventually your plate would lead to something like this, absolutely very minimal fiber on the plate. So if we then have a high refined starch diet, low fruits and veggies, we found that eventually, because these patients are not getting in fiber, there's less alkalinity in the diet, so there's more metabolic acidosis, and a decreased fiber will, of course, go into your constipation, thus increasing potassium, which we'll start discussing now as well. Because we also had a diet that was low in plant-based protein and more in high biological value protein, you would find that there's more acid, leading to a higher metabolic acid rate, decreased fiber, constipation, which we'll show now what impact that can make onto your dietary patterns, increased potassium, and then, of course, the precresol sulfates, indoxyl sulfates, TMAO increasing within the diet, which we'll discuss, decreased short-chain fatty acids, and an increase of organic phosphate. These two usually led to the more of your increase of your metabolic acidosis, decreasing albumin, increasing your risk of protein energy wasting, and increasing your metabolic bone disease. This would also cause decreased antioxidants and increased free radicals in your patients, and gut dysbiosis, all increasing to the increased permeability of the intestinal wall, which we'll show now. All of these led to our patients just having a higher inflammation risk, causing your cardiovascular calcification, of course, metabolic protein energy wasting, and all of this leading more to your patient at risk for death. So we need to reconsider a complete paradigm shift within our diets, and this is where the new guidelines come in. So Medscape interview, diets for patients with CKD, what's best, and now if you want to go read this up, this is where the new beginnings of your plant-based diets in 2019 started showing up. As a dietitian, we seldom went back to the actual literature to look for well-designed randomized control studies to look at the influence of a diet in the CKD patient. I just assumed, just made an assumption and relied on the previous accurate information everyone does, that plant-based protein, phosphorus, and potassium are bad. We need to go back and do a lot more research to begin to change the dogma, peel back the onions, layers, and then find the pockets of patients with CKD who do well on more liberalized plant-based diets. So where the study came from, or why we are being restricting potassium in our patients, was actually in the 1960s. So when they did implement the potassium guidelines, they started off with a 20-gram protein total intake diet. Despite the relatively low potassium contents of these diets, there was still hyperkalemia within these patients. Regardless of the cause, the treatment included potassium restriction of 1,000 milligrams per day. So it was restricted without any real evidence why we needed to restrict it. Both then and now, the target of high potassium foods is based on the assumption that all dietary potassium is therapeutically equivalent. So the recent studies have shown in a cohort study that there was basically found that the association between dietary potassium and serum potassium was extremely weak. So furthermore, they also found that the association between the potassium from the dietary and the serum potassium was also there was no basically correlation between those. So for potassium, I know I always get called in when the patient does have high potassium as a dietitian so that we can start controlling it. However, if you look at this diagram pooled, the only factors that I personally as a dietitian can do anything about with the potassium or hyperkalemia is dietary modifications and looking at metabolic acidosis. So it's not necessarily the diet that's related to your patients with hyperkalemia. So the main study that came out in 2016, which basically opened Pandora's box. Although up to half of your hyperkalemia episodes in our hemodialysis patients are attributed to constipation in your foods, it is more a direct link towards the constipation than the diet itself. Now I'm going to show you guys also why that is happening. Alrighty, so if you have to look at your intestinal gut, of course, whenever we do have potassium and there's extra potassium, one of the ways that the body does get rid of the potassium is through the stool patterns and, of course, through the urine. If your urine, or of course, CKD patients, we don't have effective urine output anymore, the body has to find a different way of pushing out things. And one of the ways that the body can do that is by increasing the loss of potassium through your stools. Constipation is common in both of your hemodialysis patients and, of course, your patients that are going through peritoneal dialysis as well. Slow fecal transit time along with intestinal tract favors potassium absorption. So now if your patient's, of course, constipated, your body that's trying to push more potassium through the stools are now reabsorbing it back into the system. This can also cause cramps as well from the potassium. So this suggests that the constipation instead of your potassium dietary load is the main determinant of hyperkalemia in your patients with CKD. So the management approach of hyperkalemia in patients, of course, is more increase the excretion of potassium through loop diuretics, and of course medication bound basically more. Removal of managing ongoing contributors to hyperkalemia, comorbidities, medications, and lastly, diet and constipation. So we understand that it is mainly the restriction that we've always focused on these foods, but maybe we should shift our thoughts on maybe looking at constipation and then less restricting our diets. So normal kidney function, only 2% of your potassium is related or excreted through the gut. If your GFO starts decreasing, as much as 15 to 20% of your potassium can be secreted through the colon. This is a compensatory mechanism that increases basically over time to start helping protect you. In end-stage renal patients, the potassium from colon can increase substantially up to 35% if we can just stimulate stool output. So to help normalize the potassium, the present opportunity of a colonic binding, and of course the potassium via medications. Alrighty, so this is where we now start getting exciting. Alright, so if you have to start looking at the dietary or just your amino acids, potassium's trying to get excreted through the body now. This is mostly because where the potassium and the urea is binded together now. Urea, of course, when it's going to be excreted through the kidneys, 80% of course can be excreted, and only 20% when your kidneys are working will be excreted through the colon via the feces. If your kidneys are not working, the body can be quite amazing and it can start going over to pushing at least 100% of the urea can start pushing through the colon. And of course, thinking of this now, if we're going to start pushing more of your acidic urea into the colon, you're going to start getting a bit of a disturbance within the gut fecal load as we are irritating those bacteria. This will just increase to more ammonia. Of course, pH in the colon starts increasing. If your pH in your colon starts increasing, the patients are going to start getting the enterocolitis, where the patients will start getting heavy diarrhea, bloating, cramps, pain, decreased intake of food as well. Now, this increased interluminal of pH triggers the overgrowth of bacterial species, favoriting the proteolytic fermentation regarding more uremic toxins or creating more uremic toxins. Now, we'll go into more detail with this now. While outnumbering the protective species such as lactobacilli, favoring saccharolytic fermentation, you are going to have your gut dysbiosis, which is one of the main contributors also to your patients' inflammatory states. So concentrating on the microbial community within the gut, of course, we know there's quite a large amount of bacteria in the gut. So why can't we use this then to our advantage instead of our disadvantage? Functionally, the gut microbiota provides nutrients and energy to the body through fermentation, non-digestible foods in the large intestine. It contributes to the digestion mainly through two catabolic pathways. Your saccharolytic fermentation and of course and proteolytic fermentation. One is good, one is bad in a short sense. So your colon is always going to have good and bad bacteria and kept in balance. Of course, a diet rich in carbohydrates supports basically your better lining within the stomach, so that will be the saccharolytic fermentation. A diet that's high in fat and high in protein is going to cause more of your bad bacteria growing over and causing more of your proteolytic fermentation. A complex bidirectional relationship between the gut microbiota and the kidney does exist in the physiological conditions. A type of substrate influence microbial composites, so metabolic and immune functions. As we said, now we're starting to eat food. These foods that ends up in the colon can either stimulate saccharolytic or proteolytic fermentation. So if we've got the good fibers coming in as well, we're going to have that the gut is stimulated with a saccharolytic fermentation. Saccharolytic fermentation keeps the epithelial tract and barrier inside of the gut intact, and it also prevents the translocation of endotoxins and live bacteria from the gut lumen into the bloodstream. The kidney deals with microbial metabolites, of course, and the rest will usually be excreted out if there is any urine. Now, because we don't have a lot of urine excreting anymore, we now have a decreased saccharolytic fermentation, therefore decrease in short-chain fatty acids, or just your short fermentation within the saccharolytic fermentations. You have an increase in proteolytic fermentation, and then an increase of your indoxyl sulfates, your precresol sulfates, and TMAO. These, of course, are kidney unable to excrete microbial metabolisms because we can't urinate. And eventually, this disrupts, it's basically an acid, if I always think of this. If there is more proteolytic substrates, it will increase the urea within the gut, and this will cause a disturbance in the gut lumen. Now, the gut is always there to help and protect us as much as we can. If we are going to have dysbiosis within the gut, meaning more uremic toxins, we are going to have the gut broken, or the epithelial cells broken, and the T-junctions that break, meaning that these indoxyl sulfates or these toxins directly go right through the epithelial cell, entering the bloodstream. If there's more toxins in the blood, this will adversely affect your patient's inflammatory state. This can also lead to your infections or reoccurring infections. Now, just as a short clip of where all of these or your proteolytic or indoxyl sulfates come from, when we eat proteins, of course, these get broken into your shorter proteins, which will be more your indoxyl sulfates, precresol sulfates. That's where they come from, and these are from your high biological proteins that we eat, basically. So, to shift this whole paradigm, we need to start relying more on our plant-based proteins. Plant-based proteins, of course, are going to stimulate your saccharolytic fermentation, and of course, dietary fiber is going to stimulate your short-chain fatty acid productions, which protects the gut. So increasing dietary fiber in our diets is going to help decrease the dietary acid load. We're going to have more vitamins and minerals coming in, so of course we're going to have more antioxidants. Colonic activity, we've got more stools going out. We're going to have better saccharolytic fermentation, meaning there's going to be more short-chain fatty acids, which is going to directly help with your insulin sensitivity. And your proteolytic fermentation also helps with the insulin sensitivity and decreasing of your inflammation and oxidative stress, all leading towards the decrease of cardiovascular disease and infection. So this is basically just a summary if anyone wanted to take a picture of it, but it's basically just the difference between your proteolytic and saccharolytic fermentation, where your plant-based dietary profile can have a much higher impact within your patient's gut. So, increasing fiber then, however, and this is where we need to make a shift. We've always believed if we're going to add more fruits and veggies to our patient's diet, they are going to have a higher potassium intake. However, what's now been shown that we know that potassium or the foods are not the main cause of the high potassium. So if we are going to start increasing more fiber into our diet, for each 10 grams per day that we increase dietary fiber in our diet or into our patient's diet, there is already an odds that the inflammation decreases by 38% in our CKD patients. So if we're going to add more fiber into the diet, of course, we're going to have a decreased dietary acid load, decreased metabolic acidosis. This will help increase the albumin synthesis, increase your muscle protein synthesis, thus less protein energy wasting. Metabolic bone disease, increase insulin sensitivity, decrease hypertensive neuropathy, and decrease kidney injury. If we're going to have more of your antioxidants, and because we're not eating that much animals, proteins anymore, we're going to have a decrease in the indoxyl sulfate and the precresol sulfates, decreasing the oxidative stress and decreasing inflammation. Also, because we are increasing our short-chain fatty acid productions, we are decreasing our patients' cholesterols, decreasing urea, decreasing creatinine, meaning there's a little bit of a higher chance of the GFR picking up again, and of course an increase in insulin sensitivity, and of course an increase of your stool frequency as well. So there's two ways to go about it. Of course, we can go dietary, but you can go medication as well. This is what we did a few years ago in Laratong Hospital. We provided our patients just with a simple sachet. Back then, I used to use Spasmopep. For now, I mainly used either fiber gel or the Dufalac that we use quite a lot in government sector as well. We have found that at least if you want to start with the sachets, you always start with one sachet. They can start off one sachet 3 times a day, or alternatively, just one sachet per day already makes a big difference, as long as we can just get to that 10 grams per day increase, or just an increase in it. The next step that we can do is try and encourage our patients to start eating more fiber. Now, these are mostly the main fiber foods that they've asked us that we can start including more into our diets. This includes beans, peas, and lentils, where previous years we had to avoid the beans for the phosphate and the potassium. However, because of the fiber inside of the bean, the phytates actually holds on to the phosphorus. So the phosphorus bioavailability is much lower in these foods, where unfortunately with your animal proteins, the phosphate reabsorption or bioavailability is still very high. Of course, another guideline that's changed with our fiber and with our potassium. The first thing, we do not need to tell our patients that they must completely not eat these foods anymore. They can't touch a banana, they can't touch these foods. Instead of doing this, we can now tell our patients safely they are allowed these foods, but in smaller amounts. So instead of having the entire tomato, try and encourage them to have a few slices, and this is just going to cause your patients also to feel a little bit happier that they can actually have a bit wider variety in their diet. This is an example for just how we also in our unit started encouraging our patients that they can really start eating more fruits and veggies in their diet as well. On your, left side, that is just an adapted shisheba recipe. Now, usually, when we do make shisheba, it's usually, I think it's about 3 onions, a few peppers, and then a lot more tomatoes. Where in this case, we're now going to encourage our patients, they can have tomatoes, but 1 tomato, more onions, more peppers over it. Otherwise, another example, we've always told our patients that the morojo and those things cannot be eaten because of the potassium content. However, it's not as much true at the moment now, so they can have it, but they need to be creative with it. So now they can still leach their potatoes, but add more of the carrots, more peppers, more onions, and then instead of having a much greener plate, you still have that, but just less of the green in the plate. Thank you.
Thank you, Mareka. And we would like to call our next speaker, Mariam Sattar. She's a clinical director at VNA Placement Agency and a professional medical staff placement agency in Johannesburg. She's going to be talking on diabetes management in the dialysis unit. Thank you.
Good afternoon, everyone. Thank you, Mariki. That was really, really interesting. And I think you helped me with the diet education in my mind. Okay, so. Oh, okay. So this may be just a refresher for some of you. I'm just going to go over it. Okay. So we all know that diabetes is the leading one of the leading cause of kidney damage. You can see I got a picture on top there that says the normal kidney and the diabetic kidney. So that is how it looks. Okay. I'm just going a little bit about the stages of diabetic nephropathy. With regard to hyperfiltration, it increases the blood flow and the pressure in the kidneys, causing a bit of kidney damage. We have microalbuminuria, small amounts of albumin protein in the urine, and we have macroalbuminuria, where large amounts of albumin are in the urine. There's renal insufficiency caused by decreased kidney function, and the 8th stage, renal diseases causes complete renal care. So how do we do this? How do we try to prevent or slow down the processes? And we know some of the important thing is for patient education. Okay. So what's important to do is your glucose monitoring. And besides this, keeping this in the back of your mind, you must always remember that your patient education is very important because they need to understand the disease in order to follow your guidance and your advice. So with regards to blood glucose monitoring, you need to check them at least 3 times a day before and after dialysis. Some patients frequently go into hypoglycemia during the dialysis stages, so you need to keep checking their glucose in between as well. And then also, you need to follow your hypoglycemic protocol in the unit should they go to a hypoglycemia. They must keep within the ranges of 4 to 8. I think it has changed by now. And education and rationale. So your patients are either controlled by oral medication or insulin. So you need to give them you need to educate them why the difference is between your oral and insulin treatment. And then you need, when you're educating them, you need to focus on the risks that speed up kidney damage. So by them understanding this, then they will keep a more glucose control at home. Because remember, they just stay with you for a few hours, or some of them stay for 1-2 days, and that type of education is not enough to take home. Okay. Diet and education, nutritional support, and Mariki has covered this very nicely, and we see that we can educate them to have the stuff that they have been, we've been campaigning not to have anymore. Okay. Okay, physical activity, exercise, passive exercises for those that have limited in mobility, walking, just walking around the block, walking around their complexes or walking in their street will help them to maintain their circulation. And then they need to have regular clinical assessments by their physician. Okay, bad habits, we need to encourage them to discourage them in smoking and alcohol and explain to them why these are so important as increasing their kidney damage and sending them quicker into chronic renal disease. Okay, and weight management, diet control and exercise, this will help them greatly. And our favorite one, infection prevention. So you are the one that's also preventing infection in the clinical unit. And just remember that this is not limited to you. It's also to the patients, because sometimes you find that it's them that's passing germs amongst their bodies. So it's washing of hands, use of PPEs amongst you guys, sterile cleansing of ports, and using of sterile dressing. Don't take shortcuts. And then also educate your patient on maintenance of personal hygiene, because the most common type of infection they get is UTIs. Patient education. you need to understand which level, so each patient is individualized in your unit. You need to understand which level of kidney function they are at the moment and inform, and when they go to GPs and when they go to other doctors, they need to be able to speak out and tell the doctors that haven't seen them before, like where are they in their kidney function and what's their disease process at the moment and what medication they are taking. They also need to avoid regular use of non-steroidal anti-inflammatory drugs like your ibuprofen, and because these cause massive scarring of the kidneys. They need to be careful on your investigation procedures like your bowel preps, using of the milk of magnesia when they have the colonoscopies done. And always double check with the physician or pharmacist, whatever they're taking is not having a drug interaction with them, causing them to go into further kidney disease. And encourage them to ask for help. So if they don't know and they are not, and they are scared to ask them. The more questions they ask you, the better they are. And also taking of supplements. So they must not take over-the-counter supplements like your regular vitamins and stuff. Rather check with the physician if they are able to take these supplements. Okay, thank you. And what I omitted there is the foot care. So they need to have their foot checked up on a regular intervals, okay? And footwear, many of them can afford these ortho shoes and stuff. And wound care, taking good care of their ports and educating them on the signs of inflammation and making them aware on how they can prevent such infection from occurring. Let's see. Okay. And nail care is very important, so also advise them on how to cut their nails and just to prevent them from getting more infection because of the diabetes that causes lots of foot fungal growths when they are incorrectly cutting them. Okay, thank you. We're going faster. It's on time. It's on time. Doctors.
Thank you, Miriam, for your informative talk. Our next speaker is Shamini Govender, who's going to be who's from Durban University of Technology, and she's going to be talking on pain management of patients with chronic renal failure.
Good afternoon, everyone and colleagues, and thank you to the organizers to afford me the opportunity to speak today about pain management of patients with chronic renal failure. This is the presentation of my layout, so we're going to go through each of the sections and I'll be speaking on each. So pain management is highly complex in patients with chronic kidney disease because there's a very narrow margin between pain relief and toxicity. Opioids can accumulate in the body and cause adverse effects such as respiratory distress. They are multidimensional causes of pain. For example, from the kidney disease itself and the dialysis procedures. Pain has consistently shown to negatively impact health-related quality of life and can lead to other symptoms such as depression, cramps, and headaches. The aims and objectives of the study was to investigate the types, frequency, and severity of pain experienced by patients with chronic kidney disease and to suggest strategies that patients and staff could utilize to manage the patient's pain experience. A total of 60 patients and 22 staff participated in the study, and the questionnaires were administered in the dialysis center. Patients of all genders and race was included. The patients required to be cognitive in order to provide informed consent, and patients required to be on dialysis for more than 6 months. The appropriate ethics approval was obtained from the Durban University of Technology, as well as the relevant gatekeeper permission was obtained. Medical records of the patients were analyzed, as this provided a rich source of information, particularly relevant to pain management, and this was analyzed, for example, the analgesics used, the types and frequency of pain reported both on and off dialysis, and this was scrutinized for 3 months. A qualitative research approach was utilized as it aims at understanding and interpreting the meanings and impact of this given phenomena experienced by the sample population. In this study, the pain experienced by the patient is subjective as they attach meaning to it. For example, if it is unbearable, they may discontinue the treatment or limit the duration of the treatment. This qualitative research paradigm refers to research that elicits accounts and meaning, experiences, and behaviors. And the use of this research methodology therefore enabled me to obtain a more holistic understanding from the data elicited. Some of the results of the study was that patients were on average 57 years of age and were all on hemodialysis. And this study showed that 98.3% of patients reported pain symptoms during dialysis, and for 72.3% of patients, the pain experience was moderate to severe, indicating that pain is a major symptom burden in this patient population. The most frequently reported symptoms were lower back pain at 80%, lower leg pain at 51.7%, and upper chest pain at 46.7%. Pain was frequently experienced by patients following the dialysis session at 78.35%. Between 53.3% and 65% of patients reported pain whilst walking or climbing stairs. Patients in the study had substantial comorbidities, with 26.7% reporting hypertension, diabetes, and cardiovascular diseases. Therefore, the causes of pain are multifactorial and makes management of it challenging. It is startling that depression was experienced by 85% of patients in this study. In the severity of pain experience resulted in 66.6% of patients hospitalized, and 86.6% stated that pain affected their ability to have a restful sleep. When this is seen in conjunction with the fact that 78% of patients responded that their pain impacted on their ability to work, one can see the distinctive link that pain adversely impacts their functional status. This study explored the different types of phenomena experienced by patients without any manipulation and control of human behavior, therefore enabling me to obtain a greater understanding of the patient's experience and impact on their quality of life. In addition, specific objectives focused on how the patients managed this distress and discomfort they experienced and how it reflected on their decision-making regarding treatment of the pain experienced. The use of the questionnaires, due to the paucity of information within South Africa on this topic, led to an exploratory design for the purpose of asking questions in a structured manner and seeking insights to grow the current body of knowledge on this under-recognized problem. It is evident from the results of the study that pain management was not undertaken in a strategic manner, nor was it tailored to a patient's specific needs. For staff, there were no formal clinical pain management and assessment instruments or follow-up regarding adherence to recommendations for pain analgesics, and both patients and staff would benefit from awareness about different types of pain management therapies, both pharmacological and non-pharmacological, and the long-term impact if pain continues to be underdiagnosed and undertreated. And this is to just bring some form of comfort to patients experiencing this debilitating types of pain. Focus attempts regarding patient and staff education about theories can be initiated. An assessment of pain management in patients with chronic kidney disease can assist the staff to make decisions about analgesic use for patients. Furthermore, the proposed methodologies would allow patients to benefit from appropriate interventions and manage their pain. One needs to be cognizant that dialysis patients do face significant financial burden, including the cost of the medication and the dialysis itself. Investigating staff and patients' perception about pain management provides a deeper insight on a range of pain-related issues, so that renal healthcare professionals can better understand the impact of pain from a patient's perspective. This study is an attempt to contribute information to the general body of knowledge with regards to pain management in patients with chronic kidney disease, particularly within a South African context. Notwithstanding some of the limitations of the study, it did reveal valuable insights that will inform centers' practice on a daily basis. This is some of my publications. This one is related to the pain management in patients, and this is a few more of my publications. I did attach my ORCID ID should anyone wish to follow what my current publications are and any future publications as well. My email address is attached to my ORCID ID should you want to contact me for any further collaborations as well. And I would like to also acknowledge my supervisor, Professor Jamila Adams, and my co-supervisor, Dr. Afzal Khan. Thank you so much.
Thank you, Shamini. Good afternoon, everybody. My name is DJ, and I'm going to be introducing the next speaker. The next speaker is Virosha Ramkalawan. She works at Nkosi Albert Lutuli in KZN.
Good afternoon, everyone. I see my background was covered during many sessions throughout the Congress. We've been speaking about diet, staff shortage, as well as private sector versus government sector, the public sector, and the amount of patients we have, okay? So I'm only presenting a part of my study. This is one of my first manuscripts. And then, because it was a mixed method study, so I'm doing my qualitative aspect, okay? So it's on recommendations to improve management of chronic kidney disease at primary healthcare settings and community level in KwaZulu-Natal. Chronic kidney disease is a growing global health issue, with KwaZulu-Natal, South Africa, experiencing an increasing prevalence. Risk factors include HIV, diabetes, and hypertension. Improved prevention, detection, and treatment measures are needed to reduce cardiovascular disease and CKD stage 5 progression. Approximately 20% of patients receiving dialysis in South Africa are from KZN, and the province has the second highest number of patients on dialysis therapy. CKD often begins with non-specific symptoms or asymptomatic individuals, leading to diagnosis at CKD stage 5. Complications like anemia and fluid overload emerge later on. Caregivers should identify self-control strategies to help patients manage CKD, while nurses and doctors aim to alleviate disease burden and provide comprehensive health education. However, a multivariate gap hinders implementation, leading to late-stage diagnoses and strain on tertiary institutions. SA's kidney replacement therapy is limited to 20% of patients only, emphasizing the importance of early detection and prevention of CKD stage 5. SA needs to prioritize early detection and prevention of CKD stage 5, as postponing diagnosis can worsen the condition by 40%, increase disease, increase cardiovascular events, and increase the need for kidney transplants or long-term dialysis by 63%. However, in sub-Saharan Africa, early identification of high-risk individuals remains poor, with 3/4 of adult patients dying due to the late entry and poor quality and high costs. The purpose of the study is to improve CKD management in PHC settings and community levels in KZN by identifying key factors that inhibit the implementation of guidelines in the management of CKD in the early stages. Once these factors are identified, policymakers can develop strategies to close these gaps, thereby limiting the burden of this disease at tertiary healthcare institutions. The study was brought upon due to the high influx of patients in advanced stages of CKD at tertiary institutions. These statistics was extracted from the electronic health record, which was thereafter populated on the ClickSense business intelligence tool. I've heard quite a few AI lectures. Okay, so this is the background of the study. You can see the different stages, the coding there. Stage 1, 2, 3, 4. There's some unspecified, and then stage 5. Okay, on your extreme right, those are the patients. Stage 5 is 861, whereas at stage 3, it's only 290. Then when we're looking at our visits, it's 9,000 at stage 5. Okay, and then we talk about crash landers. They are coming in stage 5. Just last month, there was a patient that came in, stage 5, requiring dialysis immediately. Where is the time to even create access? And we know we need to create an access at what stage? Stage 4, we plan for access creation. Okay, so this is a representation of those figures. The research objective is to describe the perceptions of healthcare professionals on the management of CKD and to explore guidelines adopted in the management of patients with CKD at PHC settings in KZN. The study was conducted at 4 different settings, a tertiary institution in Durban and 3 PHCs across KZN, 2 urban centers and 1 in a township. Okay, a qualitative, exploratory, and descriptive research design was followed for this manuscript. Okay, it was also purposeful and convenient sampling. The semi-structured interviews was used, and open coding and conventional content analysis was adopted. Okay, the researcher strived to meet Lincoln and Cuba's 1985 criteria for trustworthiness, ethical considerations, ethical principles was adhered to, and ethical approval was sought at various stages, from the municipalities, from BREC, as well as the KZN Department of Health and Research Ethics Committee. Three overarching themes has emerged from the study. The first theme was knowledge and awareness of healthcare professionals about existing guidelines. 2 categories emerged here: awareness of existing guidelines, lack of knowledge about existing guidelines. The subcategories were implementation of current guidelines and do staff possess the required knowledge to implement current guidelines. Some of the quotes were: we conduct urine testing using the Jacquard assessment tool. Assessment for edema, we measure patients' weight, we give dietary education, we do bloods. Creatinine levels every 6 months for diabetic and hypertensive patients yearly. For HIV patients, we monitor them 3 monthly. 4, if they are on antiretroviral treatment. At a different institution, I think, as I say, these guidelines on dialysis is already at tertiary service. So I think from the primary setting, one should look at how much screening and prevention should be emphasized. Now, this is, if you look at the guide, and maybe we need to look at it, although we cover some screening, just like small chapter on that. So in terms of the portion that's advocated is very small. So it doesn't cover adequately the setting of, especially in the clinics, dialysis you will get at maybe in a regional hospital. Definitely, that is why we need another one, at least more comprehensive guidelines, a document that you have seems to be the primary aspects. The second theme that emerged was fragmented system and lack of clear guidelines. The category emerged here was uncoordinated care, subcategory was clarity of roles. A few quotes. There's nothing actually written down for me to say who I refer to. Do you understand? So I will really appreciate something like that. Yeah. We do urea and creatinine bloods, health education, and dietary education. The last theme was implications of clear guidelines on patient care. The category here was clear guidelines, improving patient outcomes, and the importance of clear guidelines on the workup for patients into the chronic kidney disease program. There is a program for all patients that have chronic kidney disease, and they undergo a screening program to be onto the transplant list. So some of the quotes here was, the sooner the patient is caught, it will be better for the patient's family, PHC, and hospital, and a much improved lifestyle for the patient, especially the youth, nutrition programs, lifestyle, and dietary needs. If they do detect the stages earlier, if the monitoring process will be more efficient and educating the community about identifying risk factors, that will definitely reduce the rate at which the stages advances. Obviously, it's going to have, that will mean for me more referrals, obviously, because I will feel that we keep some of these patients, they stay in our system for some time, and some of them are supposed to be referred earlier, and then also then patients will have a better outcome if they are referred early. Discussions of the themes. Knowledge and awareness about existing guidelines. The study found that healthcare professionals' awareness of guidelines for CKD management varies, with some well-informed and others uncertain. They referred to KDIGO and the American College of Physicians guidelines, but noted discrepancies in adherence and understanding of their role in PHC setting. Fragmented system and lack of clear guidelines. Participants criticized unclear guidelines for CKD management in PHC settings, resulting in uncoordinated care. They reported screenings, blood tests, health education, and interventions, but lack of clarity on roles hindered effective patient management. Implications of clear guidelines on patient care. Participants acknowledged that potential benefits of updated guidelines in improving patient care and outcomes, emphasizing early detection, lifestyle modification, and comprehensive CKD management in PHC settings. They emphasized the need for early referrals, evidence-based treatment, and improved services. There's a few recommendations. Based on the findings presented, here are some of the recommendations to enhance the management of CKD in PHC settings in KZN. Guidelines, development, and dissemination. Create clear guidelines for managing CKD in PHC settings and community levels, ensuring accessibility and user-friendliness for healthcare professionals. Training and education. Provide healthcare professionals with regular training sessions and educational programs that emphasize understanding and using CKD management guidelines. This should enhance general comprehension and alleviate the disparities in knowledge among healthcare professionals. Interinstitutional collaboration, encourage cooperation and communication between healthcare facilities in order to develop a common strategy for managing CKD. Encouraging best practices and experiences to increase the overall quality of care. Utilization of screening tools. Promote the regular use of screening instruments for early CKD detection, such as the JACLD assessment tool, to guarantee that healthcare professionals are competent in utilizing these instruments and interpreting outcomes, provide resources as well as training. Monitoring and evaluation, establish a method to monitor and assess compliance with CKD management guidelines. Frequent evaluations and audits help pinpoint problem areas and gauge how implementing guidelines affects patient outcomes. Roles and responsibilities clarification. Precisely articulate and communicate the roles and responsibilities of healthcare professionals across various levels of care. This necessitates establishing a meticulously designed referral system. Seamlessly transition healthcare services from PHC to tertiary levels. Community awareness programs. Implement community awareness programs to educate the public about CKD risk factors, symptoms, and the importance of early detection. This can contribute to the prevention of CKD and encourage individuals to seek healthcare services proactively. Regular review and updates. Establish a mechanism to regularly review and update in CKD management guidelines to incorporate the latest evidence-based practices. This ensures that healthcare professionals have the most current information in their daily practice. Promotion of multidisciplinary teams. Encourage the formation of multidisciplinary teams involving doctors, nurses, dietitians, psychologists, and social workers to provide holistic care for CKD patients. Clearly define the roles of each team member to ensure coordinated and comprehensive patient management. Resource allocation. Advocate for adequate resources, including staffing, equipment, and medications, to support effective CKD management in PHC settings. Ensure that healthcare facilities have the necessary resources to implement guidelines recommendations. The study highlights the necessity of updated recommendations for the care of CKD in PHC settings in KZN, with a focus on timely detection, customized interventions, and an all-encompassing strategy. It also draws attention to the knowledge vacuum in SA and calls for interinstitutional cooperation and educational programs by addressing these recommendations. Healthcare systems in KZN can enhance the quality of CKD management, improve patient outcomes, and contribute to the community's overall well-being. In conclusion, the study advocates for a concerted effort to bridge the knowledge gap, promote guideline adherence, and establish a cohesive and informed healthcare system that can adequately meet CKD patients' unique needs in PHC settings and communities. Only through such collaborative and proactive measures can the healthcare community in KZN optimize CKD management, thereby improving patient outcomes and reducing the burden of this chronic condition on individuals and the broader healthcare system. The limitations. The study was only conducted at public institutions in one province and cannot generalize its findings to all healthcare professionals managing CKD patients due to the staff shortages. Healthcare professionals were either unavailable and some were away from work for months at a time during the COVID-19 pandemic. The researcher is part of the multidisciplinary team. This may have influenced participants' responses. Bracketing was used to limit researcher bias. Okay. Thank you.
Thank you. We do have another speaker. Before I do introduce the speaker, just a reminder, please scan the QR code once a day for your CPD points. The QR codes are available at the reception desk and in the exhibition hall on the wall. Discovery are accepting walk-ins for the wellness checks in the exhibition foyer, and you do not need to be a Discovery member in order for you to participate in the wellness check. You can also have your creatinine check done opposite the Discovery exhibition in the exhibition foyer with the scientific group and the NHLS. Please, for RCSSA members, you are invited to join us for the AGM this evening here at 5:15. Our next speaker is Pendile Shlongwa from DUT in KZN.
Good afternoon, everyone, and thank you for this opportunity. The interest of our research was on the HIV-positive patients maintained on CAPD. These patients are assumed to be more susceptible to infections due to the burden of the chronic conditions when they compared to non-infected individuals. There's the prevalence of HIV infection and end-stage renal disease is still continuing across the globe. However, the introduction of highly active antiretroviral therapy has improved the factors that contribute to morbidity and mortality among the affected patients. The CAPD is the widely used treatment for kidney renal failure, especially in the low-resource countries like South Africa. In government sectors, the patients are maintained on CAPD because there's a limited slot for HD. Despite that the patients, that the CAPD is relatively cheap treatment, however, the patients, they get to have the dialysis at home where they save on the transfer fee to come to the dialysis centers. However, the infection remains the problem that leads to discontinuation of this treatment. There is growing knowledge for cytokines being associated with chronic conditions and the pathogenesis of human diseases. So we did a study of cytokines, interleukin-6 and transforming growth beta-1 in peritoneal fluid of HIV-infected and non-infected individuals. These cytokines are pro-inflammatory cytokines that plays important roles in the regulation of inflammation. The predictive value of these inflammatory markers for peritonitis in chronic inflammatory conditions of HIV infection and end-stage kidney disease may be of interest in patients maintained on CAPD. The functioning of CAPD depends on the survival and integrity of peritoneal membrane. This membrane is lined by mesothelial cells, which also regulates inflammatory responses in the peritoneal cavity. The upregulation of these cytokines may be associated with PD-associated peritonitis and are also implicated in the pathogenesis of HIV infection. The aim of our study was to determine the predictive value of IL-6 and TGF-beta-1 for peritonitis in HIV-infected in contrast to non-infected individuals. This study was conducted in the previously described effects of HIV infection on the management of renal failure among patients maintained on CAPD cohort study. This was a single-center study which recruited 70 HIV-positive and 70 HIV-negative patients maintained on CAPD. The participants were recruited from Inkosi Albert Lutuli Central Hospital and King Edward Hospital in Durban. During the study, the CAPD fluid was sampled from the functioning CAPD catheter. It was processed and stored at the Clinical Medicine Laboratory, School of Medicine, storage freezer at -20 degrees Celsius. This prospective study determined the PD fluid levels of IL-6 and TGF-beta1 in consecutively selected 18 HIV positive and HIV negative patients maintained on CAPD. These levels were measured with IL-6 and TGF-beta1 enzyme-linked immunosorbent assay test kits from Sigma company. The optical density of these cytokines were measured, and the level of significance was set at p less than 0.05. The descriptive data for all variables was expressed as mean and standard error of mean. These tests were part of the statistical package of social science version 25 IBM. In our study, we've compared the demographic, clinical, and laboratory data of HIV positive versus HIV negative patients. With the age, sex, urine outputs, as it shows in our table, and the peritonitis episodes, serum urea, serum creatinine, hemoglobin levels were not associated between the two groups. And in our HIV population, the CD4 count was 380.7, and the viral load was 1,214 copies. However, the serum albumin levels were significantly higher in HIV negative versus HIV positive participants. The unpaired t-test showed the statistical difference in serum albumin levels between the two groups, with a p-value of 0.0049. And then in our study, we also compared these two cytokines, IL-6 and TGF-beta1, between the two groups. And then the Mann-Whitney test showed no statistical difference in IL-6 between HIV positive and HIV negative participants, while the unpaired t-test also showed no statistical difference in TGF-beta1 between the two groups. We also performed the logistic regression analysis to associate IL-6, TGF-beta1, and other variables with PD-associated peritonitis. And as it showed in our table, the IL-6 and TGF-beta1 was associated with PD-associated peritonitis with our p-values less than 0.05. No association was observed in CRP, temperature, serum, white cell counts, HIV, age, sex, serum urea, CD4 count, and viral load. This study demonstrates a positive association of PD-associated peritonitis with IL-6 and TGF-beta1 among our participants. There was no association observed in IL-6 and TGF-beta1 between the two groups. Our results are consistent with the previous findings, reported higher PD fluid, IL-6, and TGF-beta1 levels in patients who experienced peritonitis when compared to those who did not experience peritonitis. Back then in 2003, OIMAC, they also reported the increased PD fluid, IL-6 levels in peritonitis versus non-peritonitis. In this study, the serum albumin levels were significantly higher in HIV negative versus HIV positive participants. These findings were consistent with the previous findings. We reported the lower serum albumin levels in HIV positive versus HIV negative patients. These data contribute to the clearer understanding of the association of cytokine levels with PD-associated peritonitis and association of albumin levels between HIV positive and HIV negative patients. I would like to acknowledge Dr. Benjamin, my supervisors from DUT, Durban University of Technology, and Dr. Kane Dlovu from Mediclinic in Cape Town, and Prof. Asunga from UKZN, and Inkosi Albert Lutuli. Thank you.
Thank you. Before I announce for questions, you can get ready to think. If you do have one, you can come to the middle. Just a reminder to please participate in our competition. Please take a picture and then tag us on Instagram and on Facebook. And please follow us on social media for the latest updates. Are there any questions for our lovely speakers? Yes.
Good
Please
afternoon.
introduce yourself.
Yeah, my name is Cedric. Firstly, thanks for the panel. I was just remarking to my colleague that at the rate that KZN is submitting, they are building themselves up as a center of excellence in nephrology. So thank you, KZN. Yeah. Ms. Pinar, hey, the dietitian, I've got a bone to pick with you. It's not beef, ne? I want to know the intersection between you relaxing our old rules, you know, because the way I grew up is you can be a little bit pregnant. So you guys are saying now, these things of woody banana, people now, they can eat a little. I'm not sure. Have you ever gone further and maybe find out that this democracies thing that you're saying, was there maybe to see if there's no episodes of patients coming as emergencies or something like that? I'm not sure, because I'm still a bit conservative in my thinking and patient counseling in terms of diet. I'm not sure. I would just like a link on that, because I was a bit
just testing
surprised.
it.
Thank you.
Absolutely. I think that was our fear from the beginning when they said we're allowed to now start giving these patients more of these foods, that there was a period that we needed to test it for ourselves, test your own theory, if this is going to work or not. From my point of view, what happened personally, when we did allow these patients to start having these foods, the first thing that we had to do was make sure that they understand it has to be a small portion. They can't just go and have as much as they want, which was our first concern, because now you're basically giving a child a pack of sweets and see what they're going to do with it. So, of course, that was the first concern that we had. However, when we started giving these patients more fruits, veggies that they know that they have to have, the patients started having higher stool outputs. And because of the higher stool output, they were losing more potassium in the interim as well. So I not freely let my patients eat these foods, but I really only now in my practice restrict these potassium foods when I do see that their potassium levels are high in the bloods. So that's the only time that I really restrict, but then I always try to also figure out, does the patient have constipation? If there's constipation, I'll first try and sort that out, and then I only restrict. But yes, that was my fear as well. And to say at least if the patient had stools, there was very little problems with patients actually following the diet. I had great success with it.
Thank you. Are there any further questions?
Good afternoon. Thank you to the panel for all these nice presentations. We learned a lot. Maybe can I ask about the pain management? If in our units, maybe we should make a protocol, and how often should you check the pain, like in the patients? Should we maybe like do the surveys? Like how often maybe would you suggest? That's the first question. I'm going to ask another one.
Yeah. Please, can we have both questions, and please introduce yourself. Is both questions for the same presenter?
No, for different presenters, and they are not related, perhaps. Cool.
Thank you, Daniel. Well, I think, this one was tailored to a specific unit, but, from the findings and the publications that have come afterwards, there is no given, like I stated, management of pain because it's so multidimensional. However, examining your patient's chart, I always, even lecturing my students in 3rd and 4th year, the most important discussion or conversation you can have with your patient is, how are you feeling? Because that is where you are going to find out exactly how they were from their last dialysis session, and if it's documented, because as I stated, the medical records were analyzed for up to 3 months. So if a patient is complaining, for example, lower back pain, and the doctor is just prescribing an analgesic, something needs to be done further, because then we'll need to, it's going off the topic of pain management, and we're going to be speaking about vitamin D, and looking at the whole nutritional aspect too of the patient. So it's also scrutinizing blood results. So I would think it's not even a given regimen. Daily check should be done. And that will come from our patients' charts. So yes, questionnaires can be developed. For my study, I used the McGill Pain Questionnaire, which was such a rich source of information for my study. And it's not out there questions, it's simple questions. How did you feel after your last dialysis session? Is there anything you would like to share with me? Is there anything that you would like to bring to the attention of your nephrologist? It's simple things like that, and it should be done, not in a scheduled time to say, you know what, we're going to do it once monthly, 3 monthly. It should be done on a daily basis. I hope I answered your question. Thank you.
Thank you once again. Regarding the study done by Pindile and the colleagues, thank you as well for the nice presentation. I'd like to ask maybe if it was an option only looking at the t-test, just to compare the two groups, because what I'm looking at, if maybe you look for future, maybe consider like looking at other covariates, for example, patients, gender, age, and other factors, like a number of factors to consider. And then we look at the odds of having elevated levels of IL-6, for example. Maybe it is better to consider using logistic regression in that way. Thank you.
Thank you so much, Daniel, for the question. So, in our study, we did compare the demographic, clinical, and laboratory data between our two groups. There is no association that was observed between the two groups. However, the generalization of our study, I will say, was limited by the small sample size and the fact that we only tested these cytokines from the PD fluid, whereby the other studies has reported the positive association from the serum samples. So I will agree with you that we do need more research that may focus on the factors that contribute to the preservation of the peritoneal membrane and the pathogenesis of HIV infection. where we can look at maybe the laboratory data, for instance, whereby we can see how it affects the creatinine levels and serum urea levels between the two groups, where we can look at the UF ultrafiltration rates as well. And there's a lot that we can look at, but as I'm saying once again, where it can focus on the factors that contribute to the preservation of peritoneal membrane pathogenesis of the infection.
Thank you. Are there any further questions? Okay. Thank you everybody for joining our session. We are going to be taking a break. During the break, please visit the Renal Care Society stand, come and say hi, and please register if you are not a member as yet. Thank you, and we will then meet again at 4:10. Thank you.
Is it too late now to say sorry? 'Cause I'm missing more than just your body. Oh, is it too late now to say sorry? Yeah, I know that I let you down. Is it too late to say I'm sorry now? I'm sorry. I'm sorry. Oh yeah. I'm sorry. Yeah, I know that I let you down. Is it too late to say I'm sorry now? I'm sorry. I'm sorry. Oh yeah. I'm sorry. Yeah, I know that I let you down. Is it too late to say I'm sorry now? I'll take every single piece of the blame if you want me to. But you know that there is no innocent one in this game for two. I'll go, and then you go out and spill the truth. Can't remember, say the words and forget this. Yeah, is it too late now to say sorry? 'Cause I'm missing more than just your body. Oh, is it too late now to say sorry? Yeah, I know that I let you down. Is it too late to say I'm sorry now? Not just trying to get you back on me, 'cause I'm missing more than just your body. Oh, is it too late now to say sorry? Yeah, I know that I let you down. Is it too late to say I'm sorry now? I'm sorry. I'm sorry. Oh yeah. I'm sorry. Yeah, I know that I let you down. Is it too late to say I'm sorry now? I'm sorry. I'm sorry. Oh, I'm sorry. Yeah, I know that I let you down. Is it too late to say I'm sorry now? Said for nothing. We would spend our nights in bed and think of all the times we fell in love, but it's all missing something. Was it all said for nothing? Still, you pulled me up from the ground, far from the sound. You lift me up and push me down, but I couldn't take it. It's a beautiful trust me, you're not alone. Don't know if you kept my number. Access shouldn't call each other. I know we said goodbye, but if I'm being honest, you're always on my mind. No need to claim access. I know it's been a while. My cells refuse to process that you're giving your love to somebody else. Who do you love now? Who do you love now? I don't hate this new girl you love. I just wanna be her when you press on her lips with your thumb right before kissing her. I am broken, I'm jealous of the way she makes you happier. Riding solo in my car, trying to know how you're feeling now. There is a ghost on the passenger seat, and I could get used of the way he haunts me. I know we said goodbye, but if I'm being honest, you're always on my mind. No need to claim access. I know it's been a while. My cells refuse to process that you're giving your love to somebody else. I don't hate this new girl you love. I just wanna be her when you press on her lips with your thumb right before kissing her. I am broken, I'm jealous of the way she makes you happier. Who do you love now? Who do you love now? Who do you love now? All my love on you, like I haven't had enough of you. All my love on you, yeah, you, baby. I know it sounds insane, I just met you, but you make me feel this way. I'm worth the while. I don't even know your name, but you make me blush, yeah. I know love is a game. You say you like me, and all of a sudden I'm your zombie. I follow instructions because your magic leads me. I lose all my conscience. You are my function, and now I spend all my love on you. All my love on you, like I haven't had enough of you.
make me nervous. I hate it, feeling this anticipation like I'm the one on trial. You're doing us a disservice. You know that I don't deserve this, calling me out each time. I know you like to get up in my head 24 hours, and I just keep questioning. I keep on wondering why. Wondering why I let you keep me wondering why. wasn't heart, it was reason. Wonder why it's not the same. 'Cause though I shut all the doors, you felt the storm in your bones. 'Cause though I shut all the doors, you felt the storm in your bones. There are signs it's the eye of a bad one, but I didn't wanna fear the worst. It's in your gut, which I trust over my own. I only wish I'd felt it first. 'Cause though I shut all the doors, you felt the storm in your bones. 'Cause though I shut all the doors, you felt the storm in your bones. Hit by my side. Oh, 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 but if you don't wanna get hurt, boy, you should go. I know that you like to be hit by my side. Oh, 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 but if you don't wanna get hurt, boy, you should go. Boy, you should go. I know that you like to be hit by my side. Oh, 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 but if you don't wanna get hurt, boy, you should go. I know that you like to be hit by my side. Oh, 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 but if you don't wanna get hurt, boy, you should go. Boy, you should go.
than the light. Together we ignite a fire in the sky. In my dark nights, you're my guiding light. My guiding light. My guiding light. With your voice, I found my favorite song. In your arms, I found where I belong. Our love shines brighter than the light. Together we ignite a fire in the sky. In my dark nights, you're my guiding light. My guiding light. My guiding light. Open up the curtain, let the light in. Reflected on the surface, the day begins. Open up the curtain, let the breeze in. Every day I'm learning my meaning. Like a floating bloom, finally there's some room for me to find my feet to the avenue. Following my compass, it will lead me there. Lead me to my purpose, why I'm here. Now I'm heading north to find my worth. I hope to God it will be there. I will crush this earth to make it right. Like a floating bloom, finally there's some room for me to find my feet to the avenue. I'm going down there, and this time I fear there's no one to save me. These all or nothing really got a way of driving me crazy. I need somebody to heal, somebody to know, somebody to have, somebody to hold. It's easy to say, but it's never the same. I guess I kinda like the way you number the pain. Now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, and then you pull the rug. I was getting kinda used to being someone you love. Now the day bleeds into night. there's no one to turn to. This all or nothing way of loving got me sleeping without you. No need somebody to know, somebody to heal, somebody to have, just to know how it feels. It's easy to say, but it's never the same. I guess I kinda like the way you help me escape. And now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, and then you pull the rug. I was getting kinda used to being someone you love. And I try to close my eyes when it hurts. Sometimes I'll fall into your arms. I've said it feels until I come back around. For now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, and then you pull the rug. I was getting kinda used to being someone you love.
Until your body sings, until it's a bird flying high up through the clouds, singing, hey now, this ain't the first. Feed the fire until your body aches. You can get what it's worth, like a siren to the sun, singing, hey
disappear. See you fading, but I can feel you near. Doing time in a haunted home, but I'm far away from letting go. Still I'm waiting for the signs to show. My head is numb and my heart aches, falling for you. My eyes dry out as I'm diving into the blue. I'm holding on to a love that I'm about to lose. My eyes dry out as I'm diving into the blue. It follows me wherever I go. Wanted so much more. It's killing me that you may never know. I don't wanna let you go. I don't wanna let you go. I won't ever let it show. I won't ever let you go. All for you. Never thought I would ever fall this low, but I'm still holding on to this fantasy. Oh, I'm still holding on to what will never be. I don't wanna let you go. I don't wanna let you go. I won't ever let it show. I won't ever let you know. Sounds like I'm down. Downtown buying round, sounds of lost souls in the background. So I'm merging without a sound. And imagine what it would be to be lost, not found. So I'm merging I try and unwind, instead I'm unkind. My eyes open wide, but I'm going in blind. I forgot the line, just give me a line. Imagine, imagine what it would be to see the signs. So I'm urging, I'm urging. Imagine, imagine what it would be to be lost now found. So I'm urging, I'm urging. I just know I'm fighting still. There's no way of knowing how long we'll hold on. Is there something past this though? You, am I losing you? Am I losing you? Oh, tell me, you, am I losing you? Am I losing you? Oh, tell me, there's no way to tell you how I really feel. I just know it all feels wrong. There's no way of showing what we could have been. We've been blind for way too long. You, am I losing you? Am I losing you? Oh, tell me, you, am I losing you? Am I losing you? Oh, tell me, oh, sunshine in an empty place. Take me to turn two, and babe, I'll make you stay. Oh, I can ease you off your pain. Feel you give me love again. Round and round we go, each time I hear you say, this is the rhythm of the night. The night. The rhythm of the night. This is the rhythm of my life. My life.
Not sure I understand this role I've been given. I sit and talk to God, and He just lays out my plan. My head speaks a language I don't understand. I just wanna feel real love, feel the home that I live in. 'Cause I got too much life running through my veins, going to waste. I don't wanna die, but I ain't keen on living either. Before I fall in love, I'm preparing to leave her. I scare myself to death. That's why I keep on running. Before I arrive, I can see myself coming. I just wanna feel real love, feel the home that I live in. 'Cause I got too much life running through my veins, going to waste. I just wanna feel real love, feel the home that I live in. 'Cause I got too much life running through my veins, going to waste. I just wanna, I just wanna, I just wanna, I
sweet child of mine. Oh, sweet love of mine. Oh, sweet child of mine. Oh, sweet love of mine. Oh, sweet child of mine. Oh, sweet love of mine. Oh, sweet child of mine. Oh, sweet love of mine. Where do we go now? Still I fall, 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 fall. Still I fall, 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 fall,
Good afternoon, everybody. Thank you for joining us on this session. It's our privilege. I am Stefani and Nozipo to chair this session. However, this is a first for us to chair a video session. So let's see how it goes. But just let's start with the following what do you call this? Housekeeping. Housekeeping announcements. Please mute all your cell phones. And I just want to remind you guys to have your CPD QR code scanned once a day. That's all you need. And I hope you have enjoyed your Discovery Wellness checkups. Are we all still healthy? Yes? Good. And then just a note that delegates that have booked the airport transport for tomorrow, please, you can check out at the hotel and leave your luggage at the main hotel reception, and the transfer pickup point will be at the reception for tomorrow. And then we just remind that all Renal Care Society members to be invited to our AGM right after the session at 5:15 this afternoon. So without any further ado, let me introduce you to our first speaker, who is Dr. Pradeep Mistry. It will be a recorded presentation, and both talks will be played one after the other. Dr. Mistry is a consultant vascular surgeon, President of Vascular Society of South Africa, VASA, and Vice President of the World Federation of Vascular Surgical Societies. And the first topic that he's going to talk about is catheters, the good, the bad, and the ugly. And the second one that will follow right after that will be the right access on the right patient at the right time. Enjoy.
Good afternoon. My name is Pradeep Mistry, and I'm going to be speaking to you today about perm caths, the good, the bad, and the ugly. Thereafter, I'll be chatting to you about choosing the right vascular access for the right patient at the right time. I'm unfortunately unable to be with you today, as I'm currently hosting a Vascular Society's meeting in Cape Town. I'm hoping that we would see you all next year. We will be hosting a special session for dialysis techs and nursing symposium in a meeting in the Western Cape in 2025, October, so save the date. So let's talk about renal replacement therapy and understand that for starters, that when your kidneys fail, you have a certain amount of autoregulation that needs to take place by an external source. Now, the kidneys have a key role in terms of regulation of minerals, red blood cell production, removal of toxic substances, pH balance, and auto-regulation of the blood pressure. Now, some of these roles cannot be fulfilled by dialysis option access, but dialysis does aid in terms of the pH and removing of the metabolic waste. Now, most of you are familiar with the dialysis circuits, and generally speaking, we are looking towards creating high flow, reliable access with low resistance and access that is accessible for multiple interventions. This would, for one to get effective dialysis, one will require up to 600 mils per minute flow of hemodialysis. This can be achieved via AV fistula, AV graft, or central venous catheters. So the focus of this talk is going to be largely over central venous catheters. Now, before we touch on hemodialysis catheters, one needs to know about peritoneal dialysis as well. Now, peritoneal dialysis does give patients options of having dialysis at home. and has relatively equivalent efficacy as compared to hemodialysis. Here, a catheter is placed in the peritoneal cavity, and a semi-permeable membrane in the peritoneal space allows for exchange of toxic waste products to be excreted through the system. This system is, however, not for everyone and has quite a few complications. These include sepsis, peritoneal sclerosis, output failure, and hernias. So when we consider hemodialysis, the good aspects of this is this gives you easy access to having hemodialysis with a single catheter placed in a central vessel. Now, these catheters, even though they are called permed catheters or tunnel catheters, can be used for long term, but these are not necessarily the best options for long-term dialysis access for all patients. Having this foreign object in your body is beneficial to most, but can have complications. Now let's look at the good aspects of these catheters. They're easy to place. They are placed under screening. They're generally used for short term whilst waiting for maturation of autogenous access or for during dialysis access. It can also be used during periods of transplant rejection or for peritoneal dialysis. And I'd like to refer you to the vascular access guidelines written by our society not too long ago, where you will see the roles and indications for the different catheters. So many patients are suitable for this, and this technique can be used for patients with sepsis, patients who have undergone complications for aneurysm repair of their fistulas, patients who are waiting for maturation, patients who have a limited life expectancy, and patients who have contraindications for AVFs, like congestive cardiac failure and pulmonary hypertension. We will speak about autogenous access a little later. So these catheters can either be tunneled or non-tunneled. The tunneled catheters are generally used as longer-term catheters, and the non-tunneled catheters are short-term catheters whilst in hospital. They have different designs, as you can see, and different shapes. They can be either curved or non-curved. There are catheters that can be heparin-bounded or silver-impregnated. Generally speaking, most of these catheters have no significant advantage over others when we talk about tunnel catheters. The insertion technique needs to be placed via ultrasound guidance and screening, and the access choice is generally the right internal jugular. Usually, if one performs this under ultrasound guidance and screening, the complication risks are less. However, patients can have complications such as arterial puncture and hematomas over the area. Other complications can include pneumothorax. Hence, it is essential to place these catheters under fluoroscopy in a theatre setting like this, which is a hybrid theatre, and a chest x-ray post-op is mandatory if you do not place these catheters under screening in a hybrid theatre setup. The technique, as I said, is preferably via the right internal jugular. However, left internal jugular, femoral, subclavian, and other access options in the vein can be used. It is important to note that the right internal jugular is the preferred area, as the catheter tract is the straightest as opposed to the left internal jugular. One should also think about that most people, being right arm dominant, will benefit from autogenous or graft access from the left side, having complications related to left side access can be somewhat of a challenge for future access creation. If you note the 3 arrows pointing downwards from the left side catheter which is placed, these shows inflection points where the catheters tend to cause stenosis of the vessels. This is a generalized kit or general kit in which one would expect to have perm caths packaged. They introduces split sheaths as well as wires for easy access and a metal tunneler to create the tunnel for the catheter. These procedures can be performed under local anesthetic or general anesthetic. Now let's look at what is bad about these catheters. Whilst they're very useful, there are complications attached. Now the complications, I mentioned a few earlier, but they can be related to trauma of insertion of the catheter as we're placing a catheter through a major vessel. So you could get bleeding for a major vessel. This can be minor or life-threatening and hence best be placed under ultrasound. A hemothorax or pneumothorax are complications that can occur, and this is when the lung gets compressed by either air or blood in the pleural cavity, resulting in decrease in air in the lung itself, and thereafter could result in a tension pneumothorax or a tension hemothorax. Hence the necessity to perform this under fluoroscopy, or alternatively ensure that you have a post-op chest x-ray. Other complications can be cardiac arrhythmias from wire irritation as the catheter is placed over the wire, also sensitized myocardium, and changes in ECG during the procedure. Air embolism is also a procedure possible as we're using large bore needles and large bore lines in order to perform this procedure. Other complications are more long-term, and this is vein occlusion. Vein occlusions can result in complications like superior vena cava syndrome, where patients present with facial swelling, neck swelling, and arm swelling when they have dialysis access. Now, the time it takes for someone to develop stenosis of the superior vena cava, innominate, and subclavian veins varies based on the vessel the perm cath has been placed. The right internal jugular is the preferred one, as it is the straightest path, whilst the left internal jugular would be second choice, third would be right subclavian, and then left subclavian. We generally frown about placing lines via the subclavian vessels as it decreases or increases the risk of complications related to arm access for future. If one had a choice, one would not want to use temporary dialysis catheters unless in an emergency situation where patients has previous catheter-related sepsis or patients are unable to have permanent catheters in the acute setting. But these catheters are generally stiffer and have higher mechanical trauma on patients, and are also associated with shorter times to thrombosis and occlusion of these the vessels they lay in. Hence, the time period where temporary catheters need to remain in vessels should be very short. And patients should not be discharged from hospital with temporary catheters. So other complications related to thrombosis are DVTs and pulmonary embolism and thrombosis related to catheter. Malpositioning is also a challenge, and management of all these complications may require changing of the catheter, thrombolytic agents where we dissolve the clot in the vessel, angioplasty, and possible replacement of catheters to different sites. Other complications are local, like infections, as you can see, catheter-related infection to the tunnel, and sometimes catheters that result in endocarditis of the heart, and hence the catheter will require to be removed and antibiotics, a patient being treated with antibiotics. Generally speaking, the relative risk of mortality in patients that dialyze with long-term catheter access is higher than patients that dialyze with AV fistula and AV grafts. Hence, it is best for patients to be treated with or dialyzed using fistula-first strategies where possible. When not possible, AV graft access. But the reality is most patients will have a tunnel catheter at some point prior to having AV fistula or AV grafts. It is important for patients with a decreasing renal function to follow up with their nephrologist in order to then time suitable access creation timeously in order to avoid long-term catheter use and to avoid complications related to catheters, as there are some ugly complications related to these catheters. Now we will look at the ugly complications where we see patients who have had multiple catheters or sometimes even short-term catheters which cause lots of facial swelling, arm swelling, and collaterals over the area. Here you can see a patient who has a subclavian occlusion and a SVC occlusion causing superior vena cava syndrome. Here you can see the angiogram showing total occlusion of the superior vena cava with no direct flow into the heart from the venous system on the right. For someone to have management for this, we will require getting a wire through the vessel, balloon angioplasty the vessel, and possibly stenting the vessel. Challenges with this could mean stenting a vessel from there to there, but then jailing the other side. Stenting can also result in complications such as stent fractures. Here we see a situation where it is extremely difficult to tell where the direct tract for that superior vena cava runs, and occasionally patients may have catheters inadvertently placed through the azygous system. Here the patient we received wire access from below, as you can see, and then wire access from above. With this through and through wire technique, we are then able to start sequentially ballooning up this access to a much larger vessel size over time, and then eventually stenting the lesion. In this case, it was safe to jail the other side as there was no proper flow coming through from the other side. And then this allows patients to have access on the upper arm or via a perm cath through the stent. Challenging part is these operations can take quite a long time. Patients can be at risk of all the complications mentioned earlier, and at the end, sometimes all you have to show for this is just another perm cath placed, like in this picture. This is an example of a patient with superior vena cava syndrome, and as you can see, the facial swelling and large AV fistula that has undergone aneurysmal change because of the high resistance caused by the superior vena cava. Once you are able to PTA and stent it, you can see her day one post-surgery having had significant reduction in her superior vena cava symptoms. Now, newer techniques do exist in terms of catheters, and today we have what we got a composite graft in a catheter called a hero graft or a superhero graft. And these are cases where you can place an AV graft in the upper arm connected to a catheter into the chest. So the graft runs in the upper arm. This is the cannulation area, and as long as you can get a wire through and balloon dilate the superior vena cava in this area, you can then place a catheter in that area to allow direct flow in patients with superior vena cava syndrome for long-term access. These catheters are, however, not without complications, as thrombosis of this long circuit is a real possibility, and the cardiac effects of hero grafts are still yet to be studied in detail, but there are challenges related with thrombus that form around the catheter and the increased flow that it causes increased preload to the heart. So this is an example of what a hero graft looks like, and here you can see the catheter portion of the hero graft highlighting with the angiogram through the graft in the right arm. So let's now move away from catheter and just touch briefly on autogenous access, looking at finding the right access for the right patient at the right time. Now, with regards to perioperative evaluation, we generally tend to look for specific things for patients, and here we look at the causes of the renal function, the comorbidities of the patients, what do they have hypercoagulable states, do they have drug interactions, look at the dominant limb, whether they had trauma before, previous catheters, previous access sites. So all this history is very important. When examining the patient, one needs to look at the pulses, check a Ellen's test, do blood pressures on both arms, assess the superficial veins clinically, but also use an ultrasound to assess the superficial veins and the arteries as well to help find the best option for the patient. It is important to check the patient's HP and potassium prior to surgery, and an ECG and chest X-ray to ensure that the patients are fit enough to undergo anesthesia. While these procedures can be performed under local or regional techniques, a lot of them are performed in conjunction with perm caths, and general anesthesia is then the most comfortable for patients. Duplex screening has shown to be very important, and Dr. Preeti Sharma will be speaking to you a little later on the uses of ultrasound and duplex Doppler in helping you manage AV fistula, helping us choose AV fistula carefully. Now, here we know that diameter of a vein greater than 2 millimeter has a 76% chance of successful maturation, as opposed to a catheter or as opposed to a vein less than 2 millimeters in diameter. So it is important to choose carefully to get the best possible outcomes for our patients. What we're trying to look is to aim is to get spiral flow on duplex ultrasound after our procedure in the vein, so that we can appropriately manage this patient with sequential needling for hemodialysis. Arterial diameter of less than 1.5 millimeter is a predictor of poor outcome, and venous diameter less than 2.5 millimeter is a predictor of poor outcomes. There are indications for venous imaging, and this would largely be to ensure that central vessels are patent. Performing these procedures in a hybrid theatre would require central venous imaging in patients that have ipsilateral limb swelling or previous catheters or signs of superior vena cava syndrome or previous trauma in the neck or chest area. So when we look at autogenous access, we generally try to go with the non-dominant arm first, looking at this anatomical snuff box or radiocephalic fistulas, then looking at forearm fistulas, upper arm fistulas, transpositions, and then moving over to grafts where we talk about forearm grafts, upper arm grafts, etc. Today, most patients can have upper limb vascular access without even looking towards the lower limb, which is fraught with many complications. These are examples of AV fistula performed on the left anatomical snuff box. That's radiocephalic fistulas, where we join the artery to the vein, performing anastomosis, and then allowing the fistula to mature over a period of about 6 weeks before we consider needling. This is an example of a basilic vein fistula performed and then transposed into the soft tissue to move the vein away from the artery and away from the superficial ulnar nerve, which crosses the basilic vein and hence causes pain if one needles the basilic vein in its normal position. AV fistulas in the upper arm can also result in complication, but have a highest chance of giving long-term vascular access with the least chance of infection or complications. When AV access, autogenous access is unavailable, one can consider PTFE grafts, and these can be performed in the forearm, upper arm, or loop fashions, sometimes in exotic ways from one side of the chest to others. These are examples of AV grafts that have been performed, showing the different directions, but they generally move from artery to a vein in a loop format or in a curved format in the upper. So one should look for warning signs of grafts to show that they are going to occlude, and a pulsatile graft with high venous pressures implies a central or outflow stenosis which requires angioplasty. I often tell my patients it's more important to ensure that these grafts are routinely examined to check for outflow stenosis, to address stenosis timeously with small procedures by maintaining the outflow stenosis with angioplasty, and instead of waiting for it to thrombose and resulting in a much larger operation to salvage the graft. Today one needs to look at AV access and hemodialysis access as a chess game. As the surgeon or dialysis tech or nephrologist, one needs to be able to guide our patients and make the next move, knowing what the next moves are going to be in order to be able to best predict the best plan for the right patient. Now here we look at different options where we look from a 14-year-old girl who may qualify for a living-related transplant or PD before looking at hemodialysis access first. So the dialysis access would be transplant option first, PD second, and then radiocephalic fistula on the left. So one would have to taper one's approach to the different type of people at the different stages of their life, depending on their age, the reason they got renal failure, what their options are in terms of modalities going forward, and the dialysis access options. For example, let's look at a patient under palliative care with a limited life expectancy would be best dialyzed using just a tunnel catheter and nothing else. If we talk about other patients, middle-aged, hypertensive, diabetic, who presented in extremis requiring urgent hemodialysis, would be best started with a tunnel catheter, then perform a brachiocephalic fistula, and then consider the patient for peritoneal dialysis if that fails. So having a plan like this for different types of patients, depending on what stage they are in their journey in life, would be excellent in order to taper the right approach for the right patient. Generally speaking, we say the Doki guidelines with a fistula first approach is a reasonable approach to avoid unnecessary long-term use of catheters and unnecessary early use of grafts. But a tailored approach for a patient is more important than just a straightforward fistula first approach for all. So, in summary, renal replacement therapy is a life-changing event. Vascular access is the patient's lifeline. Patient's autogenous access needs to be protected and used for as long as possible. Having the right access for the right patient at the right time is a very important approach, and I wish you all well. I thank you for listening to me, and hope you enjoy.
Thank you very much, ladies and gentlemen. We are going to go over to our next speaker, but before we go over, I just want to again remind the members of the Renal Care Society that we do have a meeting after the session. Please don't leave. The meeting will start at 17:15 here at Injabulo. The next speaker is also a recorded presentation, is Dr. Preeti Sharma. And Dr. Preeti Sharma is from the Care Hospital in Hyderabad in India. We're also going to look at two topics that is going to cover. The first one is the salvage of failing or a failed vascular access. And then the second one is the USG guided cannulation of vascular access for hemodialysis. The two videos will play one after another. Thank you very much.
Namaste. I'm Dr. Preeti Sharma, a vascular and endovascular surgeon from India. Warm greetings from India. I'll be talking about salvage of failing or failed vascular accesses. I have been awarded a gold medal in vascular surgery, and recently I have received some accreditation from National Board of India. I have penned down my experiences in a book which was released by Vascular Society of India. This is my entire team, without which I am incomplete. The first photo tells us about the vascular surgeons, intervention radiologists which work with us. The next is our very dedicated and efficient theatre staff. Next is our clinic staff. So why should a fistula or a graft occlude or clot? Basically, it is mostly related to some underlying stenosis. For the kidney patients, this vascular access is their lifeline. So if it is getting blocked or if it has blocked, it is kind of semi-emergency. And when we are clearing these blocks, it is like we are glorified plumbers. If the flow is slow, then the chances of the access to stop working are high. If there is florid infection or patient's BP is persistently low, or patient has some hypercoagulable states, then yes, that access will stop working. At times, we have also seen accesses stop working because of overzealous compression. Now we work as a team, and the most important person who is spending more time than me or nephrologist with the patient is the dialysis technicians, nurses, staff. So it is very important that I communicate with them, tell them what are the red flag signs so that the patient is sent to me earlier, and the chances of saving or salvaging that access are much better. So if an access is having too high or too low flow, there is no thrill or a no bounding pulse, it is difficult to put a needle to start dialysis, or it becomes difficult to stop a bleeding after dialysis. Recurrent clot formations, edema in the arm, poor clearance on dialysis, pain in the hand, or abnormal changes in the fistulas. So we have a combined clinic. In our clinic, we scan all the patients, take a decision whether we have to do only a percutaneous salvage or an open salvage, discuss it with the patient, then depending upon the cath lab, schedule the procedures. So when I scan the patient, I see how old the fistula is, whether it's matured or immature, how long it has been since it has not been used for dialysis or it is giving trouble in dialysis. What is this diameter of the vein, extent of the thrombus, whether it has blocked recently or there is a chronic thrombus which is also there. Is there any obvious lesion which is the culprit, or that stenotic area is that lesion which has to be tackled? And then depending upon that, we can assess and decide, yes, I can make an attempt to save the fistula, or I think I should not put in extra effort and patient's money to try to save this fistula. So this is how a mature fistula looks. You can see that it's a big distended vein and it is very much superficial to the skin surface. Now this is how an immature fistula, the size of the vein is small and it is at a depth from the surface. This also shows that, this picture shows that there is a significant stenosis, and that is why you can see that aliasing pattern of color in that picture. Now this is a picture which shows that the fistula has occluded completely, complete thrombus, or it is partial thrombus. At times we can also say that there is a chronic thrombus which is there, on which there is an acute element, and that is why the fistula has stopped working. At times we see immature fistula because there are many draining accessory veins. So once a patient comes with a failing or a failed fistula, I make a working plan at how I'm going to manage this patient. So either it is a inflow problem or an outflow problem. So I start scanning from the artery, anastomosis, vein, central veins, complete circuit. This is a 2 months old fistula in the forearm. You can see that the vein is very small and there is a significant juxta-anastomotic stenosis, which is not allowing the fistula to mature. So I cannulate using the forearm vein, put in the wire, do a fistulogram, do a fistuloplasty. You can see that there is a wasting in the balloon which is there. And then the end results shows that the vein is uniformly open. Here you can see that there is no residual stenosis. One of the challenges which we face is sometimes these forearm veins have some valves. So what we do is we negotiate it by entering through the artery to the same procedure and do a balloon angioplasty. So this picture also shows very nice wasting which is there at the end of the stenosis, and with sustained balloon inflation, that vein has completely opened up. Now when we come to a completely thrombosed fistula, we prefer to do it on the same day, provided other conditions are suitable for us, because we want to avoid any temporary dialysis catheters in the neck or in the groin. The longer we wait, the longer this thrombus is going to cause an inflammatory reaction. The clot is going to get stuck to the wall, and then it will be difficult for us to remove this clot. But there are some practical challenges. At times the patient is not been dialyzed enough, patient is not fasting for or fit for anesthesia, or is not financially prepared. So if everything, all the boxes are ticked, we prefer to do it on the same day. Irrespective of that, we start them on anticoagulation and then decide what is whether we want to do a percutaneous salvage or an open hybrid salvage. We make sure that if we are using thrombolysis, patient doesn't have a recent intracranial hemorrhage or access infection, pulmonary hypertension, which are obvious contraindications to do any thrombolysis. We prefer doing pulse spray aided pharmacomechanical thrombolysis. At times we have done thromboaspiration. We initially percutaneously puncture the axis, put in some thrombolytic agent locally. First is a bolus, then a top-up. Frequently scan it on the ultrasound. Wait for a couple of hours, then go with a fistulogram that will show us how the thrombus at some places has dissolved, cannulate it, do a balloon angioplasty, and completion venogram. We have encountered some embolization which has gone through the anastomosis in the artery. So we prefer not to flush the sheets, minimum manipulations, focus on clearing the outflow before paying attention to the inflow. Make sure that the balloon is completely deflated before it is being removed, and minimize the contrast injections in clotted areas. So the options either we do a balloon embolectomy, thromboaspiration, lysis, or a hybrid surgical embolectomy. At times we have done hybrid thrombectomy, removed the clots, you can see the bunch of the clots, and then put in a balloon, inflate those areas of stenosis. These are some straightforward, simple cases in which we were able to successfully cannulate the veins, do balloon angioplasty. At times, we have encountered venous webs on a fistulogram, especially in the cephalic arch, and then balloon angioplasty them. We have seen patients with SVC occlusion, in which you can see those veins are occluded. It's more common in patients in whom both the jugulars have been accessed. So the take-home message is education of the patient, education of the dialysis technicians, nurses, everybody who is in contact with the patient, so that everybody is aware that, okay, this fistula is going to fail or is going to get thrombosed or has thrombosed, so that once we pick up those red flag signs, patient is sent to us early and we are able to save that fistula as soon as possible. Because honestly, these are financially draining. A lot of burden comes in terms of the procedures being very costly for the patient. Also, there are other challenges that the necklines have to be, or temporary dialysis has to be done. So we would try our best to prevent loss of that access site. And nothing is complete without the team. So we have to have a very strong working relationship among everybody who is taking care of that fistula. Thank you. Namaste. I am Dr. Preeti Sharma, vascular endovascular surgeon from India. Today I will be talking upon how to use ultrasound to cannulate vascular access. So what does the existing KDOQI guidelines tell? They usually tell is it is recommended to use ultrasound to determine the direction of flow and to do a proper placement in select patients, and to be performed by trained operators at bedside. So that will be related in increased confidence of the nurses and increase the patient comfort. But there is a problem is most of the centers will not have ultrasound which is available easily at the bedside for these dialysis patients. At times, there might be lack of availability of trained technicians or trained doctors who can assist in this cannulation. So I always say that it is a double-edged sword. It can decrease the incidences of missed cannulations, give the technicians or the nurses increased confidence to cannulate difficult fistulas, but at the same time, it will increase the time of the procedure, and also at some centers, patients are being charged for this special cannulation. So what do you need if you decide to use ultrasound to cannulate a fistula? Is you need a good ultrasound machine with a duplay option so that you can clearly see the vein and the artery and determine the direction of the flow, and you need a linear probe. Now this picture I have specifically put because your eyes will see what your brain will know. That is why if you put a probe in a transverse direction with a vein which is sitting like this below, or you can put the probe in a longitudinal direction when your vein is sitting like this below. So everything will change upon how you're looking at the vein, whether you're looking at in a transverse direction or you're looking at it in the longitudinal direction. Now the first picture shows that I'm looking at this vein in a longitudinal direction. So I can see a good artery, the suture line where the artery is connected to the vein, and then the vein. Now in the second picture, I'm putting the probe in a transverse direction. So the first big hole is the vein, which is a dilated good vein, and below that is the artery. Once I decide, I scan where I have to puncture the vein for access. Then you can see that the needle, which is placed at the center of the probe and at an angle of 45-degree. The aim is to cannulate the anterior wall of the vein, because if you cannulate it from the side or if you go in too deep, then you will face all sorts of problems related to cannulation. Also, you can see that I am swaying my probe forward, backward, sideways to make sure that I am not puncturing the side wall of the vein. You have to understand that we are seeing it a 2D picture, but actually it is a 3D pulsatile picture in which you have to make sure you are cannulating the anterior wall of the vein. So here you can see that my needle has successfully gone inside the vein. Namaste. I am Dr. Namaste. I am Dr. Preeti Sharma, vascular endovascular surgeon from India. Today I will be talking upon how to use ultrasound to cannulate vascular access. So what does the existing KDOKI guidelines tell? They usually tell it is
Ladies and gentlemen, just
Namaste.
pardon us a little bit. We're just trying to fix the slide. There was a problem with one of the slides. Just a little bit of patience, please.
Can we just make use of this opportunity with regards to the AGM following this session? There will be a register that the members attending this meeting to just complete the register. There will be on the table outside, the registers will be there. And if you are staying inside the venue, we will then also circulate the register. That needs to be completed as soon as possible because we need to establish a quorum before we start the meeting. Thanking you in advance. If we can get an indication from the IT guys, if it's going to work, otherwise, unfortunately, this will be it. It's not working. Okay. So I think this will be the unfortunate prompt end to the video. This is what technology does to us, right? It's out of our hands. We really appreciate your attention and your patience and your interest. Of course, there will be no Q&A session due to the nature of this presentations. We really appreciate your time and enjoy the rest of the night if you are not attending the AGM. Otherwise, we would like to invite you back into the venue so that we can start our AGM on time. Thank you.
One more picture.
Did I make something wrong with you? I cannot recognize. Do you understand why I'm watching you? Not the same gleam in your eyes. I'm honest with you. So tell me why you lie. I'm honest with you. So tell me why you lie. I'm honest with you. So tell me why you lie. I'm honest with you. So tell me why you lie.
I was so used to you. I know you felt it too. And why does it feel so final? The sun has set on us, but I'll keep the light on and pray that you see it soon. I pray it shines on you and me too. And just 'cause I can't figure it out, don't mean it's so settled right now. Why can't I just drift along slowly? And it's not late, there's plenty of time. It's not too soon, no, I'm just fine. Why can't I just float along lonely? Just think of the embarrassment that would end me and make me wish we stuck it out and get me off my roommate's couch. And when did we get so heavy? I thought that love was lighthearted like a feather, but maybe it's the way of things, the way it never seems. Yeah, just 'cause I can't figure it out, don't mean it's so settled right now. Why can't I just drift along slowly? And it's not late, there's
just getting closer. Your touch is gold. Every day we feel younger. I won't let go. I won't let go. We both know we still got time. We still got time. We still got time. We still got time. We still got time.
Good afternoon, everyone. We will commence the meeting in 7 minutes at 5:15. If everyone could just complete the attendance register in the meantime, we will appreciate that. Thank you very much.
I just want to invite the people still sitting so comfortably. There are cookies outside, so go and grab one cookie and SOMA register as well.
I don't know what we're trying to do. We pretend not to see. What are we even holding on to? Complicated situation. Yeah, there's always something. See, I always
you love me too. Put your lips next to mine, dear. Won't you kiss me once, baby? Just a kiss goodnight, maybe. You and I will fall in love. Put your head on my shoulder. Hold me in your arms, baby. Squeeze me oh so tight. Show me that you love me too. People say that love's a game you just can't win. If there's a way, I'll find it someday, and then this fool will rush in. Put your hand on my shoulder, whisper in my ears, baby. Words I want to hear, baby. Tell me that you love me too. Put your lips next to mine. Won't you kiss me once, baby? Just a kiss goodnight, maybe. You and I will fall in
Good afternoon, ladies and gentlemen. I'm sure by now you should be understanding my motto, so I'm going to do it again. Good afternoon, ladies and gentlemen. Thank you very much. But I never said you should shout at me. I just said you must greet me. Can I please ask all the members that are sitting right at the back to come closer to the front, please? Members who are right there, from the two ladies, please come closer. All of you, there are enough seats here at the front. Ladies and gentlemen at the back, please. Can I also please request that each and every one of us that is inside here, please make sure that you have signed the attendance register. Ladies at the back, I would like to see you next to me here. All right. Whilst everybody is making their way to the front, I would like to welcome each and every one of you to the annual general meeting of the Renal Care Society of South Africa 2024. And I would like to take this opportunity to to ask that each and every one of us, please, as I have requested, make sure that you have signed the attendance register, and also all the deliberations that are going to be taking place here, we are all going to participate. As a matter of protocol, I would like to observe the presence of our President, Mr. Jonathan Murray, and his deputy, Mr. Vusim Kachwa, and the presence of the Board of Directors, Ms. Sonia van der Sand, and the other members of the Board of Directors. Also, I would like to observe the presence of the EXCO Committee 2024 that has actually worked tirelessly to make this meeting a possibility. Our agenda, we will actually have an opening and welcome, and we will have the attendance and apologies from the Secretary. I'm sure we will get those from the list. Then from there, we will have minutes of the previous agenda from the Secretary, matters arising from the previous minutes, President's report, Treasurer's report, resolutions, date and venue of AGM 2026, and then we will have a closing. Ladies and gentlemen, without much waste of time, I would like to call our President, Mr. Jonathan Murray, to come and do the opening remarks. Over to you, Mr. President.
Thank you, David. Thank you so much. So welcome, everybody, to the AGM. It's our first in-person AGM, I think, since 2018. The 2018 Congress, 2020, of course, COVID happened, and then 2022, we had a virtual AGM. So welcome to the first face-to-face AGM. It's good to see all of you, and also to see the new faces in our meeting. Welcome to each one of you. So, point 2 on the agenda, attendance and apologies. So I'm just waiting on our secretary to confirm the numbers. A quorum, according to our constitution, constitutes 1/10 of all paid-up members. And as at this morning, there were a total of 192 paid-up members, meaning we need 19 people as a quorum. And I'm happy to declare that I'm sure there's more than 19. We'll just confirm the numbers during the course of the meeting. Also, in line with the Constitution, the notice of the meeting was sent out for the first time on the 6th of September of 2024, more than 30 days as stipulated in the Constitution. So the meeting has been properly constituted. Is there anyone who would like to object to that? You're welcome to do that. We haven't received any apologies. Is there anyone in the meeting today that would like to have any apologies, like to submit any apologies? Please feel free to do that. Nobody. Okay, perfect. So we're going to move on. We're going to try and keep the meeting as short as possible, because I know for a fact some of you has got plans to paint the town red tonight. So yeah, we'll try and do this as swiftly as we can. So we will go through the minutes of the 2022 meeting. It is a little bit small. The minutes were circulated on the 6th of September as well. So I trust all members have had a chance to have a look at that. So I will just very briefly go through it for the sake of time. So the President, Dr. David Maputi, welcomes everyone. Sorry, it's a bit even small for my eyes. My eyes are not so great anymore. And then, yeah, if we could scroll down to point 2, the approval of the agenda and previous minutes, that was done. There were a few pointers with Adrian Jordan and Mark Padavatan. The amendments to the Constitution was formulated and accepted. And then Prof. Haile Eis, you'll see, suggested some amendments to the Constitution. David presented the activity report. Sorry for that. The financial report was presented by the secretary at that point, Artie. And then the new EXCO was announced. Remember, we had elections at that AGM. So, anyone who attended the AGM, I'd like to request someone to propose the acceptance of it. Thank you, Stefani. Could I have a seconder? Thank you, Rina. Thank you so much. So the matters arising from the minutes, there are just one or two. First of all, as we said, we had the elections. So Caroline van Naasveld, you will see, was elected as an EXCO member at that meeting. She has subsequently resigned due to personal reasons in June of 2023. So she is no longer on the EXCO. And then the changes that was recommended by Prof. Haile Eis, where the general meetings can take place electronically as well as the voting as well. That part has been added as well to the Constitution. Are there any other matters any members would like to raise from the 2022 minutes? Please feel free to raise them now. If there's nothing. Next, we will go on to the President's report. So here we have our fantastic EXCO, our very hard-working EXCO, and I want to use this opportunity to thank each member of this EXCO for their hard work. So this committee is halfway through our term. Keep in mind that the term for EXCO members are 4 years. Hence, there won't be elections at this AGM. The next elections for EXCO members will take place at the 2026 AGM. So, once again, thank you to all of these good-looking EXCO members. I really appreciate your hard work throughout the first 2 years of our term. So just a brief report for those of you who might not be familiar with the society. This is a very brief history. We were established on the 10th of May, 1975, with only 9 members at that stage. And through its various activities, the society has made valuable contributions to renal healthcare in South Africa. The mission of the society is to advance the professional development of members practicing in nephrology, transplantation, and related therapies, and to promote the highest standards of patient care. So, as mentioned earlier, we have a total of 192 members, of which 164 is paid up. This is as at this morning. And I just need to clarify something. So, on our major database, on a big database that spans over many years, there are over 1,000 names on the database. Keeping in mind, those are members who over the years have joined, but not necessarily renewed the membership, or for whatever reason they didn't renew. So, for example, what would happen is a member would attend a congress. Keep also in mind that in the past, we had a manual system of joining the society, where people had to complete forms and EFT money and all of that, and it would only happen at congresses. So the challenge we had with that is somebody would, for example, register at a congress, pay the fees there, and then maybe not attend congresses again after that, or maybe only years later. So their names would be on the database, although they are unpaid. They are members, but they are unpaid members. Hence, we ended up with a major database of over 1,000 names. So what's happened in 2024, some of you, most of you might be aware, we actually put in place an online system where we renewed our website, new membership portal, and all of that we introduced in April of 2024. So the numbers reflected there are the members who have joined online since April, right? So these are the other numbers we are working with, and we would like to encourage everybody, even if you joined 20 years ago, if you haven't joined the online portal yet, to please do that. As I say, we're trying to make everything to move electronics and to move completely away from the manual way of doing things, because that caused a lot of administrative challenges. So everyone, if you haven't joined the online portal yet, it's very simple. You can also pay online. And yes, we have had some teething problems, which we try to sort out as we go along. Sometimes some members have problems paying, whatever, but just send the secretary an email and we'll sort it out as soon as we can. So yeah, we want to encourage everyone to join the online portal, right? The executive committee, just to mention again, the term is 4 years and we are halfway through. I mentioned Caroline van Jaarsveld, who resigned. And subsequent to the 2022 AGM, we also co-opted one or two for operational reasons, keeping in mind the Constitution allows for that. So, for example, we needed assistance in Durban. So we co-opted we co-opted a former member of the society, Mark Badavatan, to assist us with operations and events that we do host in KZN. The documents, so you will see if you have joined the online portal, if you go into your membership section, you'll find under the Documents tab some very important documents for you to familiarize yourself with. It includes all the information, applications, nomination forms, and we put that behind, within the membership portal, so it can be only accessible to our members. Please have a look at that part of the membership portal, right? We've introduced a newsletter a few months ago. So it's an electronic newsletter. So we send it out to all the people on our big database, 1,000 members. So the request is, if you haven't received it, to please, maybe you haven't updated your email address or whatever the case may be, please update it with the secretary so that you can receive the newsletter, because there's lots of information in there about everything, events, any updates. We're also trying to highlight achievements of members. We're trying to support members. So all of those information goes into our newsletter. So please update your contact details, your email address, so you can receive those newsletters. Our social media as well. Please interact with our social media platforms, especially Facebook and Instagram. Keep in mind, though, our Facebook is a bit of a challenge because there are two Renal Care Society South Africa profiles. Well, there's one, and then the other one that is active is the RCSSA page. That is the page we need to interact with, right? Unfortunately, we couldn't get to remove the old page, the Renal Care Society South Africa page. We are still trying to work out what's happening there. But when you interact on Facebook, please use the RCSSA Facebook page. And then, the contact details, just to confirm, secretary@renalcaresoc.org. So just to mention some highlights, and this is all happened in the last 2 years, right? So the Society has been involved in submissions to the Department of Health regarding the dialysis regulations, etc. We've also increased our African footprint through engagement and building partnerships with other African countries, such as especially Mauritius And also we've started with Botswana, and there's been inquiries from Malawi and a few other countries as well. Then the implementation of bursaries and grants. That has been a little bit on the back burner, but we are looking at implementing that from 2025, all right? We had a new website. Please visit the website. We had various kidney awareness events. You'll see some pictures later on of our events. One major event last year in Joburg. We had in Cape Town. We had one in Durban as well last year. We had also implemented a career awareness program that's headed by one of our EXCO members, where we go to the universities and educate the students at a very early age about clinical technology or whatever the case may be. So that is something exciting. And also we started with webinars, CPD accredited webinars. We had our first one a few months ago. The goal is to have a webinar at least once a quarter, right? So please attend the webinars. They're very interesting, and I think it's another exciting development. And then we played a big role. Some of you might have seen the International Society of Peritoneal Dialysis Congress slide on the between sessions. So the RCSSA played a major role in bringing that Congress to Cape Town in 2026. It will be the first time the Congress comes to Cape Town. So please, if you can attend the Congress, please do that. And then we've worked hard on collaborating with various organizations. And this for us also is very exciting. So the Vascular Access Society of South Africa, you saw earlier presentations on vascular access. Dr. Pradeep Mistry is the president. And that is a very exciting collaboration, because in the past, none of those collaborations took place. And the first one happened in 2023 in Cape Town. And keep in mind that usually they used to attract something like 50 attendees. Since our involvement, the numbers have jumped to over 150. So VASA is also very excited to have our society on board. And the next Congress will be in 2025 as well. We still need to confirm the dates. But please, if you are able to attend, I promise you, if you want to take your vascular access knowledge to the next level, that is the Congress to attend. And then we also have a close association with the South African Transplant Sports Association. They recently had the National Transplant Games down in Cape Town, which we always support that. And then also other collaborations with TEL, as you saw the table outside, and numerous others. So we are trying to build. We are looking also, we had discussions earlier today, for example, with Egypt. Someone from Egypt. That's also another exciting new development, possibly in the pipeline. So we are building slowly but surely. Then, of course, we acquired a lot of equipment, including, you might have seen our very cute mascot. I hope you've taken a photo with our mascot. And then also, we've had Christmas gift handovers, etc. So here are some pictures of our activities. Obviously, for the sake of time, we can't show all, but there are some pictures. This is the Joburg World Kidney Day event 2023. There we have Christmas gift handovers at Red Cross, which is very moving experience. So the year ahead, as I mentioned earlier, we've got the VASA Congress next year, which as we'd like our members to attend and support as well. We have kidney awareness events lined up. We've got more webinars. We've got the launch of the grants and bursary scheme. And then a big event for 2025 will be our 50th anniversary celebration. So you'll see we're trying to promote the event everywhere. You'll see on our T-shirts, it's all over. On the cookies that you got, it's on there. It's on the bags, so we're trying to promote it. So we are in the early stages of planning for that event. Please watch the newsletter, watch the socials, watch the website for the information on the events that are planned for that. Right? I'd like to just play a little video. Is this sound? Sorry, let me just go back. So you'll see on the video, there are some very young-looking people. Think of our Prof. David. I think he still has hair on some of these pictures, but you'll see that there are some very old pictures and then mixed up with the new ones. So do we have sound on there? Sorry, let me just, okay, there we go. So, oops. There we go. Here we go. So you can see the society has been busy over the last 2 years. There's obviously a lot of work still to do as well. We aim to build on what has been done before. But also, we can't do it on our own. We need the assistance of our members. So I'd like to request that if we do host events and there's a call for assistance, that the members avail themselves to assist, because we cannot do it all on our own. We can do much more if we have the support and the assistance of you guys. So please keep that in mind. In closing my report, I just want to mention this quote: "Community is much more than belonging to something. It's about doing something together that makes belonging matter." And what I mean by this is that it's just what you spoke about now. If you work together, remember, this is our society. It is not my society, it's not the society of the EXCO. It is our society. Let's work on building it, and let's work on making it great and doing great things, because the opportunity is there. The society offers that opportunity to do things and to be involved. So thank you so much for your attention. I'm going to hand over to the Treasurer, Rina, to deliver her report. Thank you, Rina.
Good afternoon to everyone. You can stop waving. Can we have the income statement viewed? Okay. We started the year with a sense of financial stability as we had a considerable amount in our savings accounts. To be exact, we had a total of 25,464 Rand. And we transferred a large sum to our fixed deposit account, which was 679,971 Rand and 83 cents. This gave us the confidence to start planning for the year ahead and take on new opportunities. As the year progressed, our expenses included various important items like congresses, fees, website updates, event materials, symposiums, webinars. Despite all these expenses, we were able to end the year with a healthy savings of 48,721 Rand and 55 cents in the savings account, an amount of 83,221 Rand and 83 cents in our fixed deposit account. This laid a strong foundation for us to continue our financial stability in the coming year. Please note, this Congress, we had to deposit an amount of 236,460 into this Congress. So we had to pay a deposit towards this Congress with SANS, and we should receive the deposit back after this Congress has been concluded. In closing, now my dear device. As the President mentioned, we are trying to increase the renal care society footprint in South Africa, leading by our slogan, "We care, we treat, we teach." Thank you for supporting us in this Congress and making it a success. So without you, we wouldn't be here, and we're trying our best to improve ourselves in the society. So please always try to support us. If you all have any suggestions, you're more than welcome to email us, and we will always try to assist wherever we can.
Thank you so much, Rena. Is there any questions to the Treasurer on the Treasurer's report? Any questions from the members? I know the text is a bit small, but I hope most of you can see it. Are there any questions? Yes, we have a question from that gentleman. Okay.
You didn't want me to ask.
Okay.
I don't know how. Oh, yes, it's okay. What I wanted to know, first is a suggestion. Maybe when we get to AGM, the financial statement, maybe if you can have a little bit of a print and then we look together so that we can scrutinize the finances, because finances are very crucial, number one. Number two, I just wanted to know, is this report audited or is just a draft, something like that?
Okay, so we do have an accountant, so everything is run through the books and it's submitted to him directly. I like your suggestion, so I do agree. Maybe what we need to do in the next AGM, we need to submit the income statement with so that you're all aware and it's transparent to everybody. Do you have any problems with that?
Okay, thank you. Any other questions to myself or to the Treasurer?
Yes, David. To me.
Yes, David?
Yes, David is quite correct. Because of the meetings and we have to submit to the accountant, sometimes it takes a bit of time to get the report back on time. But what we can do is maybe in the next AGM, try to send it out as soon as we receive feedback from the accountant, so that you're all aware of everything. All right?
Thank you, Rena. Can we have someone to move the acceptance of the Treasurer's report? Thank you, Sonia. Someone to second? Can I have a seconder? Thank you, Maritza. Thank you, everybody. So moving on with the agenda. So if you can recall, there was a call for resolutions to our members, also submitted on the 6th of September. We didn't receive any resolutions from members. However, there are resolutions proposed by the Executive Committee. So we will go through them one by one, and we're going to ask the members to vote as we go along. So the first resolution is for an annual membership fee increase. The Executive Committee proposes that the annual membership fees be increased from 150 Rand to 160 Rand. And the rationale is that there are increased operational costs of the society. This is the proposal from the EXCO, a 10 Rand increase in membership fees. Are there any counter proposals to this? Sure.
To get to that increase, have you got a budget? So it only requires a 10 Rand increase for the year.
Look, to be honest with you, we're trying to keep the increases as low as possible to make it as affordable as possible to our members. Keeping in mind that the membership fees is only a part of our income. The Congress is actually a major part of income for us. So it allows us to, keep the increases low to our members. Obviously, we're trying to make it very affordable, and I'd like to believe that we achieve that with only a 10 Rand increase. I hope it answers your question.
Yes, as long as it meets the budget and you have sufficient money because you have various income.
Correct.
So that's fine.
Absolutely.
Thank you.
Thank you for that question. If there are no counter proposals, could we have one of the EXCO members then to propose acceptance of this resolution?
Hi, sorry. Just wanted to find out if you're also looking at other streams of revenue for the society that would assist with.
Yes, we are. So we are looking at getting sponsorships from various companies as well. Before we could do that, though, we had to be registered as an NPO. And that was finalized just very, very recently. Hence, you won't see our NPO numbers on the documents yet. So the fact that we've got NPO status now will allow us to apply and hopefully get funding, which will be a major source of income, hopefully, for the society. Thank you for the question. Yes, Pumlani.
Thank you. Greetings, everyone. Okay, well, with regards to the annual membership, right? It's a once off the repay, like, as it says, annual per year, right? Okay, well, looking into perhaps, you know, as an EXCO, you know, in terms of everything, you know, planning, the admin and everything, and also other events that might be involved. Also, as President, you have mentioned that you're still looking into applying for other more of the funding and stuff, but maybe as of current, maybe should there be any events whilst we haven't yet applied for that? Maybe it's just like a suggestion, maybe to us that maybe can't we maybe, because it's once of a year, right? Maybe to make it, maybe to say maybe for the next, maybe until the next Congress 2026, or maybe until the next, maybe 2028, maybe to make it at least to be like even maybe to say maybe an increase of 50 to be 200 rand plain, because it's a once of a year. Because what I'm saying there is that I believe like in order to move to do anything, right, it requires finances, the planning, and you know, so I'm just like suggesting that for 200 rand maybe in a year, I think maybe we can try to sacrifice for something for the society that we really want to see it going forward, you know, and grow things so much.
Yeah. Thank you very much for that input, Pumlani. Yeah, look, as I said, the society is looking at other forms of income. So, as I mentioned earlier, in the past, we had the manual system where members would pay 1 year and then they not pay for X number of years, right? So, with the online system, you will actually get a reminder that your membership's ending within 30 days. You'll get a 30-day reminder, right? So, I'm trusting that that will allow for us to get a consistent income in terms of membership fees, which didn't happen in the past, right? And I think in a way that also allows us to keep the increase lower, because we are hoping that members, when they get their reminders, the email reminders, that they will actually renew membership and pay again. That is the request.
Can I please ask members to introduce themselves, please? Sorry for the previous ones.
Good day, I'm Daniel. I just renewed my membership right now as we talk. It was easy actually to renew
Yes,
it.
I actually got the SMS of your payment. Give it manner.
Thank you. Yeah, I was saying it was much easier to pay because the amount was affordable. So I think the more affordable it is, it's better to pay. And then maybe in the next meeting it can be readjusted based on the inflation, but just keep it low. Thanks.
Yeah, thank you, Daniel. So the 10 Rand increase is a 6.66% increase, below inflation. But yeah, thank you. So can we have one of the ESCO members propose acceptance? If there's no more questions, that is. Do we have a question? Okay. Thank you, Anson. I propose, can we have a seconder? Thank you, Sonia. Do we have another question? Okay.
I think she's seconding, so it will be better to introduce herself.
No, I'm seconding, thank you.
Okay, thank you.
Who are you?
Patricia.
Thank you. Thanks, Patricia. Okay, so our second resolution is made up of a few different points, but it's grouped together because it refers to changes to the Constitution, right? So 2.1, the Executive Committee proposes the following amendment of Article 6, Section E, regarding membership fees of the Constitution. So it reads, a membership fee to be agreed upon at the general meeting will be proposed by the committee and shall be due on an annual basis. And then currently it reads, and become payable 30 days after the end of the financial year, which is June. No pro rata amount will be calculated for persons joining during the year. So what the EXO is proposing is removal of that section as lined through. And the rationale is simply because the new online membership portal, as I mentioned earlier, allows for annual membership of the society to run for 12 months from the date of payment of annual membership fees. It just eliminates that. So your membership will run from the day you pay for 12 months. Not like in the past, where you would be required to pay 30 days, at least 30 days after the end of the financial year. So, could we have comments on that? Do you have any counter proposals, any comments? Please feel free to raise them. Any objections? Okay, if there's none, could we have someone to propose the acceptance? Thank you, Stefani. And a seconder? Razipo. Perfect, thank you so much. And then resolution 2.2, the Executive Committee proposes the following amendment of Bylaw 1, Grants and Bursaries and Awards of the Constitution. So it's basically the addition of the following bursary guidelines and criteria. So you will see all the guidelines and criteria over there. And this is the reason also why we were a bit cautious to implement the bursary and grant scheme until it's been accepted by this meeting. So obviously subsequent to this meeting, it will be added to the Constitution. So these are the guidelines and criteria. You're welcome just to briefly have a look at them. And it's be open for comments. So once again, this was made available to members, I think the 16th of September on your membership portal. So are there any comments, suggestions, objections? Please feel free to raise them.
Yeah, good afternoon. I just wanted to ask, just in regards to, come again?
Name, please.
Oh, no, I'll say afterwards, yeah. Just in regards to the bursaries, what's the actual criteria to the 2 people you choose in a calendar year? Yeah, but is this for post-grad, undergrad? Is it specific? Because, I mean, there it says it's a paid-up ordinary member. And I don't know if you guys have a student chapter, for example. I'm just making an example. So if you guys can just elaborate further in regards to the criteria and how much the bursary is actually maxed at, please.
Okay, so the bursaries...
Moses, by the way.
Okay, thank you, Moses, for the question. So the bursaries are for undergraduates. And then you will see stipulated in there the amount of money allocated is dependent on the funds available in the bursary fund of the society. So the bursary fund is made up out of sponsors money, and then also where necessary the society itself will also add, right? But it depends on what funds are available in the bursary fund. So I hope it answers your question. Not really. What else do you want to know? Okay, look, it's difficult to say at this stage, but it does depend on the funds that are available. We'll obviously try and help as much as we possibly can. Yes, David?
I think it is answered said that it's for undergrad studies. So, like the president say, it depends on the amount of money that is available. Because of the fact that you'll find that at some stage, the fees at the institutions do increase annually, and we might not know what will be the financial status of the society at that given moment. But the bursaries are for undergrad.
Thanks. Just to support the question there. If you did a budget and you know you want to sponsor 3 undergrads for whatever renal courses you're doing, isn't that number available? Otherwise, we're making a statement and it may happen. So if we want to say we can do only 1, 2, or 3, then we know. Otherwise, your budget, you guys know that can't be accepted for that year if there's no funds. You know, in the same instance, like we were saying, the gentleman here, okay, said, make it 200 Rand, but I mean, obviously, maybe everybody can't afford that. I mean, there could be an incident where you need to send a child for emergency treatment and they come to you and say, do you have money? By taking that little bit extra in the pot, then maybe you would have that. So maybe going forward, and I don't know, we must start thinking, because that question is very valid. Because sitting in this room already, you should know the renal course is starting in 3 months, and then I need 50,000 Rand. Have you got the money? I think that's where you come.
Okay, if I may come in, the reason why I'm answering is because I'm part of the budget committee. The issues that we had is that I'm sure from the nursing perspective, they are aware that the Nursing Council had a moratorium on the training of nephrology nurses. So unfortunately, up to this point in time, no institution has been accredited to offer the course. As a result, we are actually hoping that by the end of this year or early next year, as the president said, we will be implementing this as from next year. The information on the amount that will be sponsored per individual, because as it says, it's two, so it will be one nephrologist and one technologist. So the amounts that will be paid will depend on where the applicant has applied to. And then also, again, on the availability of the course, because we actually felt that we should wait until we have all the moratoriums uplifted. Moses?
I don't want to create dialogue, but the nephrology nurse is a post-grad diploma. So that's why I'm saying, if you guys can just, expand your criteria. Undergrad, postgrad, I personally think, and I'm not a nurse, I'm just saying, we should add postgrads. In the long term, it's cheaper and it's more value add to your members here, in any case. I don't think anyone here wants to go back into an undergrad unless you want to.
I'm sure the president will look into
Thank you,
that.
thank you,
and
Moses. Thank you for
expo.
that input. I appreciate that. Sianda.
Thank you very much. I'm Sianda Ngema. I was going to share the same sentiment like Moses, that nursing is only offered at postgrad when it comes to nephrology as a specialization. But also, just as a suggestion or recommendation, I would suggest that then, because it's a starter, it would not be advisable that you go full force into sponsoring the entire course of the person who want to sponsor. Maybe we may have to say, let's say we're giving 20,000 to those two people, then we don't want to pay the whole thing. Because if you look at the course, it can cost about 100K for like a year for each person. Let's try and maybe make a succinct, specific amount to say we would give to these people, looking at the budget to say then there is no funds yet to really go robust into funding these students are going to be sponsored.
Yeah. Thank you, Sianda. That's a very, very valuable inputs. And do you have more comments?
Yes.
Okay, my name is Alfred. For me, actually, I wanted to support the assertion that has just been submitted now to say, at least we need to cap it. If otherwise, and so that the outreach can be expanded as well in terms of the people that we're covering on this. So that's my submission, sir. Thank you.
Thank you.
Okay, thank you. My name is Temba. Because I was looking at the criteria there, so I think let's put it like the first one. Like the member is like, you cannot just join today and then tomorrow you get a bursary. Maybe let's say if you're a member for paying, let's say for 2 years, and then you get the bursary, because it's going to be unfair. He applied today and then he deserves the bursary.
I totally agree with that. Totally agree.
It's agreed. I think so.
Any more inputs? Sianda.
Oh, I think maybe before we move forward, Moses, answering Moses would kind of give a bit of more insight with regards to that issue of clean tech and nurses and how do we sponsor people who are undergrad. Because also about clean tech as well, I think now it's only pitched at straight to being a NQF level 8, which is an honors degree. How do we work around that? Do we even have any people in this meeting or in this conference who are undergrads who would deserve a bursary if we was to give it tomorrow?
Okay, those inputs are all very, very valuable and very valid. Could we then ask the bursary, well, the EXCO and the bursary committee to go back and relook at the criteria and then come back to the members on that? Are all members in agreement with that? Thank you so much.
There's a hand here, Mr. President. Let me just.
Mr. President, can I also maybe request that members that still have got any additional comments to make on the bursary to please also just email the secretary in this meeting, so that when we are finalizing the document, then we've got everyone's input.
Absolutely. And I think in addition to that, we should perhaps put a deadline to that. We are now, we in October. Could we say by the end of November for the latest? The 1st of December. Okay, there's a suggestion, the 1st of December. To finalize. It leaves us with 1 week. Do you think a week is sufficient for the members to respond? Okay, we've got the end of October. Yeah. It might be a bit soon. I think give the members time. You know, some members need time to do things and all of that. Okay, let's make it, if you don't mind, the end of November for inputs. Yes, Serena?
Because we don't have all our members present. So we will send out communication post-Congress to everyone so that it gives everyone a platform to voice their opinion.
Correct.
So I think let's just be fair.
Correct. Thank you, Rena, for that input. And just a reminder to all members that this was sent out. I know some of you might have joined maybe very late or very recently, but this was sent out on the 16th of September to all members. So there was time for input, but I think in the interest of being fair and correct, we'll extend that time for input until the end of November. Everybody okay with that? So then obviously we cannot vote on this resolution at this meeting. Thank you for the valuable inputs. Resolution 2.3. The Executive Committee proposes the following amendment of Bylaw 1, Grants, Bursaries and Awards of the Constitution. Additions and amendments of the following guidelines and criteria to the Haley Ace Research Award. So we've expanded and worked on the guidelines and criteria. So for those of you who might not know, the Haley Ace Research Award is an award given to nephrology practitioners. They don't have to be members. To nephrology practitioners for outstanding research. This is an award that is open for nominations at any time. So if you feel there's someone in the field of nephrology who deserves this award, you are free to nominate. The nomination forms is on your membership portal as well. You complete it and you send it through to the secretary. So just keep in mind this award is open all the time for nominations. It's the Haley Ace Research Award. And just some feedback on Haley Ace, for those of you who might not know or are new members, she was one of the founder members of the society in 1975. She's still active in the renal field, and she's a sportswoman, especially active in the transplant sports arena. And we hope you'll get to meet her sometime. She's a legend in nephrology. So once again, you're welcome. Just have a quick look. If there are any inputs on this resolution, please feel free to raise them right now. Are there any inputs? If there are none, could we have a proposer for the acceptance of this resolution? Thank you, Sonia. Can we have a seconder? Anthony. Thank you so much. Moving on, the point 8 on the agenda, the date and venue of the AGM. So there hasn't been a finalization of the venue of the next Congress during which the AGM will take place. That discussion is taking place between the Renal Care Society and between the South African Nephrology Society. So we will communicate as soon as that decision has been made. We will communicate that to our members as soon as possible. So we cannot give you a venue and date at this time. The initial discussions are, but don't quote me, but the initial discussions are that we will hopefully we'll have it in Joburg, in Gauteng again. But that will be finalized and confirmed in due course. Any comments on that? Before we close our meeting, I'm going to just open the floor. If there are any final suggestions or comments, please feel free to use the opportunity now before we close. If members have any suggestions to make the society more effective or for whatever, please feel free to submit that to the secretary, and we will definitely have a look at that. We want us to be interactive. We want you to be a part of it, and we've got so much expertise in this room that I feel we can count on. And we're hoping that all of you will join us and hold hands and let's do great things. Let's do great things. So guys, I think we've done well for time. If there's no other inputs, thank you for your attendance. Okay, the professor has something to say.
Okay, I said I'm Temba again. President, I just wanted to get a clarity on if the member resign, what is the constitution said? We wait for the next AGM to close the gap, or what's happening? Because I understand there must be some duties there that was allocated for that member. That is number one. Number two, is it possible that maybe in future we have people who can represent maybe the province so that we can reach as much members as we can? Like if you go to Mpumalanga, you know there is Nkosinati that will try to put members to Bombo and so forth.
Thank you for that input. David, do you want to comment?
Sorry, guys, if I may just respond to the second part of the question is that during my reign as a president, I think we actually had provincial representatives, if I may call them that way, and they were actually members of the EXCO. And subsequently, we had the co-opted members from different provinces. The unfortunate part is that you get this person who is enthusiastic of doing something for the society now, and then immediately when they are away, you write to them, you do everything. It becomes so impossible to get hold of the person. And the unfortunate thing is that, much as I would like on behalf of the president say, we really appreciated this suggestion. I must actually reiterate that it becomes a problem for the EXCO to write emails, to write SMSs, even to call a person, and we don't get a response. For an example, I remember there was a person, sir, from the Limpopo province. In most of the time when we had meetings, the person could not come because of the fact they would actually say it's either it's too far or this or that or that. So members, I would urge you, if you really feel that you would like to be a provincial representative for the society, and you are keen on serving with the EXCO, there's a clause which actually allows the EXCO to co-opt members so as to develop also the succession plan for the society. I really would like to urge you on this one, because I have walked that road. I'm sure even Sonia, who is the former president, to me, they have also tried it, but in most cases you'll find that because we have got active provinces, like you'll find that it's Gauteng and KZN, and then subsequently we had Free State that was very active, but subsequently we had no one from Free State. Then we've got Ansune from the Free State now. And from Limpopo, we subsequently don't have anyone. Any other province, it was a problem. We are now only having active members again from the Western Cape. Eastern Cape, it's been a challenge. But I would like to urge you, we will ask Secretary to put it on the website so that people can actually volunteer to become the provincial representatives. Thank you. I just wanted to say something on that, but the one of the resignation, I'm sure he's referring to the EXCO members, and then President will answer that.
I just want to make a follow-up of your answer. I appreciate to give us the overview of what happened before. Going forward, I think now things are getting more easier because now we have about Teams, about Zoom and all these things. It cannot need someone to travel from Free State to come to Johannesburg for the meeting. We can have a meeting now in my phone. I can get to the car now and sit and get to the meeting. So I think we can look thoroughly on that since there is technology, let's use it.
Point taken, sir.
Okay. On the same line, what I'm suggesting is that at least we should have a clear constitution around this guiding how to constitute these provincial structures. Are very important structures. And then it can't just be from a word of mouth that you're clarifying us to say this is how you feel and so forth. We need to have at least guidelines that says, okay, let's establish provincial structures. I think Temba actually simplified it how I wanted to simplify it, to say we're living in the age of technology, and then distance, geographical distance should never be a factor. And then we should actually edge towards making even more satellites, including or being more inclusive in order to grow membership and encourage payments and so forth, because that's some of the areas of interest in terms of challenges we're facing. It's payments, growing membership. But if we don't do, we're not deliberate and intentional in establishing those provincial, regional structures and so forth, and then we will forever actually find ourselves all over the place. Thank you.
Those are very, very valuable inputs, and I assure you that the discussions will be had in the executive meetings ahead. We'll definitely take it on board. Thank you so much for your input, and we'll definitely work on that. Just to come to your question about what happens when an executive committee member resigns. Normally what happens is if they had any portfolios, it would be transferred to one of the other EXCO members. If necessary, if we don't have the expertise, we would consider, for example, co-opting someone who could assist in that regard. So that is basically how we do things. Yeah. So if there are no more questions, I will close the meeting, and thank you once again for your attendance. And just to mention, for the record, we have had a total of 55 attendees, which I think is wonderful. So thank you, everyone, for your attendance. Enjoy the evening and enjoy the rest of the Congress. Yeah, thank you so much. Thank you so much.